Somebody's taking the. Yes. Somebody's taking this. Oh, you have it.
Take this and use this.
Okay, you can use the same.
Yes, this is it. Plug it.
I would say.
Ăsta e Mac. Radu, vezi Mac-ul ăsta? Can you unlock it just to see if we have image? Vezi? Dă-l un pic pe ecran. This is your laptop.
Okay.
Just on.
Let me check.
It's not necessary to connect it to the
Good morning, dear colleagues, dear guests, dear friends. It is a great honor to welcome you to EndoExperts Bucharest. As head of clinic and director, and on behalf of our hospitality and university, I am delighted to open this important workshop and Endourological stone treatment. Thank you all for joining us today. Our international faculty, delegates, trainees and technical staff, and industry partners, your presence makes the meeting truly outstanding. We have assembled a remarkable program and a distinguished faculty, co-director Daniel Rădăvoi and Laurian Dragoș, speakers and moderators from Bucharest, Cambridge, London, Valencia and beyond, Dr. Lei, Dr. Alberto Budia, Professor Bogdan Javlete, Dr. Ștefan Rașcu, Dr. Ivan Popescu, and many others. We will combine theory with practice through focused lectures, live surgeries, interactive debates, and roundtable discussion. This format reflects our commitment to hands-on learning and to translating innovation directly into better patient care. Today's topics, from current laser platforms and intrarenal pressure dynamics to miniaturization in ureteroscopy, PCNL technique, and positioning suction technology, and the measurement and the management of stone burden are not simple academic. They shape how we reduce complication, increase stone-free rate, shorten recovery, and improve quality of life for our patients. The live flexible ureteroscopy and PCNL demonstration will give you the chance to observe decision-making in real time, and our debates and panels will challenge prevailing assumptions to advance together. I encourage everyone to engage actively, ask questions, challenge ideas respectfully, and share our own experiences. These conversations are where progress happens. For trainees and early career surgeons, this is an opportunity to learn from leaders in the field and to build professional networks that will support your growth. For experienced clinicians, it is a chance to reflect, adapt, and mentor to the next generation. A special word of thanks to the organizing team, Dr. Toma, Dr. Petrino, Dr. Constantin, the operating room staff, our volunteers, and our industry partners for their practical support to making this event possible. Finally, let us keep patient safety, evidence-based practice, and ethical innovation at the center of everything we do. I wish you a productive, inspiring, and collegial day of learning. Thank you very much. Dr. Constantin is here. He's the manager of our hospital. Some words, please.
Much, Professor. Distinguished guests, please be welcome here in our hospital. We are one of the largest urology clinic in Romania and I think also in Europe. And also we have great experience with lithiasis and of course other urological pathologies. I want to salute this event which is done under the patronage of Professor Ginga and the University of Medicine and Pharmacy. Again, very warm welcome for our guests from UK, from Spain. We are very honored to have you here. And also I want to thank all of the sponsors and also our colleagues who took care of organizing this event, and also the participants. I think this event will consist a great experience, a valuable experience for all of us. Thank you very much and good luck.
Good morning, dear friends and guests. My name is Daniel Rădăvoi. I'm a urologist in this hospital, and I welcome you here today. And I would like to send all my congrats to Laurian Dragoș for making possible this workshop meeting. For us is very important, and also I would like to congratulate our guests, our distinguished guests, because otherwise this meeting will not be a possibility. You take from your time, from your OR time in order to be here. And for us, it's a great, great pleasure to have you here. And we would like to thank you very much. Hopefully, you will enjoy your experience here. Hopefully, we will have an interesting meeting. And we would like to welcome you anytime and to have as much collaboration as possible in the future. Thank you.
Okay, so my name is Lorian Dragos. I'm a Romanian urologist. Unfortunately, I don't live or work in my country anymore, but I do this in the UK at the Cambridge University. Now, I have to return my thanks to you, Dan, because actually Dan was the heart and soul of this meeting. And I think you guys are quite lucky to have people like him, and especially people like Professor Ginga, who immediately saw the opportunity of building something new and offering you, because we don't do this for us. We do it for you, especially for the younger generation. We will try and offer you teaching, education, events, debates, roundtables at a very high European level. I'm very grateful to Leia and Alberto, my very good friends. They are huge personalities in endourology in Europe. And thank you very much, guys, for taking your time to be here. I will go back again to Professor Ginga because he's a true leader. He has an open mind, showing that trying to do things for other people, which is exactly what the leader does. Thank you very much, Professor. I really appreciate this. Daniel has an incredible energy. He has put a lot of effort, but he also has an incredible team. We did a very good first boot camp, EAU boot camp in Romania. Yesterday went perfect. Thank you very much, Christy. I can only say I'm really impressed by your energy, your enthusiasm, your willingness to do and to help. And I think we have a good future ahead. And I really encourage the new generation to try to express yourselves, try to get involved, don't stay and watch, get into things. You are the next, you'll be here in my place in 10 years, but if you don't get involved with things, if you're just a spectator, this is not going to happen. Also, collaborate with companies. If you turn the page, you see how many industry partners have actually collaborated to make this thing happen. That's the only way to push medicine forward, to push surgery forward, is by collaborating with companies, trying to innovate, trying to change everything that you do into better. But that comes with something else, and this is a point I'm going to try and make when I operate today, if it's successful. You need to think about what you're doing. It's good to learn from your mentors, but the first part of learning is taking something that has been pre-digested and use it in your practice. The next step is when you actually think, why? Why am I doing this movement? Why am I not doing this? Why do I use this guide wire? What's on this guide wire? How is it built? Why shouldn't I use a different one? So think. That makes you a surgeon. You can teach a porter to operate. Anyone can operate, I promise you, but that doesn't make them a surgeon. You don't operate with your hands. They say we have the brain at the tip of the fingers, but we actually operate with our brains and with what we think. And this is something that surgeons usually don't tend to say, oh, he's a gifted surgeon. A gifted surgeon is only a gifted surgeon. And I'll rest here. Thank you very much again for everyone. Thank you for being in the room. Thank you for your interest. I hope you will have some good life surgery, but you never know with life surgery. But I'm pretty sure we'll have a very good lectures, very good debates and roundtables. So make the most out of it. Thank you very much, guys. Thanks a lot for everyone involved. Thank you.
morning. Good morning. My name is Dr. Calino Pacino, and I will make a short presentation of our hospital. Just to keep it okay. Professor Dr. Theodor Burghele Hospital has a 75-year history. He specializes in urologic surgery and, of course, is affiliated to Carol Davlian University of Medicine and Pharmacy. Known today as Professor Dr. Burghele, was first named Saint Joseph in 1942. When it was established by a congregation of Catholic nuns. After the nationalization process in 1948, it was called, as we all know him, Panduri. The actual name was given in 1991, 14 years after Professor Burghele passed away. The first chief of the hospital was Monsignor Piaget, and after the nationalization process was Father Louis Barat. So you can see some pictures from the archives. Our clinic is known for some national premieres, like the first arteriography, the first nuclear medicine, ultrasound and magnetic resonance laboratory, the first important series of cardiovascular surgeries, and the first hemodialysis in the country in the southeast of Europe. You can see there Professor Burghele with all his team. This is actually a rare photo from the hospital archive. As I was saying, it's an academic hospital with 2 male patient urology stations, 1 female patient urology station, the first in the country and the single in the country. It comprises of 120 beds for urology, 9 operating rooms, 5 endourologic surgery, 4 laparoscopic and 1 open surgery. Of course, the histopathological department is very important, the cardiology department, internal medicine, oncology unit, urodynamics, and of course the ambulatory system. We have 2 main operating blocks with over 200 laparoscopic surgical interventions each year. We provide a wide majority of procedures like radical prostatectomy, reconstructive and plastic surgery of the urinary tract, urogynecological surgery for the femoral urinary contents, and of course microsurgery and laparoscopic treatment of varicocele. Some pictures from our OR. In the endourology department, we proudly say that we have a lot of lasers. 6 of them, we perform a wide variety of cases. So we have the holmium laser, the thulium, and the Jedi Masters. We are proud to say that we are accredited by the European Board of Urology as a USP host center in the field of stone management disease. Some statistics from 2025. For renal lithiasis, we have over 1,000 cases. For uterine lithiasis, 240. These are the procedures that we mainly done in 2025. We've started also the HOLEP procedure from January 2025. We're at the beginning of this, but keeping track that everything is moving forward. We have the Department of Radiology and Medical Imaging, and of course we perform MRI biopsy, fusion biopsy, transrectal. We are very proud of the Department of Internal Medicine, that we have a great collaboration with them. It consists of 10 medical doctors, 25 nurses. They also perform a wide variety of procedures like spirometry, abdominal ultrasound, vascular ultrasound. This is the team there. We have a new cardiology department that comprises 40 inpatient beds and includes a chronic intensive care unit with 6 beds. That the department is equipped with advanced diagnostic and monitoring system, including centralized electrocardiography, telemetry, Holter monitoring, and so on. We have the anatomy department, pathology department that we are very fond of, with a great collaboration in-house. Also, I would like to mention the urodynamics department, which is situated in an ambulatory care unit. We perform, of course, pressure flow studies, urethral pressure profilometry, and optional video urodynamics. Turning back to the academic role, it's a teaching hospital. This is an important message. So over 500 medical students trained yearly, 60 consultants and specialists in teaching positions, 15 residents instructor rotations, hands-on training has in endourology, laparoscopic, oncology, and reconstructive pathologies. You've seen the Medical Simulation Center. It's a very big center, over 2,000 square meters. It's integrated in residency for safe surgical skill acquisition. So the center has 23 simulators with 3 robotics, advanced robotic surgery, 2 lab mentor advanced laparoscopic surgery, and of course the endourology trainer. A little statistic, from 2024 to 2025, the center organized approximately 2,000 workshops and simulation-based activities attended by more than 30,000 trainees. Over 500 residents, physicians participated in minimally invasive surgery training programs. We have some key research projects that were conducted in our hospital, like the ProMark, molecular biomarker in prostate cancer, like the ROMCAN, the Romanian Cancer Genomics Initiative, also the kidney cancer and occupational risk factors in Central and Eastern Europe. Now we have some lead projects with kidney stone composition and congenital malformation, AI-assisted prostate cancer diagnosis, and spectroscopy in stone recurrence prevention. Also a key project for us, and a very important slide, in my opinion. I think in 3 weeks' time, we'll have the Da Vinci robotic surgery system. And of course, we have a foundation for National Center of Excellence in Robotic Urology. To conclude, I say that Professor Dr. Burghele is the father of modern urology in Romania, and his legacy lives on the clinical and academic excellence of this hospital that carries his name. Thank you very much for your attention. So now we have a little time, I think, before switching to, or you want to, let's go straight ahead. Okay. Okay. Dr. Lee from London.
Right. Good morning to you all. Thank you very much. My name is Lea Ajayi. I'm a urologist at a teaching hospital in central London. On behalf of the EAU section of Endourology, thank you for inviting us here to talk to you today. I like to make my presentations interactive, so please, if at any stage you have any questions, please raise your hand and let's have a conversation. Don't wait to the end. It's more, I appreciate we have timekeeping issues, but we do our best to accommodate this. So thank you so much for your time today, and thank you for the organizing this and the invitation from everybody. So my first task today is to talk to you about the current laser platforms in endourology, from stone to dust. One can't have a laser conversation without paying due and homage to Einstein, who the father of laser technology. And you'll all recall that really that laser is not in continuous waves. It comes in packets of energy. Without going into much detail, what we've found is a lot of our med tech companies have been smart and very ingenious in the way they change the laser properties to what comes out of a laser machine to allow things like pulse modulation. So we'll talk a little bit about that. Today, really, it's the battle of laser technology. What is it we're talking about when we're talking about lasers? What is it? What is ambition? You might all remember Freddy. I don't know whether you all remember the Freddy laser technology. Some of you might nod your head. It shows your age. If you're nodding your head about, you know about the Freddy laser. TFL, thulium fiber laser, which is the new kid on the block, versus the older continuous wave laser, thulium YAG laser, and obviously the more modern contemporary pulsed thulium YAG laser. And the old tried and tested holmium YAG, which we'll talk a bit about today. Now, how many people in this room know what the Freddy laser is? You're showing your age. Anyone else? Yes, it was a very old laser technology, really. It was a frequently double pulsed neodymium YAG laser. Initial studies suggested quite good stone-free rates in initial published data. And then they did a small data comparing the Freddy laser to holmium YAG, and slightly inferior in its clearance of stones compared to holmium YAG. Cost analysis was identical. However, there was reduced efficiency in breaking ureteric stones. And really, unfortunately for it, it died to death because it didn't really coagulate very well either. So Freddy lasers gradually abandoned. So the younger generation, probably most of you in here, if you don't mind, probably didn't have any experience with the Freddy laser. We don't use the Freddy laser anymore. So it's kind of died to death. Continuous wave thulium was another technology that looked very promising, emitting them wavelength at 2013, 3 to 4 times the absorption coefficient of holmium YAG, shallow, very shallow penetration, and also very good for soft tissue, very good for coagulation, for tumors, and perhaps for HOLEPs in certain hands, but not very useful for urethiasis. So again, this is thulium YAG. It's something we don't use. Fast forward into modern times, the pulsed thulium, slightly different, a modification of the thulium technology, releasing the energy in a pulsed manner, has a slightly higher peak power, up to 3,700 watts in terms of generation, can generate quite a reasonable frequency and it's reasonable energy. Because of its peak power, and I'll talk to you a bit about peak power in a short while, you are able to really fragment stone because you have the peak power. The application for kidney stones is a bit novel, and we're still finding a way with pulsed thulium, but there's some evidence around its efficacy and its use, and it's continued to be effective. Some of you might be aware of the types of thulium, pulsed thulium. This is the Thulio and also the Revilex Duo, which is a combination of continuous as well as pulsed laser. The data from it is quite encouraging because when you look at the power fragmentation, it's almost equivocal to holmium YAG, but definitely superior to thulium fiber laser. Dusting in the long pulse mode is slightly better than holmium YAG. Similar dusting properties of TFL, and really, because of its smoothness, there's significantly less retropulsion. So the pulsed thulium YAG is quite encouraging. Pulse modulation is something that we're all very familiar with. If you're an endourologist, pulse modulation is something we're now embracing because it's now, technology is such that it's modified what comes out of a laser machine. You're able to do that because we know that really if you can reduce the peak power of a laser, what comes out of a laser, you have a smoother effect in your laser tripsy. So holmium YAG is very powerful, TFL not so powerful, thulium YAG even worse. So thulium YAG we don't use for stones. Again, without going into too much technology, TFL is something we're all familiar with because you're using thulium-doped fiber within the machine. All holmium laser machines are very big because it's highly inefficient. If you look at the size of most holmium YAG machines, they're very, very large. The reason why they're large is the coolant system inside, just to keep it cool. It wastes so much energy. Whereas TFL is a significantly far more energy efficient laser. It's got its drawbacks, but when you look at the dynamics, the pulse of a thulium YAG, you can see why TFL is actually very useful. When you look at the pulse of it, the energy is kind of homogeneous. So very good for soft tissue because you have a very easy, whereas holmium is quite aggressive and then it dies down. Not as good, but for pulsed thulium, much better. In terms of the water absorption of this technology, TFL definitely is 4 times more absorbed in water. So as a result of it, again, it's wasted a lot. So it doesn't deliver the energy to the stone. So it's more of a contact laser because the absorption is, if you lose it, if you try and work away from the stone, it's absorbed in the surrounding water. So to deliver the energy of TFL, you have to be in contact with the stone because a lot of it is absorbed in the surrounding tissue. Right. You'll all be aware of the publication when TFL came out, especially with Sotiv, where Professor Traxler published this. I mentioned to you about the 4 times more water, the absorption coefficient in water. You can use smaller fibers, and the idea is if you use a smaller fiber, you can create finer dust. That is the theory. But I think also with holmium, depending on your setting, you can create equally finer dust. But TFL, this is one of the advantages. Because of the technology, you can have smaller fiber, and if you've got a stone in the lower pole that you can't reach with a 200 or 275 or 375 fiber, you can use a 150 fiber to get you into the lower pole. So it has this appeal when you can't get into the lower pole with a laser, conventional laser, 200 or 275 laser fiber. So smaller operating fiber, creating finer dust, lower energy per pulse, okay, which is quite interesting and novel, and also, oops, right. Let me just go back, lost there. Right, so you can also create have quite a high frequency, and this was a problem with TFL when it came out, because we was told you can work at very high frequency, and we'll talk about the downside to that. More importantly, we were all sold the technology saying you can go faster, you can be more efficient in your stone ablation, it can go 4 times faster. And we all got all excited about TFL, like every endourologist. But what we did forget, these were all in vitro studies. In the human beings, you can't go faster. There's so many other factors. You've got to look at your irrigation system, the temperature, the heat you're putting through, the pressure. There's so many factors that doesn't allow you to go as fast as it says in vitro, sorry. And really, what they did was did a lot of trials. So a lot of the trials of TFL was done in the laboratory. And I use this analogy. You put a Formula 1 car in a laboratory, in a track, it can go 5 times faster. It can go very quick. It's got downforce, it's got everything. But you put it on a road, it will blow up instantly. The minute you turn the engine on, you put it in traffic. So what we were taught about TFL, we had to really adjust. And a lot of the settings we use for TFL now is exactly the same as holmium YAG laser. So let's talk about peak power. Peak power really wasn't a problem, and we didn't talk about it until TFL came along. And we're like, so okay, oh my gosh, this stone doesn't break. Let's talk about peak power. You all heard of the Bruce Lee 1 punch, 1 centimeter punch. That's the issue, that's the conversation around peak power. We're talking about peak power, that's the punch. Whereas TFL, what did TFL give you? Not a lot of peak power. That's why in a very dry, very hard, very dense stone, you struggle with TFL. Again, this is an interesting slide by Olivier. I remember at TNT 2 years ago, we were all told, all those individuals who use TFL, and I hate to say it, I'm on that hit list as well. We were working at crazy frequency based on what we were told and what Olympus was telling us, this is how you work with TFL. And we had complications. We had side effects. We had problems. So we now dialed down TFL. TFL is still an excellent laser, but we've now learned how to use it, and we've dialed down how we use TFL. Another area I'd like to talk about today is the pulse width. When we talk about pulse modulation. In the old-fashioned lasers, the first generation lasers had a fixed pulse width between 150 to 350 microseconds, fixed. That's all you had. And we made it work, not great, but we did make it work. Then the next generation came in that had either long or short pulse within it. Again, we made it work. Now we're spoiled. We're spoiled as endourologists. We have all these tools at our disposal, but do we really know, are we optimizing? Are we getting the best out of these technology? The science is not there yet. We're still playing catch up, trying to find the most optimum way to use the pulse modulation and laser technology. Why do we care about pulse width? Why is it important? We know that if you can reduce the pulse width, you have reduced retropulsion, and you preserve your fiber to a degree. This is a slide from Olivier and his team looking at what's your strategy for dealing with a stone. When you take on an endourological case, you have a strategy in mind. Are you going to dust? Are you going to fragment? Or is the plan popcorning? So you make your mind up before you go in, and then when you touch the stone, you make a decision, really, what is it you're looking at? Another thing I want to talk to you about today is the whole issue of Moses effect and the difference in Moses effect and Moses technology. Moses effect was described in 1986. It's an endovascular ablation, doing an endovascular ablation, where it describes a laser bubble tip and a second pass through. That's Moses effect. Moses technology is actual pulse modulation, which benefits initially from a Moses effect. Okay? It allows a small initial pulse, and then it creates a second energy behind it, which allows the delivery to the stone. What's the advantage? The advantage really is transfers more energy to the stone, and less is lost in the surrounding tissue, and allows the laser to travel at a further distance. And in doing so, you now have the Moses non-contact 2.0. So you're not actually having to be directly on the stone. You can work at a slight distance from the stone. And this is the joy in the Moses technology. Again, talking about the difference between pulse modulation, short and long pulse. This is the same energy settings, okay, 1 joule. But by manipulating the peak power and the short pulse, you're able to, with the longer pulse, take your time, whereas with a short pulse, you see the stone moving around. This is the laser that I have. I always keep this in mind. I use the Quanta laser, and you know you can work at a distance from the stone. That way, I really enjoy it because I'm working at a distance, and you can judge that you're delivering maximum energy on the stone at that distance. Whereas if you're not at the right distance, your energy delivery is incorrect. So you want to be delivering your energy to the tip of that. So you work and you learn how to stay away from the stone. So Moses, almost like a Moses non-contact mechanism. The machine that I have a magneto laser, and this is talking about bubble dynamics of a laser. And if you're an endourologist, you utilize all of this. If you're a whole lap surgeon, a lot of the whole lap surgeons use the virtual basket setting. The vapor tunnel is my setting I use a lot for my stones. And obviously I have the magneto setting, and I'll talk to you a little bit about that in a moment. So again, on the topic of peak power, holmium, you're able to generate quite a significant peak power. And then you look at thulium YAG, not a lot of power for stones. And then the second generation TFL. And I'll just talk you through some of this slide here. And I think this slide encompasses where you're delivering the same energy, but over a longer pulse. That's the TFL. You're delivering the same energy on a holmium laser, but over a longer duration. So your pulse duration is longer, so it's a finer aspect. Again, looking at the energy settings, this is delivering one joule of energy. So you're looking at holmium, a short pulse, very powerful. If you want to fragment a stone, you will use holmium setting, short pulse. When you look at TFL, short pulse, it doesn't pack a punch. Even the short pulse is 500 maximum. That's short pulse with TFL. Now, if you look at the long pulse of holmium, you reduce the energy, but you're still delivering good enough energy to fragment most stones, which allows you to dust. The long pulse on TFL, for me, I don't think anybody uses the long pulse for TFL. I don't see the indication because it just does not have the peak power to do a lot. So you don't get anywhere with it. And then magneto, if some of you have seen those, has the ability to have the power of holmium and also the power of TFL. So in terms of pulse modulation, the peak power. So this series of slides, I'm going to show you the evolution. This is from Quanta. So I've just got, it just gives you a clear understanding. So holmium functions with that sort of level of peak power. Okay, very effective. TFL, less than that, 500 if you're lucky. Okay, so it's very good for low retropulsion. However, if you have a hard stone, you have a problem with TFL. You can't fragment or very effective, and you find that with TFL. Thulium YAG, which I've talked about, has 380 watts, quite effective. So that's a competitor. If you have a laser, if you're looking to buy a laser, you have one laser. The thulium YAG, the pulse thulium, is also a reasonable laser. However, if you're doing HOLEP in your center, you're going to struggle. You do not have the power. Thulio doesn't have the power. TFL, although people do enucleate with TFL, it doesn't have the power. What Quanta have done is using the power of the holmium and incorporated TFL technology into the holmium. So in doing so, you now have this laser called magneto, which has the power of the holmium, the dusting and reduced retropulsion of TFL. And that's what magneto laser, that's what I have in my institution. Although I have several other lasers, that's my go-to laser, the magneto laser. And what is the idea? The Holy Grail is to create fine dust, okay? And you have the ability to create fine dust and in theory, reduce the amount of stents you put in patients and reduce your stone-free rate or increase your stone-free rate. So in terms of, just to conclude, ladies and gentlemen, we are spoilt as endourologists. We are in a situation where we have all this technology at our disposal and we're still learning, looking at the literature, how to optimize, what's the best way to use this particular gifts we've been given by industry. I'll stop there. Thank you very much. Are they ready in theatre?
Yes,
they're ready. Let's go. Let's go. Yes, please. Should we pass you the microphone? Can we pass him the microphone? No, I've got the mic. Sorry, questions? Yes. Yes.
Hear me. Thank you for a nice presentation.
My pleasure.
As you stated in your presentation, you had the opportunity to discover all the lasers one by one as they developed.
Yeah.
Us, the new generations and our colleagues, we have to understand and know the majority of them all at the same time.
Yes.
Is there any learning platform or any like simulation software where young urologists can go and try and learn and see all the difference as we have seen them in your presentation?
No,
or does EAU have something in...
You ask an excellent question. Is there simulation available for all this latest technology? To my knowledge, no, because you'll have to bring a lot of industry partners together. If you're interested in learning the laser, there's EAU run a workshop, the EAU Masterclass in Barcelona, and I think that we have one in May. It's done every year. It used to be run in Petras with Professor Evangelos Liaktakis. I think this year it's moved to Barcelona. So in May we have a masterclass in laser technology where all these lasers will be discussed and the pros and cons of them. We are all still learning about pulse modulation. and new laser technology keeps coming out. So there isn't a stimulation environment, but if you're interested and you can attend, the EAU do run and the European School of Urology, we do offer this, and this is in Barcelona in May. It's probably full already, but it's going to be at least annual, if not biannual event. That's a good environment. But the simulation aspect is a bit difficult because trying to bring all the different industry partners together to give essentially their proprietary features of their laser to the public, I think we'll struggle to get that because they keep it all very guarded, unfortunately. Any other questions? So, are we ready to start in the OR? Okay.
Presentation of the case by
Yes, come through.
Good morning, everyone. My name is Ramos Cartas, and I will be really short, as I'm sure you are. As I'm sure you can't wait to see the live surgery. For the first case for today is doesn't work. Yeah. The first case for today is for flexible ureteroscopy, and it's a young female patient with an incidental finding of a middle calyx calculus. Here is the properties, and you can see here the CT scan. And here is the double J stent. So now we will switch to the OR.
So switching to Dr. Loriam.
Lauren, can you hear us?
Can you hear me here?
Yes, we can. Good morning to you. Thank you very much. We're joining you from the auditorium. Thank you very much.
Tell me what you can see.
We see a beautiful case about to unfold.
So what do you see? Do you see?
We have the endoscopic view. We also have the fluoro view, and we have a view of the OR.
Perfect. So you see, I've taken out the stent. What I did, I started with a guide wire alongside the stent. Then that's the first guide wire. Then I went back, took the stent out, and now I'm with a semi-rigid scope very close to the PUJ. You can see the scope on the fluoroscopy image down there. I'm not going to force more because the view is not very good. There was nothing up to here. You can see the stone that we saw on the CT scan. You can clearly see it on fluoroscopy. I'm just going to leave in my second wire. Can you see my hands and how the setting is here?
Can we ask questions?
Leia?
Yes. Can we ask questions?
Can you see my hands?
We can, but if they can switch the image around so we have you as the main image, if possible.
Not me, please.
No, we can see. Yes, we've got a good view. Excellent. And we've got a good view of the fluoro views.
I just wanted to, I'm going to leave the wire in now. Hold this as well. So I'm going to come out with the ureteroscope, with a semi-rigid. You see the ureter looks fine. Ureteric orifice is fine.
Can I ask you questions?
Sure, go ahead.
Do you always do a semi-rigid?
Always, as you know, Leia, is a big thing. It's a big word.
Yes,
but
indeed.
I would say I would routinely do a semi-rigid for a couple of reasons. It takes 2 minutes. It allows you to understand the ureter a bit better, calibrate it, understand what's going on. And in very rare cases, even with a stone that you've seen previously that is in the kidney, you may still have surprises.
Indeed.
But again, it's never say always and never say never.
Indeed.
Now, if you look on the table, can the camera look at the table?
Yes, we have a good visualization.
Okay. So you see I've got two wires. One is the safety wire, the other one is the working wire. If you look at the table here, they are at the same length, and that's a very good, so I prefer this setup as well. This is what I told my wonderful nurse today. This is our common ground. Both of us play on this table. This is completely hers. If I put my hand over there, she will just snap my hand, and there's nothing for me to do there. So that's her kingdom. This is ours. We share it. It's like in marriage, you know. What's mine, it's ours.
Yes.
What belongs to my wife, that's hers. So, two guide wires. I do close the space here, basically with my very big tummy, and this is why as an endourologist you have to grow a large tummy. So it's not because I eat a lot and I like food, it's just a professional request.
Yes.
So you close the gap here, it means that nothing drops out. And the nurse is usually, I know we've just met, but you can come closer. I'm joking. So the nurse is usually here, and then she controls everything. And all the wires are on the table, so it's just minimizing risks. This is one of the things I wanted you to remember, because I said think about what you do. Can I have just a wet gauze? Think about what you do, because I've been talking too much. Think about what you do and make a sense of every step. I've just wet one of the wires. I use fully hydrophilic wires. Can you wet this again, please?
Are they both, I was going to ask you a question, are they both hydrophilic?
They're both hydrophilic. This is not my regular practice.
Okay.
I use hybrid wires because I don't have such expert nurses. I'm really spoiled here. And if I use fully hydrophilic wires with my nurses, they are going to come out. And that's not what we want. So I'm using a Cleopatra 11, 13, 40 centimeters flexible AXA sheath. If you look at my hands, my nurse should keep it there, put it on the table. So if it's like this, she knows that there's no movement. So I can't say, oh, you've moved the wire. No, she hasn't. Put your hand here. Yeah. And the sheath should go smoothly in. I'm not doing it under fluoroscopy control unless I feel a bit of resistance. Now, okay. I feel a bit of resistance, so I need to see where exactly am I. I'm probably up there, close to being up. So, it doesn't go easily higher up, so what do we do? The first thing is either you leave it there and you put the scope and so on, or, this is one of the things I do, then you go without the safety guide wire. So I pull the sheath a bit down, I take the safety guide wire out, and I try again. I'm gonna, because this one, sorry, is not gonna stay with. And let's see. Yeah, I've advanced a bit longer, but basically I have the same issue. Now I would normally take everything out, but since there is a bit of an issue there, I'm going to leave the guide wire in, the sheath in, and advance the scope over the wire rather than advancing it by itself. This is not routinely what I routinely do. It's a bit unexpected to have this, but you saw that even with a semi-rigid, I didn't want to force through that area, which was tighter.
And how long ago was she stent? I can't remember on the...
Now, if you fix it like this, it's very simple, very clear, and you can just, you see, step aside, everything it's fine. Now, in terms of scopes, I'm lucky today, I'm going to use a scope that I love. It's a 6.3 French scope, a very thin one, huge med scope, but though it's thin, it still has, can I have the scope please? It still has a lot of capabilities, and I'm still happy and satisfied with the ability, the torque ability.
And the working channel, although it's a small scope?
The torque ability of the scope.
The working channel, is it still 3.6?
The working channel is, yes, almost still 3.6.
Almost.
We can leave this here, and I can even ask them, because it's within access to my nurse, and I can even ask her from time to time to start it, turn it on or off. You want me to take it? That's allowed me to ask her. Any questions so far?
Yeah, well, yes. I mean, we can always have this conversation, perhaps when you're in the kidney and you're comfortable, but you know, the miniaturization of ureteroscope has changed the way we work quite significantly. I don't know whether you have any comments. I was also going to ask you about your access sheath using a Cleopatra. Is that with fans or not? Is it navigatable? Can you hear me?
Did you ask me? I can't.
Yes, I was asking you the Cleopatra access sheath you're using. Is it a navigatable one? It's 40 centimeters.
Yes. Yeah.
So you're able to go directly into the kidney with it?
But it looks like, you know, I can't advance it even without the safety guide wire. So it's going to be unlikely that I'll be able to use the flexible part of it.
Okay.
So we may still do a simple thing rather than a suction.
Normally when we're doing a flexible ureteroscopy and using an access sheath, we're told to keep the access sheath below the UPJ, so you have good distension of the renal collecting system. Do you tend to try and place your access sheath above or below the UPJ?
So when I use a flexible access sheath, obviously I have to go above the kidney. UPJ.
Yeah.
Now what my excellent nurse did, I've asked her to flush the working channel of the scope. I've already, but I'm going to do it again, I've already make the wire wet. Because as I said previously, I'm going to try and advance the scope over the wire rather than advancing it. Trageți-l un pic în spate. Și puteți deja conecta. Aveți conectorul pentru...
This patient was pre-stented.
Yes.
So the ureter is clearly not very compliant, even being...
It's still
not compliant.
Yeah, so... But, you know, the first rule of endourology,
I share that.
Force. So let's see what happens.
We have microphones. If you guys have questions, there's plenty of microphones.
You can plan a live surgery or you can plan a surgery as careful and as good as you...
Yes.
But it may still not work the way you want. Ok, acum prindeți-l asta. I'm going to try and advance the scope gently, see if the scope travels over the wire easily. It should. Let's see. Now there is, look, even with a scope, there is a bit of over the wire. It doesn't go. You see, can you see the X-ray?
Yes, challenging non-compliant ureter.
Yes, the scope is not advancing, though it's a very thin, it's a 6.3 scope. So I'm going to connect it, see if I can actually see something. But yeah, live surgery is not the best scenario. Let's see what's going on.
How long had he had a stent for? 2 weeks? 3 weeks. 3 weeks is often sufficient, really. And female ureters are better than male. In terms of female ureters, more compliant than male.
I'm not sure if you can see the endoscopic view now. Now, obviously, I can't bend the stent, the scope.
Yeah.
I can only see and watch what's going on. And I'm going to try and see if...
Can we also get the endoscopic image?
Yeah.
Yeah. Okay, so what would be the next thing? The scope doesn't go up. Now, what I need to do is, obviously, though the wire went in nicely and so on, I need to check, is it my wire in the kidney? So I'm going to put some contrast. Asta e 100% sau 50%? Okay, so you see, contrast goes.
Can we see live feed for the fluoro image? Thank you.
Yeah, just a sec. Doesn't look good. No, yeah, I know, but I need to see exactly what's going on. So I'm going to retract the scope a bit more. There's not too much space for contrast to go alongside, so. But it looks like.
First thing, let's reassure ourselves you are in the renal system for the audience.
So what do you think? Is the wire out?
Yes, that was going to be my suggestion. Sometimes the wire can be, this is not for everybody, training endourologists, this is for the expert endourologist.
Okay.
Take the guide wire out.
What I'm going to do, because I have no other option, I'm going to try and retract the wire.
Correct.
And see if, because it may be that the wire is, though it looks like it's in the kidney, it may not be in the kidney. Now, a bit more fluoroscopy that I would normally want, but yeah, it is what it is. So why? We did, and I stopped because it was very tight.
For training endourologists, be very careful in this kind of scenario.
Fair enough.
A lot of residents will stop, put a stent, come back another day. But yes, I would do exactly the same because we like to think we're skilled. Take the wire out, having good vision, good dexterity, do not push, and just make sure you have optical view.
There's no extravasation. It's just a tight kinked ureter there.
Yeah.
So we didn't perforate the ureter. It's just not a very friendly ureter.
No.
Can I have the wire back?
And I'm really pleased you've really been very gentle here.
Can you guys see the...
Yes, we can. It's a very poorly non-compliant ureter.
I'm going to try without a guide wire and see if I can manipulate the scope into the kidney, which I did.
Congratulations.
So I'm in the kidney now. But you saw, don't force.
No.
Stop. Think. Understand what's going on and then carry on. Now let's explore the kidney a bit.
I think the message you just delivered, this is the whole advantage of live surgery. You want to see how to get out of a very difficult situation. So congratulations for even managing that.
But do you see this, guys? How is the environment alongside the scope? I'm not sure if, for the experts, it's very easy to recognize it. For the people the surgeons who not doing a lot of ureteroscopy. Now my flow is on, but does it look like there is any movement in the kidney? Because I have no outflow whatsoever because of that tight area, and it means that the pressure now in the kidney is exactly the pressure that I have on the bag. So that would be approximately 40 centimeters of water. Now the big problem, the big risk is when in this scenario I start putting more pressure. This is, so many thanks to my beloved colleagues here for giving me this wonderful case.
Yes.
Guys, thank you. Now I know you love me.
Well, it's a difficult case, and you expertly navigated your way into the kidney. I can imagine the vast majority of urologists who are non-skilled would have stopped, put a guide wire in, put a stent in, and come back another day. So the fact you're able to even get inside the kidney is quite a skill. So again,
now the other lovely thing is that, you know, I'm using how shall I call it? American deflection scope. It means I push the lever up, the tip goes up.
yes.
Again, I'm very lucky today, so they gave me exactly the opposite. So I'm using a
You all know the difference between logically logical and logically illogical. Okay, logically logical, up is up, down is down. Logically illogical, up is down, down is up.
Luckily, at least I knew about it beforehand, because it happened to me a few times in live surgery when I didn't know. And yeah, you see, oh, come on, what is this guy doing? Does he even know how to operate? Yeah, so guys, what's this?
But
yeah, that's a very nice view
It's a
of
nice
the papilla
view.
with some Randall's plaque. This is how Randall's plaque looks like. Don't do anything to it. Leave it there. Don't laser it. Has no... Yeah.
so,
What's this one? Again, another
yes,
one. Leave it
question
there.
from the audience?
Yes, go ahead.
Sorry, in this case, would you advise passing the access sheath along your flexible ureteroscope?
I will try, but you know, I can't force. And this is the stone, yeah. Now, the problem is, you see, the visibility is poor. I have no outflow whatsoever. What do? So sometimes if I don't have a pump, you see, I just press on this and I get a bit of... Now, the big issue is here, not now, because I can see the stone, I can navigate around it, but when I start using the laser, there will be no visibility whatsoever. So, let's push our luck a bit, and I will try and advance the access sheet over the scope, hoping that I'm going to bypass that area now since the scope is already there. Yeah, you see where the stone is?
Yes, thank you.
And now, let me see. Let me see. Sometimes, you know, the scope straightens things up. You see, the sheath bypassed that area, but did you see the movement? Can you see my hands?
Yes, indeed. We can see your hands.
So the movement was not this. The movement was this, like with the PCNL.
Yeah, yes,
You know, small rotation,
yes.
and I think I'm in there.
Right, and the
Yep.
flow,
And
this
now-
flow begins.
Now you see a completely different view. There's flow, things happen in the kidney, all the visibility is going to get much better, and I think we can open the laser, please.
I think-
use a Soltive laser, which is one of my favorite lasers for stones. And
I'll just, before you go on to the laser, I just want to make this point you've just made quite important.
now another quick trick here. If you can see my hands, can you see it?
We can, yes?
Yeah, so with thin fibers. So the TFL lasers allow you to use very thin fibers. You need to control it. You can't do this, you see? If you do this, you're gonna fracture the laser fiber. So I hold it here with these two fingers, and then I advance it very close to the tip here, with small movements, like 2 centimeters, not more, preventing any bending. And, you know, be patient. That's endourology is about, actually surgery is about patience, but endourology specifically. Be gentle, be patient. Don't use
I'm going to
force.
go back a second because you took some time to make sure you had flow. You did not start lasering because you saw the stones. It's, again, an important message to the audience. The fact that you took your time, you wanted to have good inflow, good outflow before you even, and good visibility before you even engage the stone. That's quite an important message. It's very easy to have seen the stone, laser where it is, but you didn't, which is excellent, you know, in terms of technique, so that you actually spend a little bit of time to make sure you optimize your visibility, reduce intrarenal pressure and temperature, okay? And you make sure you have a good flow. So what laser fiber are you using, please? The size?
I'm using a 200 microns. I could have used 300 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 microns. I could have used a 150, but that's my standard, that's my preference. Because, you know, the inflow, I can control it, and I can increase the pressure on the inflow, and I have a large outflow. So bending is not an issue. Can I have the aiming beam off, please?
Yeah, I have two questions for you.
Yep.
Whilst you're there, I see you break the end of your fiber. You break the...
Yeah.
Yes?
Yeah.
Reason why you do... I do that as well. But
yeah, obviously I've learned this from Olivier.
Yes.
And it's because I want...
You can see, you want to see when you're dusting, you want to see you're actually in contact with the laser, so a lot of urologists break the tip.
So what I'm going to do now, I'm going to change things a bit. You'll see at some point the sheath in front of me.
I do have another question.
Very slowly trying to see if I can put the sheath in. Okay, so I'm still too bended.
I was going to ask,
completely bended.
Would you...
I'm gonna straighten the scope, and now we can see the sheath. And I'm going to try and go over the stone with the sheath.
Would you have considered manipulating the stone from the lower pole into a slightly more favorable calyx?
The access would have been very difficult, yes, but I think I have a decent access to the stone at this stage. And I wanted to show you, because everyone says, oh, you've got a 6.3 scope, that's not going to allow you to bend the sheath. Look, 6.3 scope, I can bend the sheath in an acute angled calyx.
Again, you know, having this technology has changed the way we think. Before we had the small scopes or the suction access sheath, the convention was to move that stone. You wouldn't engage it in the lower pole.
Now, what do I need? What am I missing here? I'm missing space. I'm missing a way to control how dilated the kidney is. As you can see, I'm not in a rush to start lasering. I want to have an optimal condition. So what I will need now, because the outflow is good, you can see outflow coming from here. I need an increased pressure in the kidney, so I will need someone to squeeze on the bag, please. Thank you. Yeah, I'm not in a rush to start lasering. It's there, it will happen. If I need to manipulate it, I will. So,
Again, an important lesson that you're...
And I don't have any suction yet. Now, the problem with squeezing the bag is that you don't transmit too much pressure from there. It's a bit of a different... The closer you have the mechanism of increasing the pressure to this, the less pressure you lose through the... So, guys, I would strongly advise you that you find a way to get something that you can control the pressure a bit better.
Yeah, it's important
but
to have
the tider, so the tider should be able to do that.
Correct.
Now, I'm not happy. I don't think it's going to be a good lasering. I don't think things are... Because I still don't have enough pressure in there. I will start. Let's see what happens. As you can see, I keep my fiber quite close to the tip of the scope. I fix it. And then I will start lasering, but probably I won't be able to finish this in the time that we have left. I would encourage you to start on time with the next lecture. I will carry on with surgery here.
Okay, thank you for that.
Settings is going to be 0.5 to start with, and it's going to be 10 hertz, okay? Small, not too much energy, and low frequency for sure.
Okay.
The other thing is, yeah, I'm not really happy with this. I may need in the end to relocate it. Let's see how it goes. Because you can see it's... Now, if you're not happy with the pressure when you have a sheath in, what can you do? You have to retract the sheath a bit, allow the kidney to get some pressure in, and this is what I'm going to do now. Sorry guys, you're not seeing any lasering yet, but you will, I promise you.
Should we switch and come back? So, Lorian, what we're going to do, listen, we're going to switch over and carry on with the lecture. We'll come back to you shortly.
Okay.
Very, very difficult case. This is the joy of life surgery, and you've expertly got into the kidney. You've engaged the stone. Challenging, very challenging case.
You see some lasering just to, but for the moment, it's not ideal.
Yes.
Okay? So this setting is enough.
So, Lauren, we're going to come back to you. We're going to move on to the lectures. Dr. Buddha, are you we're ready for you? We'll come back to you, Lauren. But good luck with the case. We'll come back to you shortly.
It's okay. Good morning, everybody. Thank you so much for your kind invitation. It's a pleasure for me to be here today representing my group and representing the Spanish Urological Association. Yeah? It's for... No, don't worry. I can pass the slides. Don't worry about it. Thank you. Thank you so much. So it's a pleasure for me to be here today, and I'm going to speak about intrarenal pressure and intrarenal temperature during endourological procedure. And when I started in endourology and surgery, it was a very safe scenario for patients. I started with a Freddy, with Candela laser, and the first hormone laser that I had was a hormone laser with 10 watts. So, we use as well a gravity irrigation system, so the possibility that the patient suffer complications for a high temperature or high pressure was very low. So the only factor that we had to control is the positive urine culture before the surgery. But nowadays, this scenario has changed a lot because we have available high-power laser, and so we can choose the strategy for baking the stone, and sometimes we prefer to use the dusting technique, and so we need a good visibility, and so for that we need to increase the inflow for keeping a proper visibility during our procedure. So in my personal opinion, I think that the line that separates a non-complicated surgery from the complicated surgery is a thin line that depends on the silent drivers. Silent drivers that we have to consider, and the main silent drivers nowadays in intrarenal surgery and percutaneous surgery is the intrarenal pressure and the intrarenal temperature. So, for analyze the first drive of complication, intrarenal pressure, we have to consider that for performing a safe and proper procedure during the retrograde intrarenal surgery, we have to have some technical factors. We need to have a very good visibility during the procedure, and we need to get a high efficiency with our surgery. For that, we need a high power laser, and we need a high inflow for getting that. But for getting these technical factors, perhaps we can affect to the physiology of the kidney and produce a damage during the surgery. So intrarenal pressure, we know that the normal values for the kidney is not more than 15 millimeters of mercury. Because if we increase that pressure, we are going entonces to produce intrarenal backflow, and we are going to increase the probability of complications because bacteria or some bacteria that is in the urine entonces can pass to the general entonces blood entonces flow. So we know entonces thanks entonces to the model animal studies that if we increase the intrarenal pressure above 20 millimeters of mercury, entonces we are going to produce a pielotubular backflow. If the pressure, intrarenal pressure, is higher than 30 millimeters of mercury, we are going to produce a pielovenous backflow. And if we increase entonces above the 70 millimeters of mercury, we are going to cause the fornix entonces rupture. So we have as well entonces some knowledge for entonces model animals, and we know as well in this study that the maximum pressure that we can generate in the endourologic procedure is not more than 50 millimeters. Because entonces when we study the pig model with renal gammography using in intrarenal surgery a pressure of 21 millimeters of mercury, only during 15 minutes we are going to produce an intrarenal backflow in the upper pole and in the lower pole. Is the first area affected in the kidney. And with a very low pressure, 21 millimeters of mercury, we prolong the surgery until 70 minutes. The 66% of the parenchyma, the renal cortex, is affected by intrarenal backflow. So in my opinion, I think that it's not only important to control the intrarenal pressure, it's very important to control as well the time that we are going producing a high intrarenal entonces pressure. In vivo intrarenal pressure measure has shown as well that the main differences between to have complications like entonces sepsis when it's compared with the control group in more than 120 flexible ureteroscope, entonces was the presence of positive previous culture, because entonces sepsis was produced in 50% of patients with a previous positive entonces culture. And it was entonces detected as well that the patients with sepsis has entonces a higher overall intrarenal pressure, has a higher intrarenal pressure during the flexible ureteroscope, and entonces has a great variance when it's compared in intrarenal pressure when it's compared with the control praticante groups. So, entonces we have not only to control the intrarenal pressure, it's important to control as well the positive previous entonces urine entonces culture. So we have then three factors to control: intrarenal pressure, the time, and of course entonces the presence of bacteriuria in the previous entonces culture. And in my personal opinion, there is a fourth entonces important factor that we have to take consider is the papilla anatomic characteristics. Because entonces when we have a normal anatomic entonces papilla, the normal anatomy of the papilla reduces the intrarenal backflow, entonces because this anatomy produces a compression of the velini entonces conducts. But if we detect entonces papilla calicial abnormalities as surface pitting, loss of contour, ductal plugging, or even entonces Randall's entonces plaques in more than 50% of the papillas, is to say we have a PPLA entonces score, is a specific classification of the morphology of the papilla. In these cases, we are going to increase the risk of intrarenal entonces backflow, and we have to keep in mind that the 77% of kidneys have at least one papilla with a high PPLA entonces score. So, entonces, in my opinion, entonces we have to consider entonces four different aspects. The first one is intrarenal pressure. The second one is the time that we are going keeping a high intrarenal pressure. The third is the positive urine culture that we have to try that the patient reach entonces the operating room with a sterile entonces urine culture. And the fourth is the abnormalities of the papilla. So we have to consider it in the operating room and modify the intrarenal pressure that we are generating into the kidney when we are performing the surgery, depending on the morphology of the calyx. So, nowadays, we have different tools for increase the safety during our procedure. So, we can different devices that can allow us to know which is the pressure, intrarenal pressure that we are generating during the procedure. These devices have an important disadvantage, is the high cost that they have, and so we can select for patients with high risk. It's a heart stone burden patients or patients with a previous positive culture or perhaps infectious lithiasis. So, for increase the safety for our patients during the retrograde intrarenal surgery, it's important to control the intrarenal pressure using URS with a real-time pressure sensor in the tip, using smart pumps that allow us to adjust automatic the controlling the inflow and outflow, or using suction devices, these of fans for reduced intrarenal pressure. It's important that the patient reach the operating room with a sterile urine culture. It's important as well reduce the operating time, and it's important inside during the surgery to see all the papillas and adapt our intrarenal pressure depending on the morphology of the calycial papilla. The second driver of complications is the intrarenal temperature. And so, for that, when we are using a high power laser, we have to look for a balance between the efficiency and the safety of the patient. We have now this problem when we started to work with laser, because we used a lower power laser, and in these cases we use always a low frequency, and then the predominant effect that produced the laser was a mechanical effect. So the temperature that the laser, the low power laser generates is very low. But now we are moving to where increasing the efficiency with the high power laser, and then we have increased the high frequency, we use high frequency and low energy, and then we have changed the predominant effect of the laser, and photothermal effect is predominant when we use a low energy, a high frequency. So we have extremal risk of thermal damage. The heat dynamic is known for all of you. The optic energy is generated by the pulse laser. It creates a steam bubble, and when the bubble collapses, there is a quickly transmission of the energy to the water and surrounding tissues. So, for controlling the thermal risk, we have to consider three different aspects. Is the laser power that we are going to use. The irrigation flow is a control of the inflow and outflow, and of course the anatomic location in which we are going to treat the stones. Because nowadays we know that the temperature threshold is only 43 degrees centigrade, and we know that if we increase the temperature, then the time is reduced with a logarithmic function. And if we reach a temperature of 56 degrees centigrade, in this case, the damage, the injury of the kidney is instantaneous. So, perhaps we should know a safety thermal matrix in which we have to combine the power of the laser and the watts that we are generating, and the irrigation flow that we need to keep safe threshold of the temperature. So if we increase the potency or the power of our laser, we need to increase as well the irrigation rate. So when we are going to treat a patient, entonces we need entonces to get a perfect balance between the total energy delivered and the possibility of cold, entonces the water that we are entonces heating. We have to consider as well entonces what are the limits entonces of the power laser, that the power of the laser when we treat entonces the stones. Because if we are working in the kidney, we should not entonces pass entonces the energy of 20 or entonces 30 watts. And if we are working in the ureter, the limit is only entonces 15 watts. Mainly, entonces, because in the renal pelvis and in the kidney, entonces, cavities, entonces, we have a low inflow, entonces, resistance, and there is a natural, entonces, heat sink provided by surrounded, entonces, blood flow. So, prácticamente, we can use a higher, entonces, fluid volume than in the ureter. And the ureter, we have a limitation because we have a high inflow, entonces, resistance, there is no space, and entonces, there is not anatomical, entonces, heat sink. So, entonces, it's important to limit, entonces, the entonces, power of the laser in, entonces, the ureter. It's important as well, entonces, to know the laser properties that we are going to use, and we know, entonces, that, entonces, TFL, entonces, laser, entonces, is, entonces, the water absorption is 4 times, entonces, more, entonces, than, entonces, holmium laser. The modulation of the pulse, entonces, the most mode, entonces, and the distant, entonces, most mode, entonces, reduce the temperature of, entonces, the water surrounding the stone. And the long pulse, the use of long pulse as well increase entonces the heat entonces areas. It's important as well entonces to keep the safety entonces distant entonces to the urothelial tissue at entonces 0.5 entonces millimeters in order to reduce the probability of entonces injury the tissue. And it's important as well when we are using entonces the laser entonces to know that the operator duty cycle, entonces timeline, entonces should be entonces 50%, because it's the only way entonces to keep the temperature in entonces a normal entonces threshold. Because if we activate entonces the laser continuously only in 10 entonces seconds, entonces we can increase a lot entonces the temperature of entonces the water. And it's important entonces to know as well that if we increase the size of the fiber for the same entonces power laser, entonces we are going to generate a higher temperature. It's as well entonces important entonces to reduce entonces the endoscopic entonces seed diameter ratio in order to maximize the thermal entonces turnover and protect our patients and reduce the temperature into entonces the patient. And if we need, entonces, because we are treating entonces, a hard stone, and we need to increase a lot entonces, the power of our laser, we have entonces, the possibility entonces, to use entonces, some advanced mitigation tools. Is, for example, entonces, to use a chill irrigation solution that entonces, helps us to keep stable the temperature, and we can use as well suction devices entonces, for maximize the turnover of the temperature. So, entonces, the playbook entonces, for thermal safety is to limit the power depending on the location entonces, of the stone, is entonces, to get a flow optimization, is entonces, to use an intermediate activation of the laser, and for entonces, hard stone to entonces, decrease of the temperature of the irrigation fluid, or entonces, use a suction entonces, device. So, entonces, if we want entonces, to perform a safe procedure for our patients, we should entonces, to control entonces, the quadriflecta of retrograde intrarenal surgery, and to get a perfect entonces, balance entonces, between suction, irrigation, intrarenal temperature, and intrarenal entonces, pressure. And the future is promising, really, entonces, because entonces, we are going to have real entonces, time sensor into the patient, and we are going to have systems that allow us to have automatic control of the quadriflecta of retrograde intrarenal surgery. Thank you so much for attention. This is my hospital in Valencia, in Spain, and so you are invited to visit us. Entonces, when you want, you are welcome entonces, to Valencia and to our hospital. Thank you so much for your invitation. Any question?
Thank you for your presentation, wonderful state of the art. Just a little curiosity of mine. Are you acquainted with the intelligent pressure control system by Tidor? And what's your opinion about this tool?
Yes, I think that is a good tool entonces, for increase the safety. I think that in the future, perhaps entonces, it will be our way entonces, working. Nowadays, I think that perhaps the control of intrarenal pressure perhaps is only necessary entonces, for high risk entonces, patients because I learned entonces, to control the intrarenal pressure without now what is the figure that the pressure that we were entonces, generating into the kidney. But I think that for novel surgeons or for entonces, high risk entonces, patients, it could be a very good entonces, tool entonces, for learn in a quick entonces, way what is the pressure that are we generating. And perhaps when you have learned entonces, it's perfect. It's possible to reduce the use of this type of sensors because you have learned entonces, about the intrarenal pressure that you are generating. But I think that there are entonces, some high-risk patients in which entonces, you have to use that.
And of course, you talked about time. I'm very curious about this factor. You have a time limit on a flexible uteroscopy, 60 minutes, 90 minutes?
In my clinical practice, it's 90 minutes.
Also here?
Yeah.
Also here?
Yeah.
Thank you very much for your...
Thank you.
Yes, of course. It's okay.
Lauren.
Can you hear me?
Lauren, we're back with you.
Yeah, can you hear me? So
We can hear
have
you.
a look at the X-ray now. Okay, stone is gone.
By magic.
And I
Tell
just
us how you
wanted,
did it.
I'm finishing now. I just wanted to show you, this is one of the very few last fragments. I wanted to show you one of the things that I'm doing. I was waiting for you guys to finish with that. So I laser in the sheath. Laser on, please. Yeah. And you see, at some point, the stone, you just have to wait, because it's attached a bit to the... Yeah, so I'm not forcing, I'm just waiting. You see what happens? It will slowly come over from there.
So you get the Venturi effect,
Yeah.
the vortex effect.
Yeah, but it's attached to the... Oh, see, that's it.
Beautiful.
And now the stone is behind me, because I have a 6.3 scope and an 11 French sheath. So it means that the stone has already passed behind me. You can't see it, but I can feel it when I retract the scope. So when I do this, you don't see it, but the stone is behind. Once I go back to the entrance, the stone will fall into the suction. Now I have the suction on, and I think that was the last fragment.
Can I ask a question? Before you go, are you still in the lower pole? Did you end up lasering in the lower pole?
Look at the
We're looking at the
X-ray.
fluoro. We can see
I
the
did
fluoro.
everything in the lower pole.
Fantastic.
With 6.3 French scope. Lots of people say you can't do it, you can't bend it. I could bend even an 11.3 French, 11/13 French sheath with no problems whatsoever. So as long as you know what you're doing, things can be done. So I'm really grateful to you all for watching this case, and very, very much grateful to my wonderful assistant and the excellent theater team, the anesthetist, and everyone here in theaters. They are really, really professional. A really professional team. Thank you very much, guys.
Thank you. We would also like to congratulate you. This was a very challenging case, and it's interesting that you were able to do it successfully and effectively. We have 1 or 2 questions from the audience.
Yep.
Dear Laurian, congratulations for the surgery. It's
Thanks,
a challenge case, and you have resolved it with very easy. You have made it very easy. My question is about the indication. It's a moderate size stone in the inferior calyx, and I think that it could be a good case as well for mini percutaneous surgery. Do you think, my question is about that, do you think that the use of fans, in this case, has changed the indication of mini percutaneous in the inferior calyx?
Definitely. Look, you can do things that you couldn't do before, and I'm a fan of fans, let's put it like this. Yeah, so this is how the calyx looks at the end. It was a lot of friction of, the stone was quite long, but I think we're done. I'm just going to take that small thing out. That's it.
I have another question. You were being very explicit in the size, between the size of the access sheath and the flexible ureteroscope. You have to have a certain diameter difference to allow that suction.
Yeah, you should have ideally 2.5 French. I will discuss a bit in my presentation about the difference.
We'll save that conversation because I think quite an important.
So look, even with a tip there, I can bend the scope and bring the sheath in. You see, very clearly.
Sorry, another question. We didn't actually caught
any other questions?
The power settings that you've used for the case.
Thank you. Your energy settings, please.
I couldn't hear you.
The energy settings that you used.
Your laser settings.
So I started with 0.5 and 10, and then I moved to 1 and 10 because this large gap between the sheath and the scope allows me to get larger fragments, so I'm quicker. So having this combination, why is it a good scope good, a small scope good? Because it allows you to do this. You're much quicker. So most of the operation today was not the lasering, was access, going around, making sure that when you start, you can do it. So I think more or less that's it. I'm going to put laser on standby, please.
Okay.
I'm going to put a stent and come out.
Congratulations for a beautiful job. Well done. Thank you very much. We'll see you in the auditorium shortly.
Nu e așa, și dacă ai diametru mare, văzut ce fragmente se duceau.
We are moving to the next round table, to the next session, and the session is my favorite laser in endourological stone treatment. So I invite Dr. Stefan Rascu from Bucharest, and he's going to speak about what is the favorite laser in ureteroscope. So thank you so much when you want.
Thank you. So we're just going to set up the technology a bit. That's what you should do before every surgery you perform. And just a second to switch the screens. Okay, so dear colleagues, it's a great pleasure to be in front of you today. Have several topics to discuss today, and one of them is my favorite laser in endourological stone treatment. And as a disclaimer, I would start with, well, there's no such thing. There's no such thing as favorite laser. There's not even such thing as a favorite tool to use in the certain surgery, because there are lots of clinical scenarios that make you adapt. And they make you switch instruments just to be able to offer the proper solution for your patient and for the case you're actually facing. Okay. Yeah, we'll do it the old-fashioned way. So What I'm going to talk today is about, well, the two most frequently used lasers. It's the high-power holmium laser, and it's also the TFL. Now, we all know they have differences in wavelength, in pulse profile. For example, the holmium YAG has a irregular, spiky profile, just like a shark bite. The TFL has a symmetrical, smooth profile, just like a tabletop. The pulse energies are different, so varying from 0.2 to 6 joules in high-power holmium, and from even lower, 0.02 to 6 joules in TFL. So also the most important aspect I would consider would be the pulse duration. So lower, lots higher in TFL and lots lower in high-power holmium. And again, some slight differences in terms of diameter of the fibers. Now, each of these two lasers have their own advantages. I would say that for the high-power holmium YAG, and it's a nice slide that was with a nice research done in the Michigan State University by Khurshid Ghani, that actually demonstrated that with the high-power holmium laser and high-power holmium YAG, and with the MOSES technology, besides having a reduced rate of repulsion, you also get an increased fragmentation rate. And that usually happens to the MOSES effect. And that gets you more fragmentation at distance. And that's quite important for a ureter stone setting. That's quite important. Now, we should always keep in mind that they have different profiles of the peak power. High power holmium has a high peak power. TFL has a low peak power. Again, in the wavelength, they have different profiles. Now, the TFL has a long, very long pulse profile, even in their shortest setting. And again, a nice illustration here given by Eugenio Ventimiglia that actually showed us the differences between a TFL, a high-power holmium with MOSES technology in the second image you see over there. So you see the wavelength of the TFL in blue there. That's very, very long, even if in the shortest setting, 2 to 6 times longer compared to the high-power holmium laser settings. But you know what? Usually in lithotripsy, in my opinion, high peak power actually matters, because laser lithotripsy is not only represented by dusting. So that's ideally, you know, it's ideal to perfectly dust the stone, but that's not available in every clinical scenario. So high peak power actually allows you to fragment the stone more efficiently. It can be adequate for all locations and all scenarios of the stone, whether if you have an embedded stone or an impacted one, whether if it's mobile, if it's small or large, and usually any location, whether it's in the bladder or the kidney or the ureter. So also fragmentation given by this high peak power can be efficient for all stone compositions compared to the TFL. And again, given the peak powers of the two lasers, you know, usually TFL has a low peak power. This means what you're doing to a stone is not efficiently fragmenting, but rather drilling, so putting holes inside a stone. And another research by Khurshid Ghani, well, they performed the following thing. They increased the power of the TFL from 1 joules to 3 joules, and what they found out, they have very little increase in the ablation depth, even in the short pulse. And the normal question to ask was, okay, but where does all the energy go? So if it's not going in the stone, where does it go? The actual point is that it goes in the environment, the liquid environment around you. And that may be fine in a kidney when you have lots of space to work on, but it's not okay in the ureter where you have a limited space, and this means thermal effect on the fluid you're using. And that might lead, of course, to the mucosal damage given by the increase of temperature of the liquid. And this is actually one of the things that stood upon giving the warning, warning by the Olympus. And after a thorough analysis, well, it revealed actually that users likely exceeded the 20 watts total power settings in the ureter and also in the PUJ. And this is the reasons that they were getting lots of strictures after after performing laser lithotripsy onto the ureter, and this is one of the reasons most of the people that were using TFL on the ureter, well, have given up on that. So I'm using both lasers in my department, so we're going to talk about the ureteral stone because the renal stones are the subject of discussion of my colleague who's going to be after me. So you don't have a favorite laser on the ureter. Mainly you use what you have, but you have to know how to use it. That's the key point. So it very much depends on which stone you have on the ureter. It's not necessarily a matter of size, also, although size actually matters, but it very much depends whether you have an impacted stone or a non-impacted stone. So let's say I would have an impacted stone, what do I want? Do I want to drill inside it? No, because there are scenarios when you cannot even reach the stones with your scope. You cannot reach your stone with a lithoclast, with a basic lithoclast. Therefore, I would use a high-power holmium laser for a ureter because it allows you to work a bit from far away. Having a high peak power will matter, of course, and having the Moses effect or the vapor tunnel that you see in quantum technology would actually allow me to fragment more and even from a slight distance. Always using the low power settings. This means you should use a frequency that's perceivable by the human eye. Frequencies over 10 Hertz actually cannot be perceived by the human eye. This means 10 frames per second. Higher than that, it's hard to perceive. Always with low energy settings, and usually below 1 joules. And if I have a non-impacted stone, well, that should be easy to perform. Always use the TFL as it has reduced retropulsion, always, again, with low power settings, because it allows you to perfectly dust a stone, also in the ureter, small fragments resulting after it. So as a conclusion or as take-home messages, well, the high-power lasers improve fragmentation speed, and that, of course, reduces your OR time. High-power holmium has high peak power, TFL has a low peak power. Also, the high-power holmium can split the pulse, Moses effect or vapor tunnel. They have more fragmentation and more precision modes as built-in settings. And also a ureteral stone would require more precision. High-power holmium can be ideal for large renal stones or impacted ureteral stones. Always in the ureter, in my opinion, you should use less than 10 watts. Ideally a frequency of 5 Hertz and energy that can go maximum to as high as 1 or 1.2 joules, and always staying, of course, away from the mucosa. But the key point of my presentation, I think, that would be just don't be keen on using only one laser or one type of device, one type of instrument to solve your case, because in lots of the situations you have different clinical scenarios where you might have to use all your toys, all your tools to properly solve the case and leave the patient preferably stone-free. Thank you.
Question. Thank you very much. Beautiful presentation.
Perfect.
We're clearly very spoiled, but we have several lasers.
Yeah.
And that helps you a lot.
That's true. Unfortunately.
2 is not bad going. But if you were to just have one laser, like a lot of people just have, can only afford one laser, would you go for TFL or would you go for holmium?
It's a very good question, actually. You know, it's a question I've always asked myself because, well, maybe you don't always have to operate in your own environment and operating room. I think I would opt for the high-power holmium because unfortunately here in Romania we have large kidney stones, not necessarily for PCNL, but still stones that can be solved through retrograde intrarenal surgery. And in my opinion, that's more versatile. It's proper for the ureter, also for bladder stones, and also for kidney stones. In terms of price, well, that's another discussion.
It's a balance, isn't it?
Yeah.
It's a balance.
Yeah.
Does any of you have a view in the audience? Many of you use TFL laser? No? Interesting. Okay. Thank you.
Thank you.
Thank you so much for your presentation. We are going to move to the next presentation. Dr. Razvan Popescu, Endoscopy for flexible URS. What is your favorite laser for flexible ureters?
No. C'est bon? Which one is the best one? Doamne, și pe asta. Actually, which one is working? I plug this one.
Free of that now.
It's all mixed up.
Yeah. It's all mixed up now.
I think you'll go with the old-fashioned way.
There's a connector.
Okay. Okay, I'll choose the. Which one?
Do move it to your laptop. From the bottom laptop, move that to your laptop.
This one?
Yeah. Connect
here
that.
to here.
Good. There you go.
Let's
One
check.
of the two should work. Hopefully, we'll try the other one.
Allow.
This should do it.
I think the safer approach is the thing.
Continue back. Quit. So maybe like this. Yeah? Okay, thank you for the introduction. Sorry for the inconvenience. I may recap some of the things my colleagues have actually already discussed. My name is Popescu Razvan. I'm assistant professor here in this hospital. And the subject we will discuss today is laser technologies in flexible ureteroscopy, the renal side of the discussion. Okay, from the first statement, I want to say that I have nothing to declare, no conflict of interest. And the discussion starts with the holmium, YAG, and thulium. Who is the actually winner? Is there a winner? Maybe, maybe not. As the starting statement, from the early beginning, we have to state that there is not only about the laser. There is also about type of flexible ureteroscope, type of the ureteral access sheet, laser fiber, also laser settings. You have to know the laser settings you are working with, surgical technique, and also stone type. Okay, from the last few years we were used to the guideline recommendation of the holmium YAG recommendation. Actually, in the 2025, this includes also the TFL recommendation, so we can use it. Talking about the basic principles, holmium YAG is more based on the photothermal principle, while thulium laser is based on both photothermal and photomechanical phenomena. We have also the laser terminology with pulse energy, frequency, pulse width. We already discussed it.
types of modulation in holmium and thulium fiber lasers, and the standard settings for holmium. Just remember, we don't have the standard settings for thulium right now. Actually, each one of us is using it absolutely how he improvises, or maybe from other papers. The same standard and Moses effect as my colleague already presented, illustrating the propulsions between the standard and Moses. And talking about parameters, we can easily observe several differences between holmium and thulium. First of all, we have the wavelength difference from 2100 to 1090-40, and we are continuing with the water absorption, already discussed, the fiber diameter, which is significantly reduced in TFL, pulse energy, ablation efficacy, calculate type, thermal injury. We will discuss it in the further slides. This is a more detailed scheme published from Professor Taxe and Cronenberg, also with the same principles. So the laser settings differences are, this is a slide highlights the difference regarding pulse energy, which is 10 times lower for thulium. This might help you while getting very, very fine dusting. The frequency, which can be as high as you want, but fortunately is not necessary. Another important aspect is that holmium-Young pulse profile is irregular, with spikes from time to time, asymmetrical, while the thulium is almost square wave, symmetrical, producing constant peaks. Okay, some aspects regarding the fragments. The thulium present for 4-time ablation volume in the same time in the in vitro conditions, high dust quantity and better dust quality. Significant litropulsion and smaller fiber size comes with the advantages in deflection, accessibility, irrigation, and also in visibility. Last but not least, the dimension of the TFL is 10 times lower than the holmium. The electric consumption is significantly reduced. It's consuming like 2 hair dryers, and the electric connection, the switcher from is like the normal electric for all the equipment in the room. Here is one systematic review I found from the last year, which presents interesting results from 8 manuscripts published in the last 4 years. They are important manuscripts. Most of them are presenting a higher stone-free rate for thulium compared to holmium. Some of them are also presenting a shorter operating time, better visibility, lower retropulsion, and similar complications rate. Oh, I got electrocuted. Okay. Laser burn, yeah. I don't know exactly. So, let's see if is this exactly how it's discussed in the studies, because this systematic review analyzed all the studies. So the stone-free rate favors TFL, but there is no significant differences. Operating time, also mostly no differences. One study favors TFL. Lasering time, also. They show no difference. They show some differences regarding the retropulsion, which favors the TFL. No complications were registered regarding the complications rate. And thermal safety show no clinically relevant differences. There's a study, a recent study showed that thulium fibers demonstrated equivalent or marginally superior outcome compared to pulse holmium YAGs. So it's not so big difference that is presented in vitro settings. Maybe more studies are waited to. There's also take-home message. TFL reduced retropulsion, superior dusting, mostly in the in vitro, and yeah, Shorter operative time, is it real? The previous study showed that this is not real. Improved visibility this year might be real because it uses smaller fibers and beneficiates from better irrigation. We have also thermal safety concerns as limitations and lack of standardized settings, limited long-term data because it's quite recent. The advantages of Holmium YAG: already proven its reliability, established safety profile, wide availability, lower costs, maybe. Okay, so I found a study from a close friend, actually she gave me, Mariela Corrales, who worked a lot with Professor Truxte, and they studied the intrarenal lesions produced by TFL and holmium laser, and in a porcine model by dusting, and they reveal no differences detected after anatomopathological evaluation for both laser, and only slight inflammation was seen in all cases. So the animals had only interstitial nephritis. Clinical outcomes: high stone-free rate for both lasers. TFL may be associated with shorter procedure, comparable complications rate. Laser choice depends on the case complexity and hospital availability, because this is a quite real fact that we have to take into consideration when we start a case. Maybe it's not always important the laser fiber when we start a case. Maybe it's advisable to evaluate the complexity of the case to see exactly what access sheet do we need. Do we need suction? Do we not? Yeah. The planning, I think, is the key to this one. So TFL represents a significantly advancement. Holmium YAG remains a viable option, and future trends favor the optimization of TFL. Thank you for attention.
Thank you so much for your presentation. Any questions from the audience?
Only one comment from my part, Răzvan. You must have a preference. You must have a preference. I will hold you to that. You must have a...
Actually, I prefer dusting, so I prefer thulium.
Okay.
A really fine dusting.
My question is about your clinical practice, because you are really lucky in your hospital because you have a wide offer of laser.
Of course.
I have not this possibility, so I think that you are very lucky. My question is about your clinical practice. If you have a hardness, a hard stone, you have a large stone, what is your preference?
I think the holmium.
What?
The holmium, I think.
The holmium.
Yes.
So
I think I will choose the holmium for
you
for
choose
a
the
large,
laser depending
hard
on the
stone
characteristics of
and
the stone
with
and the
high density on the CT scan, many ounce field units. I will choose the holmium, the 150 watts from Quanta.
I have a short experience with the TF laser, but my impression is that when you want to treat a very hard stone, you have difficulties and to get a good efficiency.
Exactly.
So I think that TFL, perhaps the modification in the future is to increase the peak power, and similar to the hybrid laser. Do you have any experience with the hybrid laser, with the pulse thulium laser?
No, unfortunately not.
Thank you so much, and
Thank you.
congratulations for your presentation.
Great job. Right.
We are moving to the last presentation of this round table. What is your favorite laser in PSNL, Dr. Ahayi?
Just vandalizing everything, aren't we? Sorry for that. Do you have the... Right. So, I think my job is easy. I think you've already done my job for me already in the conversation as to what's the best laser technology. We all know the indications for PCNL. You're all familiar with it. 2 centimeter stones, lower pole stones, stags obviously, complex anatomy, those that have distal ureteric obstruction, those who have failed other treatment modalities. Now, my standard PCNL, I use a 24 French. And I use a Trilogy. I've upgraded my Trilogy. I've got a Trilogy Max now with a better handpiece. But for my mini perk, I use an 18 French thing. And no doubt in my mind, I use a high-powered laser, not TFL. I use a high-powered laser. I've had the privilege and fortune to have tried all lasers that exist out there, okay? And I always revert back to my high-powered laser without a shadow of doubt. Why is that? As we discussed already, there's so many factors we have to take into consideration when deciding what laser technology we use. The size of the track, okay? Are you doing a mini, ultra mini, micro perk, okay? Or are you doing a large stag-on calculi? That helps you to decide what sort of laser you're going to use, okay? Are you using standard track? You can decide on that. You look at the size of your stone. You look at the density of your stone in part of your planning to decide which laser technology will be available to you. Are you using a suction device for your perk? You might want to look at TFL if you're using a suction device for your perk, okay? Are you doing an endoscopic combined procedure? If you have one laser, you want to be able to move that laser and the machine fiber from the top end to the bottom end if you need to. So you might want to use one that use a smaller fiber, TFL perhaps for that, because you can move it from the upper end to the lower end if you're doing an endoscopic combined intrarenal surgery. So there's so many factors that you've got to compute before you can say, okay, this is my laser. As you said earlier, you can't say never, you can never say one. You have to be able to be versatile and say, okay, depending on the state when you're doing a PCNL, and these are some of the factors you will take into consideration when doing a PCNL to decide this is the laser I would like to use. Right, in terms of laser technology, for me, when I'm doing a standard PCNL, I still favor a high-powered laser, okay? If you're doing a mini PCNL, especially if you have suction, I would use a mini perk. TFL is slightly more favorable when you look at the literature, you look at the evidence. TFL, perhaps if you're using a suction device with you, TFL lends itself very well because you're able to dust and clear fragments out and aid that Venturi effect. So depends on the case. When you look at a publication, really, a recent publication, they say TFL is comparable, really, to holmium laser or pneumatic lithotripsy. Slightly more efficient compared to more modality, shorter disintegration, shorter operative time, lower energy requirements. It's really highest, according to this, highest stone-free rate. I'll come to my thoughts on all this in a second. A word of caution in this publication. Okay, a word of caution. Higher infundibular stenosis with TFL, at 12 months. So worth keeping in consideration, although you're able to dust faster, less retropulsion, because of the heat, you get higher infundibular stenosis. Now, those of us who've had experience with using TFL know of some of the challenges you have when you're dealing with a very hard stone. There's a thing called carbonization, where no matter what you do, you struggle. What does that mean? Over 40% of urological specimens treated with TFL, especially for uric acid resistant stone, have this charring effect, where you're not, and you see that also with bladder stones. If you try and deal with a hard bladder stone, you don't get very far. You get this carbonization, you get occasionally these sparks that come on when you're using TFL technology, especially if you're working at a very high frequency. It's a bit of a concern. Obviously, you limit your frequency when you're doing a flexible ureteroscopy because you get a lot of interference, whereas when you're doing a PCNL or bladder stone, where you can increase the frequency quite high, you do get this sparking effect and this carbonization that goes on. So keep that in mind, okay? Again, you get a lot of melting and chemical artifact, and you don't want this. This has been shown in electron microscopy, showing that TFL carries a porous effect on stones, especially when and it actually converts Bouchard stone into a Morpheus calcium stone. So it's quite bizarre that the technology can affect the composition of the stone. Again, when you increase in when you compare holmium to TFL, the carbonization, we didn't see this with holmium because it had enough peak power, but you got this carbonization effect with TFL technology. And the charring is more often really when you're working at high frequency, as I said earlier, when you're in the kidney or in the bladder. A lot of my colleagues have already told you about the technology, and the battle of technology, what do you use? For me, it's very, very simple. I use a high-power laser when doing PCNL because it has the proprietary features on there that lends itself beautifully to fragmentation and clearance. And in my opinion, humble opinion as it may be, high-powered laser is definitely the laser I would use for all my PCNLs. Thank you very much.
Thank you so much. Any question from the floor? Yes.
Just a quick question. Well, first of all, congratulations for your beautiful presentations on lasers.
You're welcome.
Very, very, very nice.
Thank you.
Now, if you were to choose for PCNL, what's your opinion about high-power holmium compared to the pulsed thulium lasers?
Interesting. I've had the pleasure of using the Thulio, the pulse laser, and I have to say it's very, very good. Very good. My initial experience with it, I've done a lot of endoscopic combined intravenous surgery using the Thulio. One of my fellows worked with Thomas Tailly in Belgium, who is just published on that, using ECRS with Thulio. So does Guido Giusti from Milan is also very keen on these two. These are two people who pushed the whole Thulio. I think it's definitely as effective, and the advantages are there. Do you need to get up to such a high peak power for stones? Perhaps not. For HOLEPs, yes. So you don't need that kind of power. And Thulio, I think it's coming in a stronger manner than we think, because you can plug it into the wall socket. It's got the advantages of TFL, but also enough for stones, enough peak power to treat all stones. So I think the pulsed thulium definitely for stones is a game changer, and it's probably here to stay.
Yes, for sure. We have it for about 1 year. We're not fully accustomed to it, but in our opinion, it's quite efficient.
Yeah.
It's quite efficient for stones.
Correct.
Yeah. Thank you.
Congratulations for the presentation.
There's another question up there.
Thank you very much for your presentation. I see you're a really big fan of high peak power laser for PCNL. For about 2 or 3 years now, we have in our clinic shock pulse, which is a novel technology from Olympus. Have you tried it yet?
Yes, I had shock pulse for a little while, and very effective. It's a plug-and-play device, and for PCNLs, it works very well. Okay, I've got the benefit of a Trilogy. I've got a Trilogy Max, which I think is slightly more efficient in the way it works. But shock pulse is still a very robust platform for stone lithotripsy. Very good.
Thank you.
Slight controversy for me here. You've all seen TFL. We've all seen the literature, and we all talk about TFL being the most amazing technology, faster, more effective. Slight word of caution. These are in the hands of experts. Okay, a lot of the work has been done in very committed urologists. I think my slight anxiety is TFL technology almost the word average sounds a bit demeaning. In a urologist who's not familiar with, pulse modulation, I think they might struggle to get the optimum out of TFL. And I think holmium is slightly easier. So a lot of the publications we read are in incredible hands, very experienced surgeons. So they're very driven, they're very motivated to give good outcomes. And I think that gives TFL quite a good reputation. But we all know in real sense that actually, when you're, the case Lorien did this morning, perfect for TFL, I'd say. And that, for me, is probably one of the indications where I use TFL, where you're dealing with a lower pulse stone, you can't maneuver out of the scope, you need a small fiber, you need a small scope, perfect case for TFL. That is probably the only. The rest of it, I would always prefer holmium.
Yes, I have a question for you, because in a standard percutaneous access, do you prefer, as you have said, the fragmentation technique with the Holmium laser, because you can generate big fragments and you can take out with a standard access. My question is, do you think, because in my opinion, pneumatic lithofilter is cheaper, is more cost effective, and you generate the same effect that if you use a fragmentation approach with the laser. What is your clinical practice? Do you choose the technology depending on the efficiency in terms of cost effectiveness? Because, for example, in my experience, if I have a big stone inside the kidney and we are going to choose a fragmentation strategy, in this case, I prefer to use pneumatic lithofilter because it's more efficient in terms of cost effectiveness. What do you think about that? Perhaps we have to choose the technology depending as well on the economic aspects.
This is an excellent question because technology continues to evolve. If I'm doing a stag-on, for example, I do prefer I use my Trilogy Max, the pneumatic effect, the ultrasound effect, the Trilogy effect of it, and the suction effect, I find very useful and efficient. Okay? If I'm doing a mini, and my mini is 18 French, I would use the laser. But I have to tell you, EMS are now about to produce their own nephroscope, 18 French nephroscope. And once that comes out, hopefully by the end of this year, we'll get to CE marking. I'll probably switch back to using the Trilogy again with the smaller Trilogy. It's very efficient. I think so. So I think the laser, currently I do like the use of laser when I'm doing a mini perk, but for my standard 24 French, I still prefer the pneumatic effect of Trilogy.
Thank you. Any question more? Well, I think that the conclusion of the session is that we need to adapt the technology to the characteristics of the patient of the study.
Indeed.
So thank you so much for all the speakers.
We will take a 15 minutes break now, not a half an hour, and at 11 we will start again. So please be back by 11. Thank you. Adică o să vă rog la ora 11 înapoi aici, da?
Artlist.io.
Putem să punem cazul? Nu e ok asta?
There is always a ray of light, guiding us towards health.
Se aude mai bine așa?
There is always
Okay, so thank you everyone for coming back from the coffee break. I hope it was good because we will have a lot of an interesting case here. So it's an 45 years female patient with bilateral lithiasis. We have a slightly issue. We'll do a PCNL. We will perform a PCNL on the right side now. And I want to show you the pictures and the particularity of this case. Here was the... Okay. Păi abia am făcut cu el. Mai departe. Încă o dată. Okay, so here is the CT scan. There are two videos. Please play it. So please look on the right side of the patient. We already mounted the double J stents, and you can see on the right picture that we will try a multiple access tract PCNL. So this is the special case. Thank you very much, and then let's go to the surgery. They are mounting the montează la varielele acum.
So, let's take a... Can you hear me? Yeah. For those of you in the room and not still at the coffee break, what do you think, looking at this lady, what would be your approach? What are the different things that we could do for her? Okay, so what would that be? The etchers. Let's have a bit of a dialogue. Does it work?
How is it? Perfect. Okay, so probably one option will be endoscoping combined intrarenal surgery in a supine manner, having a both approach of PCNL and flexible ureteroscopy. However, in this case, I know that we will do it in prone position, and I don't know.
Why prone? It's good to dialogue with you, but I want some other colleagues from the room to think and let me know what they think. Ilya, you're on the experience of the surgeon. That is correct, and that is, the answer that saves you all the time. Why this or that? Because this is what I know. This is what I do. Mm. And what would be the advantage of doing one over the other, or disadvantage?
Which can alter the introduction of the needle. But personally, I would do it also in supine because we're used to this.
Okay, so you're saying that doing a prone procedure pushes the bowel away from the kidney.
Yeah.
Okay, is this correct? Does anyone have any different opinion? Are you aware of any studies showing this, confirming it, or not? So, what do you think, Alberto? Is prone going to push the bowel away versus supine?
No, basically it's in supine. For me, my preference is supine position, and only reserve a prone position for horseshoe kidneys. Is the only indication for prone. If entonces we can reach the calyx in supine position. My favorite position is supine. I learned entonces in prone, and with the influence of Dr. Gaspari Barlucea, we change entonces to the supine position. Is Valdivia position modified by Galdacao position?
Yeah. So basically, there are studies showing that it's just the opposite. The bowel will move away from the kidney in supine rather than in prone, or at least it's the same incidence of bowel interposition between the percutaneous axis and the kidney. Dan, can you hear us?
Hear you very well, Laurian.
Excellent. Are you ready to?
Yeah, we're ready to start.
Perfect.
First, we place the patient in a lithotomy position, and after the cystoscopy, we have see the external right ureteral orifices, and on the guide wire, we have placed the ureteral access sheet. Then we place the patient in a prone position. You can see here the posterior axillary line. The camera is in this direction. Is this the line in which we should do the puncture? But we have also the ultrasound, we have the X-ray. I am going to look first with the ultrasound in order to show you how the pilocalyceal system looks before the introduction of the contrast, so the system is not dilated yet. Then you are going to introduce the contrast, and the last calyx to opacify will be the posterior calyces. And this one are the calyces that should puncture. So.
You've got a very skilled assistant again.
Look, this is
and
the
also
kidney.
A surgeon watching you.
This is the inferior calyces. Of course, that is a hypoechoric area in the
Can we
inferior
focus a bit the
calyces.
camera on the ultrasound image?
Camera. Look, this is the inferior callus, and this is prior. This is the image prior to insert the contrast.
Very good, thank you.
Now, an endourology, when come to the OR is looking for the needle. I will try to project the needle in order to see what is the best way to access and the shorter distance to access this inferior calyx. And I will have in mind this, in this area I will have to puncture. Now we are going to inject the contrast in order to see that we have a posterior calyces in this area. Hai, Mădălin, bagă substanța. Okay, bagă.
So you're using a guided puncture. So
yeah,
a guiding system that is attached to the ultrasound probe. So it's not a freehand puncture as we would call it. What size? What's the size of your needle?
It's an 18 gauge needle.
18G.
We can do also. Întoarce spre mine, te rog frumos. We can look also again with the ultrasound in order to see if this inferior calyces has any dilation present.
The previous setting where we could see the ultrasound screen and the fluoroscopy screen was perfect.
Yeah.
That is perfect. Thank you.
Okay, but
or if you change and you put the fluoroscopy as a larger image and the ultrasound as a smaller image and the ultrasound as a larger image.
They are going to do it immediately.
Perfect.
And if you are looking on the image, on the ultrasound image, this is the path that I can follow. I can check also with the X-ray in order to puncture the pilocalyceal system. So we can do a freehand directly fluoroscopically guided puncture, an ultrasound combined with X-ray, or only an X-ray puncture. It's always better to check if you are correctly in the pilocalyceal system. Eu cred că l-am puncționat, dar nu cred că ne vine nimic mare. You can do also, you can push the inferior calyx and then to advance with the needle in the inferior calyx, and then hopefully you are looking for the urine or the contracts to come out. Da. Schimbați locația. Da. Mai bagăm substanță, Mădălin? Mari, eu cred că sunt, dar nu vine substanță. Mai bagăm substanță? Da, da. Sometimes, in this type of Stencore calcula, you will not have the contrast on the needle, and it's better to check also with the guide wire. Or to aspirate.
Did you feel the stone at the tip of your needle?
No, I didn't introduce the needle in order to feel the stone, but now I feel that in this area I have the stone. Now I can feel it. Okay, I will try to puncture it a little bit to change the direction of the needle a little bit.
I think that calyx is quite posterior, although...
Nu mare. Ce naiba nu vine?
So now once you establish that there's no problem, no organ in between your needle, the skin and the stone and the kidney with ultrasound, you're happy to just go fluoroscopy guided. I think this is very much what you do, Alberto, isn't it? You basically check with the ultrasound to make sure there's nothing in between, and then most of the puncture you do it fluoroscopy guided. Am I correct?
I usually combine the X-ray image with the ultrasound.
Now we can see the contrast that is coming out from the needle. I will introduce the guide wire. People think that the puncture of the pilocalyceal system is the difficult part, but we think that the difficult part is the introduction of the needle. If you are not introducing the needle enough, you will have only the flexible part in the pilocalyceal system, and it's going to come out, the guide wire, when you are doing the dilation of the tract So it's very important to pass this guide wire and to introduce it very well in the pilocalicial system. Mare nu merge mai mult, se oprește.
But this may not be possible sometimes when the stone completely occupies the calyx.
Yeah, this one is a stiff guide wire. We can change with another guide wire in order to see if it's better to... Da, un ghid negru. In order to see if we pass this guide wire on the ureter or at least in the upper calyx or...
Which guide wire do you use in this case?
First we have used, look, this guide wire has already passed on the ureter, if you can see it.
Yep.
Yeah? And then we are going to, we are leaving the guide wire in place. We are not using a safety guide wire, but we are going to make an incision of the skin large enough for the dilator to pass very easily, because sometimes if you are not doing this type of skin incision sufficiently large, you will have an obstacle here. And we have to do the incision large enough. This is an ethanol guide wire that we are using right now. But for PCNL, in most of the cases, we are using a very stiff guide wire. This is the fascial dilator that we are introducing first in order to, because this fascial dilator has a tip that permits dilation of the calyx.
And what size is that fascial dilator? The first
It's
one?
16 French.
So there's a one-step dilator, 16 straight into a... Okay.
Yeah. And then I will have the unplugged sheets with the dilator inside, which is 24 French.
So it's a
you can see
two-step.
also that the contrast is coming
It's
out
lovely.
on the
Very nice,
dilator.
yes.
We have to check. If it's not coming out,
it's too far in.
Our help is going to inject some contrast in order to be sure that we have contrast on the dilator. And then we are going to introduce the unplugged sheet. That is a clear Petra 24 unplugged sheets.
So any comments on how far do you push the dilator and how you make sure that you're not causing more problems, especially if you use a nitinol wire, a flexible nitinol wire, I mean a softer bodied nitinol wire? And
you
also
have to be very prudent not to kink the guide wire.
Exactly.
And to introduce the dilator, rotating it. As you can see, I rotate the unplugged sheet with the dilator inside when I introduce it. Now I'm going to leave the guide wire in place, and I'm going to introduce the nephroscope on the guide wire.
So I can see your guide wire is down the ureter, but do you bother to try and secure it down to the bladder?
No, because
Not always.
It's bothered me to have a guide wire during the procedure.
Correct.
And I'm going to extract it.
Correct.
When I see the first calculi, I'm going to extract the guide wire. I don't need it, but I have to be very careful not to leave the pilocalicial system. Nu văd nimic pe ecranul respectiv. Așa. Look, can you see the calculi?
Yep, beautiful.
Can you see my urine that is coming out?
Excellent access.
It's perfectly clear. Da. Putem să dăm C-arm-ul. We are removing the C-arm because I can't see anything on the device. Now I'm pulling back the nephroscope and I'm putting this
the cap
on the unplugged sheet, and we are going to attach also the aspiration system, because we don't need the aspiration system. You will see that the shock pulse will aspirate all our fragments, but especially when we are fragmenting the calculi with laser, this aspiration sheet is helping us in reducing pressure.
Okay.
The urologists that are performing PCNL in supine will say, do you know that in prone, the unplugged sheets will stay more close to the spine and will stay vertically?
Yes.
Is my unplugged sheets vertically or
no, not
it's
at all.
horizontally?
That's very impressive. it's quite. It's a nice lateral position. It almost looks like a supine PCNL.
It's like a supine PCNL because I have my ampla sheets parallel to the floor. Can you see it? There is no difference between supine and prone when you are looking to the position of the ampla sheets. Because the urologists that are performing supine PCNL, they are saying you have a increased pressure due to the fact that your ampla stays perpendicular to the... It's not this way.
No.
We are using an aspiration sheet. We are using a device that is aspirating the fluid. So our pressure, you will see that we have a collapse of the pylocalyceal system when you start to aspirate. So I don't see any advantage from this standpoint.
I mean,
between supine and PCNL.
Correct. I mean, one of the most difficult parts, most urologists are scared of or worried about the puncture. Your puncture was very slick, very effective, combination of fluoro and ultrasound. The ultrasound, you use it to look at your track, or you look at to make sure there's no colon, there's no spleen?
Yeah, it's very important to avoid the puncture of adjacent organs and the colon.
Yes.
So, and also the ultrasound is guiding you about the inclination of the needle. When you put this probe on the patient and we have this device, this guiding device, you know exactly what angle you have to introduce the needle.
Correct.
So it gives you a lot of information. But we are always checking the puncture with the fluoroscopy.
So what's your plan with these small stones now?
Now we are going to introduce the shock pulse probe, and then we are going to change to the trilogy probe, and we are going to start to fragment.
Come out a bit more.
You will see that there is a collapse of the pylocalyceal system due to the low pressure that we have. The shock pulse is using ballistic and ultrasound fragmentation and is also aspiring the fragments. The trilogy works on the same principle, but depends what you prefer.
Just to
look.
This back. Yeah, I was going to say, can I move it back a bit more so we can see?
At the beginning, I have only these small fragments.
Just to move it back a little bit. Okay, I can stand there. Sure.
What about the size of these fragments? Are they going to go through the sheath directly without?
You don't wear lead?
No, it's okay.
Are you sure?
Without suction? I think they're quite small. They could pass through.
Now I'm going down. You can look also at the Venturi effect.
Exactly, that may be more efficient.
Cine mi apasă, Mădălin? Cine mi apasă puțin pe apă? You can see the Venturi effect. Even though I have a 24 unplugged sheets,
you can do it.
You can see that all the fragments can come spontaneously on the clear Petra sheet that I have.
Excellent.
Look, I don't have to fragment. All the fragments are coming spontaneously. Now I'm going to, after I aspirated all the fragments, I will try to look for the renal pelvis. But first I have to look for all the small fragments in order not to leave something behind. Așa, Alința, mai apasă puțin pe apă, te rog. If it's not coming out spontaneously, I will use the shock pulse. Mari, uite, mai am pe ăsta și nu vrea să iasă. Poate îmi dai shock pulse. Uite, am altul care a ieșit. So I have the majority of the fragments are coming out spontaneously. Now here I have larger fragments that I have to fragment. Mari, cred că poți să închizi aspirația puțin. I will close the aspiration on the unplugged because I have a lot of aspiration on the shock pulse.
So we see you're using the shock pulse. Is that your preferred lithotripsy device? We see you're using shock pulse. Is that your preferred one?
Yeah, so but also trilogy. We can prefer also trilogy. Yeah. When we have harder stone, I think that the trilogy is better. And we prepared both devices in order to see the difference between them. This is a harder stone. I didn't make a hole in the stone yet, but in a few moments you will see that.
I can see your assistant is irrigating from below.
Yeah, I can irrigate from below in order to increase the pressure and not to have a totally collapsed pilocalicial system. Mari, parcă nu merge cum aș vrea eu.
You don't use a pressure
Acum
pump?
merge. Sorry?
You don't use a pressure pump?
Sometimes we have pressure pumps, but
you can give him a break.
Yeah.
Give you a break if you use a pressure pump.
We have pressure pumps, but we are not using it.
Okay.
You can see that in 2 minutes I made a huge hole in this calculi. I think that is the largest fragment here. And immediately you can see how the probe is advancing into the calculi. And you have to see that I will put the probe on the mucosa, and you are going to see there is no damage of the mucosa when I will try to aspirate only the mucosa. So you're not going to have any bleeding, anything as adverse event after using shock pulse or trilogy.
Can you comment
this is
a
the
bit
upper
on...
calyx. They are telling us that only in supine position you can access the upper calyx. It's not this way. By lowering the diameter of the scope, you can see that also in prone position, especially how we are using it, parallel to the floor, we can access the upper calyxes. So I have a very low pressure, I have a very good visibility, I can puncture any calyx compared with supine, in which if I have to puncture a secondary calyx will be much more difficult, especially if it's an upper calyx. What are the differences? The only difference in supine is that the anesthesiologist will love you if you are doing in supine. So we can still have some debates between urology and...
What about endoscopic combined procedure?
We don't... Lay.
ECRS.
Lay. If you are using shock pulse or trilogy and it's aspirating almost everything,
yes.
and you have a prolabation of the pilocalicial system, what the help we're going to see?
Fair. Good point.
So I'm wasting a lot of time by using laser in a calculi like this one. So a friend of mine will help me with the flexible, but on the other side I'm losing a lot of time. I'm gaining time with these devices. Mai dăm și trilogy puțin. I will change with trilogy in order
What
to
were
see
your
the difference.
settings for shock pulse?
I have two settings. I have a pedal. In one side, I can use mostly pneumatic, and on the other side is combined mostly ultrasonic, and on the other side is combined pneumatic with ultrasonic. Now I'm going to introduce the trilogy probe in order to see the difference. I think that the trilogy is better for harder calculi.
Correct.
But for
soft one, it doesn't make any
soft
difference.
one, it doesn't make any difference. Yeah.
You're spoiling us. I don't think I've seen any live surgery with both shock pulse and trilogy in the same.
And we have Julio sitting waiting, and we have the TFL as well. So he is spoiling us.
So you can see that on trilogy, the pneumatic effect is pronounced compared with the shock pulse. But this is useful when you have very hard calculi. A calculi like this, a Stackor calculi, I can resolve in 30 minutes only by using the shock pulse.
Can you show us a bit the trilogy's screen so we can comment a bit on that?
Can we get close?
Look, I can move a little bit the amplitude in order to...
So I'll talk to you about the settings on the trilogy. We've got frequency of 12 hertz and a ultrasound of 80%. Impact factor 70. Is it on hard or soft or in medium?
It's sort of a
medium.
Yep. Okay. So this is one of the comments about versatility. Yeah.
I was planning for this patient because this patient has a bilateral Stackor calculi to perform a prone PCNL on one side and a supine PCNL on the other side. but I don't have the time in 1 hour because I have to reposition the patient. Maybe I'm going to do it in the when you are eating, but no one will see the puncture and the positioning, and it's no advantage for the people that are
Any tips
coming
and
to
tricks when you are using these devices, Shock Pulse and Trilogy? Because we can see that you press a bit and then you come back, you press a bit, you come back, you probably rotate a bit the probe if it gets stuck into second. Can you make any comments on this?
Laurian, I can't hear you very well because it's noisy. It's noisy. The Trilogy is noisy compared with the Shock Pulse.
So
I didn't heard anything from what you said.
Any comments on or some tips and tricks on how you use these probes, both Shock Pulse and Trilogy? You are pushing a bit and then relax and rotate a bit the probe so you don't get buried into the stone.
I'm pushing and then I'm relaxing a little bit. I don't want to do a lot of pressure on the calculi. Look, I put also the shock pulse back. The aspiration of the shock pulse is it's better comparing with the Trilogy. I have these fragments that are migrating in the upper calyx.
From there.
I didn't want, in particular, for this to happen. Since I have, but if you fix the calculi on the mucosa, you can fragment it much more easily and to aspirate the fragments. You can see that I'm with Trilogy on the mucosa and nothing happens. I don't have any bleeding. I don't have any damage of the mucosa. Thank you. And I can reach the upper calyces in the prone position as well in the majority of the cases. So I don't trust the studies that are saying that only in 20% of the patient you can reach the upper calyx and in supine in 80% of the cases. Do you know that Mario Sofer studied at the University of Medicine in Bucharest, and he published an article saying that only in supine you can reach the upper calyces in the 80% of the cases. But as you can see, the only problem
that is if you do 80% of your cases supine.
But you can see that the only problem that we have is the collapse of the pilocalyceal system. This is the only problem, and I have introduced a 24 amplat sheet. I could have introduced a 22 also, but in this case, I wouldn't have this kind of irrigation, and the collapsing will be worse. So I will retreat a little bit the amplats. I will use also the Venturi effect and the aspiration. Mari, poți să-mi dai drumul aspirație? Look, all the small fragments are coming out spontaneously. I have here another piece that I will fragment it because it's large enough in order not to pass. Mari, mai dăm puțin shock pulsul? In order not to pass spontaneous. Poftim?
No.
Hai să we can try also the Trilogy only with ultrasound in order to see the difference.
Now, while you're doing this, I'm just going to make a quick comment.
I'm going to find it immediately after the removal of this. So now I'm using the Trilogy, but only only with the ultrasound settings.
A quick comment about the difference in how ballistic is achieved with these devices. So with shock pulse, the ballistic or the impact effect is basically a special modulation of ultrasound. That's why you also don't hear that noise, that tuk 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 noise when you use it. So that's why you're right. It may be that it's a difference when you tackle very large, very hard stones. With Trilogy, the ballistic effect is more of a true ballistic. It's a piezoelectric effect, and this is where you hear that noise. Now, a question for the younger guys in the audience. What would be the frequency that you would need for ballistics? It was already mentioned, if you heard.
Uite, Mari.
More or less.
Fragmentele
So
astea.
what would be that frequency? Who can tell me something? I'm not going to ask Ilia again, but I'm going to ask Ilia to point to someone who's more or less your age and experience.
So I asked my name. I heard my name, but I didn't hear the question.
No, Ilia. No, it's not Leia. It was Ilia, which is one of the young specialists here.
Apologies.
It's from Republic
No
of
worries. I
Moldova,
know.
Ilie.
I'm not going to ask you this question because you know all the answers, Leia.
Okay. You can see I don't have enough inflow of water. So you can't tell me that I have a increased pressure and about the pilovenous reflux and about the pyelonephritis in prone. You can argue about that. It's clear that I don't have pressure at all in the pylocalyceal system. I have also a problem because
suction is too strong.
The suction is too strong.
Now you can adjust it. You can lower it down. So, for ballistics, you would have something in the range between 10 and 20. So normally it's up to 12 hertz, 15 hertz, means 15 times
We are
per
not
second.
complaining. We are all.
But do you know what do you need for ultrasound? How do you achieve fragmentations, ultrasound fragmentation with these probes? What's the frequency used there? Any guess? Let's guess if you don't know. 1,000. Okay, let's bid.
50 ml syringe.
Have you seen any?
Who says more or less?
50 ml syringe. Yes.
Have you seen any blood until now?
No, not at all. It's beautiful access, very clean.
We are doing PCNL or what? We are puncturing the renal parenchyma or what we are doing?
No, your access is spot on.
No, you've made the comment many times, Dan. It is impressive how these devices are basically protecting the urothelium. So you can touch the urothelium. There's nothing. The only problem is when you push too much because it's still.
You don't have to push too much because you can perforate the renal pelvis. So you have to. It's better to extract the fragments like this. Look, they came up spontaneously. You don't have to pull the probe. You only need to fragment the calculi. You are going to the amplats on the calculi, and this is a large one, but most of them are coming out spontaneously. You don't need to do dusting. You don't need to aspirate them.
Excellent demonstration.
They are coming out spontaneously. So you don't have any argument for supine compared with prone.
So
of course, the anesthetic, that's why we are doing also in supine, because there are fat patients with cardiopulmonary diseases. Mari, dă drum puțin la aspirați. Look, I have some fragments that are stuck here in the amplacid. Mari, are you pencil? I aspirated to a lot of fragments. I will use a grasper now
to finish off.
So, Leia, from your perspective, what's the difference? You're in the room, so you feel the room.
Well, absolutely. Firstly, the access was beautiful, really nice puncture. I quite like the combination of fluoro and ultrasound. Looking at the lithotripsy effectiveness, I must say shock pulse seems to be more effective on this occasion.
Because it's not a very hard calculi, that's why.
So shock pulse seems to be more efficient at lithotripsy than it is Trilogy Max. The challenge with Trilogy Max is you, again, trying to find the optimum setting. Shock pulse is often just plug and play. With Trilogy Max, you've got to adjust your suction, your pneumatic, your ultrasonic, the frequency. So there's a bit more work required, whether it's soft stone, medium or hard stone. So you've got to adapt the Trilogy to suit you. But in this particular case, in terms of the stone density, I think shock pulse is doing a fabulous job.
I have the problem that a larger calculi are stuck here on the aspiration part.
Big syringe.
Yeah.
In the big syringe.
Because I aspirate very large calculi, and at some point they are stuck in here.
Yeah, you need to flush them or suck them out.
Look, they are coming out. But
is the suction on the
probe?
On the amplats.
On the Cleopatra?
Yeah.
That's on, is it?
Yeah, it's on. Right now it's on. look, all the fragments are coming out.
You see, that's why you need the sheath a bit lower. I can see Alberto smiling.
But the sheet is parallel to the floor.
I'm joking, my friend. I was just teasing you.
Yeah, I am doing also in supine PCNL, so. Yeah. But I don't like sometimes, because the kidney is moving a lot, especially in a very skin patient, and when you are puncturing the lower calyx, it's not a very nice sensation when the kidney is moving towards the.
So. When we're teaching residents and fellows, we always say they have a safety guide wire.
Yeah, but
you don't. Do you find the safety guide wire gets in the way?
Yeah.
Of your maneuverability.
I finding in getting my way, and my mobility is decreased by using these safety guide wires. But I have to be very prudent, and prior to remove all the fragments from the calyxes that I puncture, I will place an antegrade double J stent. This is my ureteral catheter. I have two possibilities. I can use a grasper in order to retrieve the ureteral catheter, to place a guide wire until it reaches the bladder, and then to extract the ureteral sheath, and then to place the double J antegradly. This is the safest way. But I can do also, I can look directly at the pylo-ureteral junction and place a guide wire from here, an antegrade manner. I can use both ways. I will show you how we are using with a grasper. Okay. Because I don't think that... Mari, dă-mi o pensă, te rog. I will show you how we can retrieve the ureteral catheter with the basket. Vezi, Mădălin, să nu fie legată de sonda, da?
So I can see that you're planning to put a stent. What's your exit strategy overall? Just a stent and nephrostomy, nothing?
I don't think that I need a nephrostomy. I think I will look with our C-arm in order to be sure that I'm stone-free. And after placing an antegrade double J stent, I will retrieve the unplugged sheet in the calyces in order to see that I have no residual fragments, and in majority of the cases I'm not going to leave a nephrostomy tube because there is no need for a nephrostomy.
Do you do a trachoscopy on your way out? Do you look?
Yeah, I'm doing also in order to see that I don't have the colon or anything else. But I have done the puncture also using the ultrasound.
Yeah, so you know you're spot on.
So we are going to introduce this guide wire on the ureteral sheath.
Where's your catheter?
The C-arm will look at they are retracting the catheter.
All the way out?
Yeah, all the way out. Where I'm going to look at the bladder in order to see, dă mai jos, Mădălin, in order to see, nu văd C-armul din cauza imaginii monitor.
Any questions from you guys?
This is the ureteral catheter. Now the guide wire is in the bladder. Yeah. I am sure I didn't force the nephroscope to look at the pylo-ureteral junction because I would have forced it in order to pass the guide wire. I don't have any perforation. No. So this is the proper way in order not to
put too much torque on the kidney.
Yeah. If you are putting torque on the kidney, you have bleedings. Yeah. So now I am extracting the ureteral catheter, and then on the nephroscope I will advance with the double J stent. I will leave the upper part of the double J stent on the renal pelvis, and then I will remove slowly the unplugs.
Nice technique.
Because I can have some fragments that are...
And your nephroscope is what size?
It's 90 in French.
90 in French, so it's a MIP.
On a 24 unplugged sheet.
Daniel.
This is the junction.
Daniel?
Da? Yeah.
Congratulations for the surgery. It has been a great demonstration. I have a question because in this case I think that is not necessary, but do you usually check the collecting system with anterograde flexible nephroscope when you finish the surgery?
Sometimes when I think that there are fragments left, yeah, we can use the cystoscope or a flexible ureteroscope in order to check. But I will perform an X-ray in order to be sure that I don't have fragments, residual fragments. And I always can introduce a cystoscope on this ampla sheet. Now I'm looking on the X-ray in order to see, you can see the double J stent advancing into the bladder. Now I'm going to remove the pusher, and with the nephroscope I'm going to push in the renal pelvis the double J stent.
Nice.
Now I'm going to have an X-ray. Mai spre mine puțin. You can see the ampla sheet. Așa. You can see the ampla sheet that is.
Nice,
I don't see any residual stone,
nice,
but now I'm going to check also with the nephroscope.
Yeah.
By removing a little bit. Look, I don't. Here I have a very small fragment. Mai dăm puțin shock pulse sau spensă sau. Da, I will use a grasper in order to see how you can retrieve a fragment with a grasper.
Dan, thank you very much. You did an amazing job. Very, very good surgery, very neat. You showed everything. You
Next time I will
explained.
perform it in supine. In order for everyone
Come on,
to
you
be
just
content.
showed that prone PCNL is still a very, very good and safe way to do PCNL. So congratulations, and congratulations to everyone in the room. Well done.
Thank you. Look, Leif, this is my access point, and I can come out progressive.
So no bowel there for sure. Excellent. So we can change to lectures now. That was a I'll be a bit here closer to you because I can't see over there otherwise. First of all, again, thank you for being here. You've had the chance to witness and to watch a very nice procedure expertly done by Dr. Radavoy. You've seen the puncture, it goes so naturally and so smooth and quick. Look, it's not like this. You have to do quite a lot to have this relaxed way of doing things. But it shows that it is possible, and it's a very, when it goes well, it's a wonderful procedure. But like any surgery, when it doesn't go well, things can get quite complex. So what I'm going to talk to you about, and there's no space to walk here. Well, I'm going to try to talk to you about today relatively quickly, hopefully. So when there's like 2 more minutes, let me know. Is that okay? Because I want to be in time. Is about smaller scopes. And you saw me using today a 6-point French scope. 6-point French is basically the size of a stent, actually, one of the thinner, the stents which are on the thinner part range of stents. We have smaller stents, but we very rarely use them. We use 6, 7, or sometimes 8 French stents. 6.3 French scope is basically the size of the stent, and it should go up. But even that scope didn't go up. So you need to know what you're doing, and you've seen how the problem was sorted. Anyway, let's move to what we are talking about today. This is probably the picture that for at least in the last 5 years, everyone, every lecture, there was no meeting. Sometimes I was joking, and if I was in a meeting and someone didn't put it, at the end I just put a slide with it, just because you can't just ignore it. And it's something that you have to remember always. This is how the ureter may look or can look. It's the famous Olivier Traxel study with grading of ureteric lesions. This is what you can do to a ureter, from just a bit of scratch to quite severe damage. And why? Because of the anatomy. Oh, sorry. So, let's see. No.
and this should come on. The anatomy of the ureter. The ureter is not a tube. It's not a simple thing that is continuously straight and so on. It basically, when there's no urine, there's no lumen. It's completely empty, and it doesn't have the same size, the same position, the same thickness all the way. Even the thickness of the ureteric wall is different in different parts, and that's very important when you do a ureteroscopy. When actually you pass something through this organ. It's basically an organ. It's not a tube. Don't think of it as a simple tube. These are some nice reconstructions of how ureters look like anatomically, and we all know the problematic parts: the PUJ, the pelvic ureteric junction. The other one, the crossing of the iliac vessels, where I've seen scopes bended. I've seen, looking at my residents, and you see that the scope goes like this while the ureter is here. And immediately you feel like your stomach goes up here, and they don't realize where is actually the direction of the ureter. And obviously, I would say the tightest part, more or less, is where, especially when, let's think a bit, even if I take one extra minute. Who can tell me when this would be probably the tightest part of the ureter? In what particular case? Give me an example. Correct? When you overstretch the bladder and you don't know what happens, why can't I manipulate the scope anymore? But when it's quite common that this is a tight ureter. Think, BPH, muscular bladder, that part gets very tight. Very large BPH, when you have a J-hooked ureter, that part is horrible. And this is where you most likely will perforate, and your guide wire will go submucosal. Okay, what is the normal ureter size? And that is a study which is not so old actually, but they basically stated that 3 millimeters should be considered the upper limit of normal size for a non-obstructed ureter, okay, a standard ureter. What does it mean? It means, and this is a very nice CT scan following the ureter down to the bladder, and you see, it's not a straight line. It goes like this, and you push a rigid scope through it. If you look at a surgeon pushing, an experienced surgeon pushing a rigid scope, is never this movement. The movement is always like this. If you look at their hands up and down, it's always like this, lateral, up, down, and so on, trying to follow all these things. And that's why I did choose this video. So now we were talking about what? 3 millimeters. 3 millimeters means in French, maximum 9. Yeah. So it's approximately 9 French altogether. 9 French is relatively okay, but our access sheets are larger on the outside. So it's 10, 12, 12, 11, 13, or even larger than this. Again, the very nice image, because this is when the problem usually happens. Either when you push the ureter, the semi-rigid ureter, where you shouldn't, or these are images after usage of access sheets. Yeah. And this is a classification, another one, a pulse classification, grade 0 to 5, where we have the complete transaction of the ureter. I'm not going to insist on this, but it's good for you to know. And the clinical significance is basically a decision tool. What do you do if this happens? And it's quite reliable because it has a high inter-rater reliability, and it allows us to standardize. So when you report a ureteric lesion, probably this is a good way to report it so everyone knows and talks about the same thing. But we also know for a very long time that actually access sheets, though we, initially we used them, we overused them, then we start to not use them anymore, and now we use them again because we have fans, and that really changes things. So
what was the most important thing for all of us? Because initially when we introduced access sheath, it was, oh, you can take fragments out, you can basket, you can pass the scope much easier. No, the big issue, the big thing that the access sheet provides is, and this is from Ralph Kleiman from 2003, okay, 23 years ago, is a safe intrarenal pressure. Keeps the intrarenal pressure low and allows us to prevent the big problems that come with high intrarenal pressure. Now, a few tips and tricks about also the initial part, because I told you about the submucosal thing. What do you dilate? What do you do? And this was a nice one from Olivier. Basically, don't force. What we showed today was exactly what the message. If you see a very tight ureteric orifice, it's better to say, okay, I'll put a stent and wait, rather than cutting, stretching this and creating. I'm not saying there will be a stricture, but if there is one, it's non-defendable. Why did you force? It doesn't mean that if you can't go through it. You can. You'll put a second wire and then you'll force your scope and so on. But all that means force, means stretching, means rupturing, and there will be a scar. How tight that scar is going to be, God knows. Definitely not you as a surgeon. So that's a nice slide. Now, ureteric access sheath. As I said, efficiency, whatever, but the most important thing to me is the reduction of intrarenal pressure. Risks, injury, failure of placement, and obviously the cost. It increases the cost of the procedure. How much force do you use? You saw me stopping. I stopped with a semi-rigid ureteroscope. I didn't push farther because I felt that it is the force that I used, it's too much. And believe me, it's a long process until you actually know and safely know. And the big danger is initially when you don't know, then it's a kind of a long, safe period when you know, and then there's another period time in your professional experience after years of doing it when you feel, I'm an expert. What does the expert do? Goes the next step. So you start again to push a bit more than compared to what you previously felt it was safe. And this is when a lot of things happen again in the hands of experts, because we always push a bit more than the normal guys. Okay? So that is dangerous, but at some point you'll have to do it because you'll get the cases that no one else was able to sort, and you have to try. But that should come much later in your career. And this is a nice study, I think, again, Prof. Kleiman, and it's quite old as well. I don't remember exactly when it was done, showing the force that is required to push the sheath. And it's quite logical, it's simple, but even simple things need to be require proof or evidence. The larger the sheath, the higher the force. Okay. The problem is, if you look here, in many cases, applying more than they established there, 4.84 newtons, resulted in ureteric injury in pigs. Okay, forces more than 8 newtons routinely resulted in a pulse score more than 3, perforation with less than 50% partial transaction. You would say, okay, especially those of you who worked on pigs, they don't have the same ureters. Actually, the pig ureter is horrible. It's much more difficult than a human ureter. And I have, not in this, I have some nice slides where I show how tortuous is a pig ureter. So not easy. But this is good because it gives us some idea of what does it mean. And obviously, the larger the sheath, the larger the chance or the risk of ureteric injury. That means, if you have a large sheath, you have a higher chance to cause permanent damage. What is then the link here? It's very obvious. The problem is that in 2019, and that is only 7 years ago, there's no updated study, worldwide, 12-14 was still the most used access sheath. And that is by 70%, not like 51 to 49. So people are still using, urologists are still using very large sheath. Though in 2019, we had already scopes small enough to pass through smaller sheaths. But everyone felt that, it's an easier access for the scope. And that is true, because this is a very nice picture that I took. And you see, why do we actually need smaller scopes? Because you can't have a scope that barely fits to the sheath. If you have it, you lose exactly what you actually, the main function of the sheath. There's no space, there's no outflow, you're doing nothing. You're just basically increasing the size of your scope. So you need space in between. So though a little view would fit in a 10-12 sheath, you see there, but it will completely occupy the sheath. You can force it through. Why would you do it? There's no benefit whatsoever. So you need a space in between. You need a difference. Yep. And what would be a good difference? My good friend Emre Şener from Istanbul did this study that was quite a few years ago as well. At that point, the thinnest scope was a 7.5 French scope. And he very nicely established that a good rate would be when you have a 10-12 sheath, so not the large one, but a decently small sheath, and a scope that is actually lower, smaller. Well done. Congratulations. Thank you. And the scope that is actually smaller than 8 French. 7.85 like the Olympus fiber optic scopes, or 7.5 like the Storz or the other scopes. So that is a good compromise and remains a reference. You have enough space to operate safely. That's it. Now, what do we have currently? We have the reusable scopes, which remain a bit larger because of durability, obviously. Yeah. And the fiber optic scopes, when we talk about reusable, they will always be a bit thinner. Why? Quick response. I'm not going to ask Ilya again. Where is Tudor? Tudor, there you are. Tell me, quickly. Why a fiber optic? You can easily build it smaller than a thinner. Yes, but why? Because of the chip on the tip. Okay? So if you want to put a durable chip on the tip, you can't use exactly the same chip that you use on a single use. So you have to use a chip that is a bit more larger, stronger. So that's why there are some Chinese ones, though, I must admit, but none of the big companies are building reusable scopes that are thinner than 7.5 French for the moment. So this is Olympus, this is Wolf. Wolf has a scope with 2 channels. Obviously that comes with another sacrifice. You have 2 channels, but you have a large scope. Okay. Now it's very difficult in the current context in nowadays to justify anything that goes above 8. I mean, no one will use it. So this is the size, and when you see 6.0 /8.8. That's another thing. When you buy a scope, when you look at a scope, they will try and say, oh, it's a 6.5 French scope. Really, all the way, or just the tip? Because they say, yeah, the tip, but the tip is like 2 centimeters, and you have to pass the rest of the scope. So the size of the scope is the largest point of the scope. And that is the size. Yeah. And Storz, and this is the single use from Wolf over there. And then Storz, I think, is the next slide. You've got 8.5 for the Flex XC, which is the digital, 9 French for the single use. Come on, guys. And the Flex X2, which was for a long time the reference in terms of size of reusable scopes, that was 7.5 French, and it was a good scope. But obviously things have changed, and now we have a completely different situation. But before we go there, let's talk a bit about this ratio of endoscope to sheath diameter. That was a very nice Chinese study from 2024. They established that obviously for pressure reasons, you need a 0.75 ratio when you use a standard sheath. What happens when you use a suction sheath? You need a larger or a smaller ratio? Quick answer, come on. Smaller, so you can decrease the distance from the pressure perspective. Why? Because it's not just gravity, it's suction. Correct. So they say 0.85 from the suction perspective, yeah, from the intrarenal pressure. But obviously, if you want to get fragments out, then things change. So I still prefer the very thin scope that I use, 6.3, and I used an 11-13 French sheath. Why? The patient was pre-stented. Okay, and the sheath went reasonably up to the point where it didn't. Normally, if the patient wasn't pre-stented, I would have definitely asked, and I did ask, for a 10-12 French. Yeah. Now, what did they say? They say that the stone fragment size, and that's a different study, with standard is you can take something out that is approximately 0.25 millimeters, sorry, but with suction. And you've seen the fragments that I took out, or at least the people in the room saw that I took out much larger fragments through that sheath. And then that gets you to the point where we say, oh, perfect, lasers, we need dusting, we need... Do we? Because sometimes I would rather fragment and go quicker because I know I can take out larger scopes. So if you really know your tools, if you have a small scope, relatively large, so 11 French axis sheath, you can change your lasering technique. You can go from very fine dusting to less fine dusting. How do you do that? Probably Leia told you. You adjust what I call the hammer. You know, what's the hammer? The hammer is the energy of the laser. Forget frequency, has nothing to do with the size of the fragments. It may or may not speed the process. The hammer is the energy, joules, and that's why I want you to remember, you know, J from joules is almost like a hammer. That is what you need. Big hammer, big fragments. So you increase the energy. Small hammer, small fragments, you get dusting. Remember this, it's a good analogy. Good, I'm gonna jump because I'm late now. I feel I'm late already. And this is the new scenario. This is the new world. And this new world is not gonna go back. Like the price for oil, you know, at the station is not gonna go back anymore.
In this era, it's very important about what laser we are still using. If it's a holmium, it's a
Exactly. Exactly.
It's still important. Maybe 2-3 years ago it was important. But why we are debating about laser? Because in PCNL and flexible, we still need to fragment the cartridge, not to perform dusting.
We are debating about lasers because you need to know your tool. You need to know what you use and how to use it. And you need to understand what's the pros and cons. If you don't know that you can't use, and you say, oh, this laser is not good. No, it's you who don't know how to use it. But we have to finish. So this is the scope that I'm using on daily basis in my theater. And most of the comments were, okay, so it's a thinner scope. It won't have enough force to bend the sheath. You've seen it with your own eyes. And it wasn't a small sheath. It was an 11-13 French sheath. You can bend it. It has enough force. Obviously, not for a second operation, but it's a single-use scope. Good. And why do we need a thinner scope? I think I can almost rest my case here. But this is how they evolved very quickly. These thoughts, and I love them. Okay, I've been working with them for so many years. In 2018, we were telling them, you need a thinner scope. And then they had been working on on the single use for many years, and then it's still 9 French. While this Chinese company, in 4 years, went down from 9 French to 6.3. So this is being very rapid and flexible and understanding and adapting to what we actually need. You can see the difference in size with the same access sheath, what's the space in between, and what size of stone fragment you can pass alongside. And guys in the room saw that at some point I stopped. There was nothing in front of my scope, but I stopped and I came back with a scope. Why? Because I've had these large fragments that already went down, and where the sheath was curved, they got stuck. And I feel this with the very fine movements that I do with the scope against the sheath, because I always control the sheath and the scope. One of the reasons, one of the main mistakes, and I hate to see this, I see experienced surgeons doing live surgery and they do this. It means that you don't understand what you're doing. You need to control the sheath all the time. So my hand is on the sheath and on the scope. In the same hand, I control the sheath and the scope, and I feel everything, and the sheath doesn't go in or out without me knowing. So I felt a bit of resistance when I advanced the scope. It means that the fragments got behind me, just came out, and at some point you start seeing them and they come out. Okay, you saw that in theaters, you didn't see it in Now, there are other companies building thin scopes, and you'll see next year, or this year actually on the market, other 6-point-something French scopes, even a 5 French scope from HugeMed as well. But this is a red pine pediatric synchrotry, a shorter scope made exactly for kids. And I'm just going to show you this video, but it's good because it's a real case that I did. And this is an 11-13 French sheath. And yeah, look what happened. Yeah, there it is, exactly there. So it went up sheathless. I'm going to stop here. Thanks for your patience. Hope you enjoyed it. And if you have any quick questions, we can take them. Otherwise, we'll have to move forward. Anything you would like to? Thank you. Any comments? Done.
Going from dusting to fragmenting is not such important. Of course that you have to know the peak power, of course that you know what laser to use, but the difference has shrink between lasers.
Correct, done. It's good until it's good. When it's not, it's not. Yeah. And I'll give you an example. What if I couldn't pass the sheet?
In this case?
So then what? So then I can fragment?
No, you have to dust.
If I don't know how to dust with my laser, or my laser can't dust, then what's going on? So, yeah.
In particular cases,
yes,
yeah.
but not always.
Not always.
Okay? Good. Let's move to the next one.
If you want to stick to the schedule, then I would be the first one to debate.
The roller coaster. You have it all.
Now, interesting topic, isn't it? Are advances in ureteroscopy making PCNL disappear? And again, I would start with a disclaimer. The disclaimer would be, are the guidelines, or of course, the urolithiasis guidelines enough nowadays? Because they still rely on the largest diameter of the stone, right? Is that enough? Well, in my opinion, it isn't. It isn't to choose between percutaneous tragic, percutaneous access, or retrograde access. And we're going to have to shortly or briefly discuss about the advances. Well, we have fans nowadays. We still don't use the conventional ureteral access sheet anymore since we have the fans. We have, of course, improvement in the laser machines. All have been discussed here already. So we have the latest pulse-thulium. We have the high-power holmium YAG laser. We have the TFL. We pretty much have everything. We don't have the magneto yet. But, well, I don't think that's an issue, at least not yet. We have all sorts of disposable, single-use, chip-on-the-tip scopes. We also have inbuilt suction scopes. We already have the automated pressure control system. Well, all these advances actually have led to the extension of the indication of retrograde intrarenal surgery. They actually, basically diminished all the range of complications that we might have encountered before. But what does the literature say nowadays? Well, we have all sorts of clinical trials. We have all sorts of articles, meta-analysis, and everything that's been published starting about 15 years ago. Well, not here in Romania, but all around the world. We have this nice meta-analysis that was comparing RIRS with percutaneous nephrolithotomy for treatment of renal stones of more than 2 centimeters. So just, well, above the guidelines, so to say. So 8 trials, about 600 patients involved. Well, this trial, the first one to find that were no significant differences in stone-free rate. No infectious complications difference between IRRS and PCNL. Hospital stay slightly shorter for IRRS, together with longer, of course, operating time for flexible ureteroscopy. Another Cochrane database systematic review published about 3 years ago, comparing again the percutaneous access with retrograde surgery for treating renal stones in adults. Well, an average size of the stone between 1 and 4 centimeters, many patients, over 4,500 patients involved. Basically what the study found is that through PCNL you have a 10% more chances of being stone-free. Basically, in terms of major complication, probably it had little or no effect in terms of major complications. And the key findings of another study that was published 1 year ago in BMC Urology, comparing flexible ureteroscopy, but this time combined with negative pressure suction sheet, with percutaneous nephrolithotomy, but for treating this time Staghorn stones. A single-center study was done in China, actually, with pretty much 2 comparable groups, about 40 patients each. What they found out is that PCNL was associated with shorter operating time, lower costs, and combined with the suction sheet, flexible ureteroscopy resulted in less complications. I mean, less blood loss, shorter hospital stay, and also shorter lithotripsy times, and that's interesting. Another interesting aspect that the study revealed is that the retrograde intrarenal surgery had fewer complication chances and reduced risk of renal injury, together with diminished inflammatory response from the patient. This translated into lower C-reactive protein and procalcitonin levels after the surgery. Well, just to sum up, while PCNL offered shorter operative times for them and also lower costs for patients, at least in the Chinese system, the flexible ureteroscopy combined with the suction sheets, well, it reduced the lithotripsy duration and hospital stay time, it decreased the intraoperative blood loss, it improved stone clearance, and of course, it lowered the post-op complication rates. And also, it revealed that you might have lower risk of getting renal injury during and after the surgery. Another nice study published 2 years ago in European Urology Focus by Vinit Gahar and Professor Somani, and they actually come up with this nice question: could the use of a flexible and navigatable sheet, basically a fans, could be a potential game changer in flexible ureteroscopy? Well, 25 centers worldwide were involved, about 400 patients. You can all see the results in the table. A high chance of success for grade A plus B stone-free rate, actually about 97%. And after multivariable statistical analysis that was centered on the stone volume, well, it revealed that a stone volume of over 3 cubic centimeters was significantly associated with lower probability of grade A stone-free. And again, regarding our discussion about lasers, TFL use was slightly associated with a higher probability of getting a stone-free patient. But of course, the limitations included the lack of a comparative group. Another nice study published recently, well, about 5 years ago, again comparing IRS with PCNL for pelvic stones, this time more than 2 centimeters. Well, not that many patients, but still comparable to groups. Well, the main conclusion of the study basically was that IRS displayed acceptable efficacy with less risk of bleeding that would require a blood transfusion. And of course, it could be applied to patients with large renal stones. So again, above the indication given by the guidelines as an alternative to PCNL with less chances of getting complications. Another analysis that was recently published in the International Urology and Nephrology Journal, this year I mean, pretty large one, more than 60 studies on more than 7,000 patients. And again, comparing the two methods, PCNL had, of course, a significantly higher stone-free rate compared to the flexible ureteroscopy, but it also had significant chances of getting complications. And of course, higher degree of post-op hematuria. Again, using a microperc might have helped in reducing the risk, but still, even with microperc, you get more chances of bleeding than with flexible ureteroscopy. And in conclusion, well, although PCNL has demonstrated a superior stone-free rate, at least for renal stones over 2 centimeters, but also for under 2 centimeters, that's quite logical. It was accompanied by a higher risk of complications, longer hospital stay compared to the retrograde alternative. And the last study I want to mention during my presentation, that was again published 3 years ago by Esteban Emiliani. And the question was, the prime time for flexible ureteroscopy for large renal stones is coming. Is percutaneous nephrolectotomy no longer needed? And that's a good question. It's quite the question we're trying to address right now, right? And just to sum up all the information, because it was quite a large meta-analysis. Well, based on all the current studies, the flexible ureteroscopy has emerged as a promising alternative to PCNL, also for the management of kidney stones of more than 2 centimeters in their largest diameter. They have low complication rates, acceptable stone-free rates, not necessarily better than PCNL, but acceptable. And it can offer patients a less invasive options with pretty favorable outcomes, I would say. But what the most important conclusion of the study is, according to at least to my opinion, is that, well, all these data are insufficient to compare the standard PCNL that was performed for a long period of time with the new technology, flexible ureteroscopy. And that's our problem today. We don't have a PCNL or microperc or mini-perc or ultra mini-perc compared to the new technology we can use nowadays in flexible ureteroscopy. So it might be beneficial to perform large center studies, prospective randomized controlled trials to make and to try and make a good answer for this question. And just some cases I want to show you. So this, well, multiple ETIAs on the left side, approximately 3 cubic centimeters of volume, well, an average Hounsfield unit of more than 1,300. Previously stented, fans of 11-13 used, single use 7.5 French, high power laser used. We're not going to go through all the case because we don't have time for that. Basically, it ended up with a visual stone free after 88 minutes of surgery, with a total laser time of about 40 minutes. And by visual stone free at the end means I've checked all the calyces and no fragment was there. So again, above the indication in the guidelines, still a stone-free patient at the end. This doesn't mean it's not possible. This means that statistically you have less chances, but still a good rate of success. And this is another case just to try and illustrate what I said before. So just the history of the patient, surgery for the an average ureteric stone on the right side, about, well, that was in 2024, 4 years before anyhow. Ultrasound revealing an inferior calyx left kidney stone of about 12 millimeters. Of course, the patient was scheduled for surgery back then on the other kidney. He didn't follow up on his appointment. 4 years later, a colic on the right kidney. He had a stone eliminated, but at ultrasound we found a stone about 4 centimeters in the pelvis, well, with a high probability of having a staghorn stone. And that's the CT I've performed back then. And you can beautifully see a staghorn stone on the left side. This is the 3D reconstruction. Well, I tried to measure a volume. Still, I skipped this part. I've appreciated about 15 cubic centimeters. Later on, I've come back and actually calculate the volume, 11.3 cubic centimeters, but with a mean Hounsfield unit of 600, so soft stone. Judging by the aspect from the CT, most probably with the wide right on CT, a uric acid stone, most probably. So what I've done next, of course, after discussing with the patient, we had to decide between PCNL and retrograde intrarenal surgery. After a thorough discussion with the patient, explaining all the complications, potential complications, risk, and everything, we've decided to go with retrograde intrarenal surgery. Well, I've started the literacy, of course, with fans in place. 30 minutes later, the renal pelvis was free. And in my opinion, this is the most important part in any surgery you might want to undergo, to free up the renal pelvis at first, at least. Well, many minutes later, well, he was okay with small residual fragments in the inferior calyces. Well, total operating time of a bit more than 1.5 hours, but the most important thing in this case would be the exit strategy you're going to apply afterwards. So what should I do next? Will I wait? Will I schedule the surgery? Will I schedule the patient for another surgery, or will I wait to see what happens? And because I knew from the beginning, most probably we're facing a uric acid stone, I've decided to mount a magnetic stent inside, just in place. Administered some urine alkalinization therapy, and scheduled the patient back for a CT 6 to 8 weeks after the surgery. And he was stone-free eventually with the urine alkalinization therapy, and I've extracted GG stent in an office setting. Now, just to give a quick glimpse on what's happened in our hospital in 15, 16 years' time. Well, in 2010, we had about 12 to 15 PCNLs per week. Now we have between 3 and 5 PCNLs per week. In 2010, we had no flexible arthroscopies. Now we have between 20 and 25 a week. So these are the numbers for our hospital recently. And in my opinion, before the conclusion, just a quick glimpse on what I want to say next. Well, usually approaching the stone is based on what I call the PSA, and not the prostatic specific antigen, but the personalized stone approach. You should always take into consideration the stone dimension, whether you're using volume or cumulative diameters or area or whatever you're using, but not a single dimension of the stone. You should take into consideration the stone location, the density, and always the patient's characteristics, his preferences, and always the informed consent. So if you have a compliant patient that you explain that's compliant, and you explain all the risks of the surgery to him, what you're going to do, he might and for sure he will be your partner for this tailored treatment. in what comes next. So as a conclusion, well, I would say that the technological advances in ureteroscopy, and especially the development of disposable scopes, suctioning technology, so the fans, are, I wouldn't say they are making PCNL disappear, but are significantly changing the role of PCNL. Because it's still hard to say that it will disappear, as for sure we do not have enough evidence to directly compare the two methods with all the technological advancement they've been through. But actually, these technological advances are shifting the middle ground cases towards less invasive flexible ureteroscopy. Still, PCNL, I expect to remain a critical, distinct tool in endourology for, of course, the management of complex stone. And in my opinion, the future is actually seen as a combination rather than a replacement by using the EEC-IRS, of course, which merges PCNL and ureteroscopy just to get the optimal results for your patient. Thank you. Questions? For sure. Okay, thank you.
Where's the... We lost the... Can we put it on? Am I not in? No? Excellent. Dr. Rascu, thank you very much, and thank you all for your patience. This is the last bit before your lunch break, so we'll try and keep it as concise as possible. So when I was asked to do this debate, or are advances in ureteroscopy making PCNL disappear, and I've been asked to discuss against it. When I was asked, I did ask who I was debating against, and Dr. Rascu was who I was told. So I went looking for this man. I went looking for him online, and I found this beautiful picture of him. And I thought, it's very elegant, very precise. He also has a look like Mona Lisa. You can't just quite work out what he's saying, what he's thinking. I went to deep dive. I had to go to a counselor to see what... Very expensive picture. Very expensive, beautiful picture. You can't read his mind. And I tried to read him. I went very close to try and understand, and I came to a conclusion. He loves PCNL. That was what he was saying. That's why he looked so happy. And even when he stood in front of you today, it was clear that that was what was going through his mind. He loves PCNL. So the conversation really is about miniaturization. And we've talked about miniaturization in flexible ureteroscopy. Okay, you heard Dr. Dragos tell us about it, smaller scopes, etc. PCNL has also evolved, okay, from mini to micro mini to ultra mini PCNL. So we've also got smaller in our PERC track. So the advantage of a flexible ureteroscopy is mitigated or not necessarily required because you can PERC using a very small track. Then there's the conversation we're having currently in the Endourological Society. Temperature, pressure, what does it mean? What does it all mean? And what do we understand by it? Yes, there's some publications looking at what is ideal. The critical temperature is 43, but you need to maintain it for over 120 minutes, which we don't when we're doing a ureteroscopy. We talk about pressure. What sort of pressures do we need to be able to maintain? Again, we don't really know. I mean, we've got some publications, company-induced publication on intrarenal pressure. We don't really know. So are there any big benefits, really, in flexible ureteroscopy, knowing the pressure, knowing the temperature? We do not know. Now, there's a conversation of this. You all know direct insuction scopes, the whole suction flexible ureteroscope. Various publications on that saying the advantage of this is there. But when you really look at them and you take a deep dive into what the scopes are, you know to suck stones, you need a big working channel. You know to clear a big channel, you need a bigger scope. And that's not ideal for your patients. When some of these scopes are 11 French, 11.1 French, in order to have a big enough working channel. 3.6 is the ideal channel. That's what we use now. And I guess TFL lends itself very well to technology in terms of dusting. But not everyone has access to TFL lasers. So you use your normal holmium laser. Yes, you can dust beautifully with the holmium at the right settings. But the whole idea of this really is you need big working channels, which means you need big scopes. Even Poussin, who initially came up with a small scope, have pivoted and gone for a 9.2 because they knew they needed a 5.1 working channel. That is a big scope, and itself has risk of complications associated with flexible uterorhinoscopy. So let's not forget this. This has risks. Let's dish the dirt on this, okay? You need larger working channel. You need to deliver irrigation at such high volume. And what does that do? Increase intrarenal pressure. Do you want that? No, you do not want that. And the whole intraoperative optimization, when you're doing flexible uteroscopy, as you saw Dr. Dragos this morning, he was very meticulous, very precise. He didn't start laser till he knew he had good inflow, good outflow, beautiful optics. Then why do you want to ruin it by putting contact of the ureteroscope on the urothelium to suck the fragments? And what does that do? It affects your visibility, clear in present danger. Suction, decompression of your system also causes petechial bleeds. So I have my doubts really about the whole flexible uteroscopy. Now, the case for PCNL, it's the gold standard. It remains the gold standard for stones more than 2 centimeters. Below 2 centimeters, I will give in. If you look at the EAU guidelines, below 2 centimeters, I think it's fine. But really, more than 2 centimeters, PCNL offer the most optimal, most efficient ways to clean stones. A good study looking at proximal ureteric stones, okay, 1.5 centimeter, 2 centimeters, proximal ureteric stones, looking at a stone-free rate of PCNL versus retrograde intrarenal surgery. There is no comparison, 90% to 70%. Operative time shorter for PCNL, complication rate comparable. Okay, another study looking at that also demonstrated similar outcomes. Looking at stones with larger stone burden. If you've got a 4 centimeter, 2 to 4 centimeter stone, you can't compare. Although you showed a very beautiful demonstration of a uric acid stone, a stagon, congratulations on that. You can't compare the stone-free rate in large stones compared to flexible uteroscopy. So I'm not so sure. And looking at this study, retrograde intrarenal surgery could achieve comparable rate, but requires multiple treatments. And don't forget about the morbidity for the patients having ureteric stents for a duration of time. It is a morbid situation not to have. So for smaller stones, harder stones, stone-free rate about the same. Now, let's not forget about endoscopic combined intrarenal surgery. You're able to do this quite capably. We presented on this quite a long time ago at EAU, a number of years ago, passed the ball. We've presented on it in Texas not so long ago at the AUA, that the fact that endoscopic combined intrarenal surgery reduces the risk for secondary puncture when you're doing PCNL. So you have fans, we've talked about that in detail. You have this for flexible uteroscopy, very effective, direct suction scope. Please do not forget for PCNLs, we also have access suction sheaths for perks, which again improves the efficiency of your stone-free rate and stone clearance. There are different devices out there, from mini for ultra mini, the old Venturi effect. Again, this is work in progress. So PCNL, I can guarantee you, is not dead. Other considerations to take in mind, if you want to clear a patient in a single session with a significant stone burden, I think everybody in this room would choose a PCNL, I think, okay? If you've got a patient with a single stone. If you want to reduce the need for repeat procedures, I don't know what your health system is like. In my health system in the NHS, the patient's been on the waiting list for a year. So if they come in, they want one treatment, it's going to treat them. You don't have time to bring that patient back for a second procedure. So you would do whatever is humanly possible in your power to get that patient stone-free, one operation. Okay? So retrograde intrarenal surgery, it says, according to literature, has a shorter hospital stay. I've been conducting now for the last 5 years supine PCNLs as day case procedures. We have no beds in the hospital in the NHS, so you've got to be quite innovative in getting your patients home the same day, irrespective of the size of the stone. Even for staghorn calculites, I'm very concerned. As long as the access was good, they haven't bled, they've got somebody at home, they go home, but we call them the next day, make sure they don't have fever. If they develop fever, they come straight back into hospital. There's no fever, there's no hematuria, and they're fine, they stay at home. So we have a protocol in place for day case PCNLs, which ensures the patient can go home the same day, and it's safe for the patient. Okay? Again, PCNL has a higher initial stone clearance rate and can lead to faster overall recovery. So we mustn't lose sight of that. We think by offering a patient a 2-session flexible ureteroscopy is good for them. Don't forget about the morbidity associated with them having a ureteric stent. Some people can't go to work when you put a stent in them. So the idea of waiting 2 weeks or 3 weeks whilst they have a stent, they're off work for 3 weeks. I would rather do a PCNL 1 session, 2 or 3 days off work, and they're back to work. So I think PCNL has the advantage of getting patients back to work quicker. So, in my opinion, PCNL remains indispensable. For large stone burden, for complex staghorn calculi, although you gave a beautiful demonstration of a uric acid stone being treated with a flexible ureteroscopy, congratulations with that case. For hard, dense stone, cases where multiple stone clearance is required in one go, and you have to get the patients treated in one day. I.e., if a patient's on anticoagulants, you've stopped their warfarin or their apixaban, and your physician, cardiologist says you have one time only, you will perk that stone. Quite gladly, and I'm sure a lot of you would do the same, especially someone with significant comorbidity, where all your colleagues have optimized the patient to get them ready for that one operation. You're not going to do a flexible ureteroscopy on a large stone. You would take your time, make sure the patient's optimized, and you would offer flexible ureteroscopy. So, question we were asked, PCNL, it is not disappearing. In fact, it is evolving. There's no doubt it's evolving. The fact we're able to miniaturize our track, the advent of supine PCNL, the whole idea of having suction devices helps. And we've talked a lot about laser this morning, having pulse modulation laser and the efficacy and the benefits of that. If you're keen on tubeless, you can do tubeless, not necessarily true tubeless, but no nephrostomy and leaving some kind of drainage. I'm not a fan of complete tubeless. I think it's vanity. It's good to have some drainage, at least for 24 hours. And endoscopic combined intrarenal surgery. So my conclusion, Dr. Rasko, I think we work together. You do a flexible ureteroscopy, and I do a perk. Indeed. Thank you very much. Any questions, please, before we break for lunch? There must be questions.
Yeah.
Question.
We won't go for lunch unless there are questions.
Yes, questions.
Quick question.
Yes.
When you have a complication like a bleeder, do you use tranexamic acid?
I must say, routinely, we don't in our practice. There's some surgeons who do that for a lot of the PCNLs. We always leave a urethral catheter at the end of the procedure. Even when you've done a perfect track, you look at the patient in recovery, and if the color, you're not happy, they go straight down to radiology for CT angio immediately.
So no interoperativity?
No, I don't give. Okay. I don't put any Fluorosil. We don't put anything there. We also don't give them tranexamic acid. I look at the catheter. I leave a urethral catheter after every perk, and I go to recovery periodically just to make sure the color is clearing. If I find it's a bit bloody, and the patient looks hemodynamically stable, I'm fortunate I work in a teaching hospital. We have intervention radiologists. They're down for CT angio. They're embolized immediately. Immediately. Questions? Can we hear from the younger audience, please? We're not going for lunch until we hear from you. What does it say? You've all been listening very patiently. Please. So you mentioned some, sorry, I didn't quite hear that. Somebody who's got hepatitis, right? Mm-hmm. Okay. We'll still perk them. We have enough disposable equipment to perk, okay? And single use. Hypertension, yes, correct. Correct, you're absolutely right. You've got to watch those patients. And how did you treat them? Did you do a flexible uteroscopy or perk on them?
I have one case recently which had time-based calculi.
Okay.
And went into sessions of flexible ureteroscopy. But now it's another question. For Steinway stone, Dr. Rashku, what kind of equipment would you use from the ureteroscope, access sheet, laser, and
If I would like to reduce the risk of bleeding in a Stackor calculi, I should use a 14 French amplat sheet. I can introduce on a 14 French
Quite
amplat
safely,
sheet
very
with
safely.
a nephroscope
Yeah.
and a larger 5-word laser of 500,
What? Yeah, 5. Yeah.
which is much more effective comparing with a flexible ureteroscope.
Correct.
And the time needed for fragmentation is reduced considerably.
There are options, and this is what I find quite interesting in this debate, that PCNL, just like flexible uteroscopy, is evolving. And we are continuing to learn, we are continuing to adapt our technology to suit our patients. And as you said, PSA, patient-centered approach.
I believe that's the key. So just a quick comment. You know that the negative pressure sheet was first developed for the PCNL, not for the flexible ureteroscopy.
Indeed.
This means at some point someone worried about the intrarenal pressure with the miniaturization of the devices. I guess that's crucial.
That's crucial.
So,
there's a great study by Hugo Naglia looking at that from Tyrol region, looking at intrarenal pressure in mini perks.
Mini PCNL was actually evolved.
Can I have a microphone? Sorry, you were about to say something. We were taking a question from you.
Was actually developed by two guys, okay? And it's Udo Nagilev, the Austrian guy. So the problem with mini PCNL is that it is very, very quickly turns into a closed system.
Yeah.
Okay? So when you press the scope against the sheath, it's a fully closed system. And there are studies showing a higher incidence of sepsis, urosepsis post mini PCNL because of that, because the surgeon forgets that this is a closed system and also abuses the Venturi effect, takes the stone fragments out. So that's for the younger guys to remember. This is, you need to know your tools, and you need to know what are the pitfalls, what are the dangers, so on. And this is why they started to think again more about pressure in, and then they developed the suction sheath that is always open in a way, or even puts additional.
And you have also to have at least 4 French
difference.
between the diameter of the nephroscope and the amplat sheet in order to have the backflow. You saw that I had problem with
Indeed.
the fact that my pilocalicial system was collapsing.
Decompressing all the time. Yeah. So what I do in that scenario is I actually have a pressure bag, and so that there is some pressure in the kidney, which helps you to a bit of distension, especially in supine where you don't have the ability to distend, and your amplat sheath is either horizontal. You do need some pressure. So I use a pressure device just to give me a bit of pressure. Questions?
Just one quick question. So, in urolithiasis, the more you operate, the more you come to the conclusion that stone-free rate is quite, I don't know how to put it. It's a relative concept.
It is.
100% stone-free rate after the surgery is quite utopic, at least in my opinion. Just a quick question. So let's say you had my case. I do agree it was challenging to go for retrograde intrarenal surgery in that case. I do agree it's challenging. Maybe it's off the guidelines, so not to discuss about that. But how would you have seen a PCNL in that case?
I think that's a complex case, and that's why I congratulate you particularly on your success with this case. It's a branching staghorn calculi. It's uric acid stone. Looking at it, you probably need 2, maybe even 3 punctures, so it wouldn't have been straightforward. But sometimes, depending on, I use the word luck and anatomy, you might be able to maneuver, if you come by the upper pole or the lower pole, you might be able to maneuver to get from the one pole to the other. And if that helps you a lot, then that still leaves the interpolar region, which I suspect you might need to do a second track. So when you showed the case, I'm like, oh gosh, it's not possible. But the fact that you were able to achieve good success with a flexible ureteroscopy shows the need to have to be versatile and flexible and to be able to think on your feet. Which would have taken longer, difficult to say. Yeah, I can't say there's a right or wrong. As you know, I think PCNL and flexible ureteroscopy are meeting, and that's why endoscopic combined intrarenal surgery is becoming the vogue, where you can have two lasers. During the EAU, you might have seen in surgery that happened in my hospital, they were working simultaneously. Someone with a laser or trilogy from above, someone with a laser from below. So simultaneous effectiveness. I'm not sure how good that is for the patient, I have to be honest. In terms of intrarenal temperature and pressure, I don't really know. But it did speed up procedures.
So far it seems to be good, at least in here in our hospital.
Correct.
It seems to be fine so far. We don't have many cases of this, but we're improving. Yeah, indeed.
Good. Thank you very much to both of you. That was a very nice debate, and I really love that we had contribution from the room. We'll go to lunch, but before that, just the last comment. I love ureteroscopy, flexible ureteroscopy, lasers, and so on. I also love PCNL, and the message here, both of you have very nicely, I hope, was delivered, is that these are complementary procedures. It's likely that ureteroscopy will take a bigger bite out of the PCNL realm, but overall PCNL will remain. And think of just one thing. What do you do when there's actually no antegrade access? And we all know enough cases, especially in tertiary centers, that come to us, there's no way to go from down below. Even for a small stone, then you still have to do a puncture and a percutaneous access and a PCNL, mini, standard, or whatever. With all this, thanks again for your patience. Thanks for being with us so far today. We are inviting you to have lunch, but 2 o'clock sharp we start. Thank you very much.
Thank you.
Thanks a lot.
Guys,
can we have a faculty picture, please, now, because Leah is... Can we have a
optimal outcome. First, I would like to express my alignment with my colleague from UK, with Lai, that the PCNL is not that is still relevant. According to EAU guideline, it's still the first line treatment for larger stone, larger than 2 centimeters in diameter. And also the EU is saying that small instruments tend to be associated with a significant lower blood loss. This, despite considerable progress in flexible ureteroscopy, PCNL continues to hold a pivotal role in modern stone management. This sustained relevance is largely driven by the recent technological innovation, particularly the introduction of miniaturized instrumentation, which have been associated with a marked reduction in intraoperative blood loss, as well as overall procedure morbidity. A one-size-fits-all approach to accessing PCNL, it's rather like using a single key for every lock. Ambitious, but ultimately a recipe for trouble. In reality, no two PCNL are alike, because no two patients are alike. Each case demands a tailored strategy guided by patient-specific factors such as BMI, the presence of cardiovascular pathologies, the presence of scoliosis, as well as stone characteristics, including volume, branching complexity, and location. Together, this variable dictates the optimal access and tract planning, reminding us that in stone surgery, customization isn't a luxury, it's the whole point. To begin, I would like to address the enduring debate surrounding the optimal patient positioning. Historically, the first PCNL was performed in 1976 in prone position. In 1987, however, Valdivia introduced an alternative approach, the supine PCNL. While this technique has been gradually adopted over the years, particularly across Europe, it has yet to achieve widespread acceptance within the global urological community. A likely explanation lies to its natural reluctance to depart from established practice, since conventional prone PCNL consistently delivers high efficacy with acceptable low morbidity. According to the EAU, PCNL performed in both position in prone and supine are as effective as supported by a comprehensive review and meta-analysis of the current literature. Beyond a reduction in operative time, largely attributable to the avoidance of patient repositioning following ureteral catheter insertion, there is no compelling evidence to suggest a significant difference between prone and supine positioning with respect to hospital length of stay, non-lower calyceal puncture rate, number of puncture attempts, rate of tubeless procedure, mean postoperative blood loss, and transfusion requirements. The stone-free rate are high in both positions, reaching 82% in prone and 80% in supine PCNL. Notably, a particularly pronounced advantage in favor of the prone position emerges at 14 days postoperatively, with a stone-free rate of 92% versus 84% in supine. This difference may be in part explained by technical factors such as the more frequent use of multiple access tract in prone procedures. Further insight is provided by the CROES PCNL global study, which analyzed more than 5,800 consecutive patients treated over a 1-year period across 96 international centers. Compared to supine cases, prone position patients were more likely to undergo upper pole access and to require multiple puncture. At 30 days postoperatively, the stone-free rate remains significantly higher in the prone group. Achieving safe and precise percutaneous renal access remains the cornerstone of successful PCNL. The prone position offers a direct posterior approach to the collecting system, theoretically allowing access to a posterior calyx through broader avascular plane, thereby minimizing the risk of significant parenchymal bleeding. Notably, comparative analysis of CT urogram have demonstrated shorter trunk length and a greater number of potential access sites in favor of prone position.
In practical terms, this translates into a broader surface area available for percutaneous entry, facilitating more medial and versatile access trajectories, an advantage that may prove particularly variable in complex stone scenarios. If you were landing a plane, would you opt for a narrow, slightly wobbly runway or a wide, stable one with plenty of room for error? Most of us would prefer the latter, and in many ways, this is exactly what the prone position offers in PCNL. The prone approaches provide several technical advantages, including a larger surface area for puncture, a more generous working space for instrument manipulation, unrestricted instrument excursion, and the flexibility to establish multiple access tracks when needed. In essence, it gives the surgeon both room to work and room to adapt. By contrast, the supine position comes with certain inherited constraints. The flank is not fully exposed, which can make initial access more technically demanding. Access to a posterior calyx is not always feasible, and upper pole puncture can be particularly challenging. In the supine approach, puncture is typically performed more laterally along the flank. You see that in prone is performed also laterally, resulting in a longer access tract. This has important mechanical implications since the point of which the access sheath enters the kidney functions as a fulcrum, and the greater the distance between the fulcrum and the skin, the more limited the maneuverability of the sheath's distal and within the collecting system. Another important drawback of the supine position is increased renal mobility during percutaneous access and tract dilation, an issue that is particularly pronounced in patients with a BMI of less than 25. Clinically significant kidney displacement may occur in up to 1/3 of supine PCNL cases. While this does not appear to adversely affect overall success of or complication rates, it is associated with prolonged fluoroscopy time. Several factors have been identified as contributing to significant renal displacement, like including lower calyceal puncture, longer renal artery length, and reduced perirenal fat. Supine PCNL has been shown to enhance endoscopic access to the upper calyx via a lower calyceal tract. So far demonstrated that the upper calyx can be reached in up to 80% of supine cases compared with 20% in prone position. You saw that is not a rule, that we can access also in prone the upper calyces. However, this apparent advantage can be effectively mitigated in the prone approach, where direct upper pole access is technically more straightforward and can be achieved with a more medial trajectory closer to the spine. Supporting this is a large review of 16 studies and 8,500 patients evaluating the performance and safety of superior calyx access in PCNL. Beyond facilitating access to the renal pelvis and to all the calyces, while achieving favorably stone-free rate with fewer puncture and complication, superior calyceal access offers an important mechanical advantage. It aligns the nephroscope with the longitudinal axis of the kidney, enabling more efficient and controlled intrarenal navigation. In particular, single-tract approaches that rely on repeated manipulation of the nephroscope to access multiple calyces may place significant stress on the calyceal neck, predisposing to mucosa injury and subsequent complication. Even within the Valdivia global study, the prone position demonstrated superior stone-free rate while maintaining a comparable safety profile. This ultimately brings us back to a fundamental question. If the prone approach consistently delivers equal safety, greater versatility, and in many cases improved efficacy, what compelling advantage does the supine position truly offer? In supine, patient reposition can be in prone, patient reposition can be time-consuming, and anesthesiologist generally favors the supine approach, as airway management and cardiovascular monitoring are more challenging in the prone position. This is particularly relevant in obese patients in whom the prone position may compromise pulmonary function, increase peak inspiratory pressure, and adversely affect gas exchanges, including reduction in saturation of the oxygen. The supine position may reduce the risk of both central and peripheral nerve injury and lower the likelihood of thromboembolic events by avoiding compression of the inferior vena cava. It is particularly advantageous in patients with cardiorespiratory comorbidities, as intraoperative monitoring and anesthetic management are more straightforward in this position. Of course, that ESIRS in Galdacao modified supine position allows for comprehensive exploration of all calyxes, leading to improved stone-free rate and easier residual fragment removal. The supine position offers distinct hydrodynamic advantages during the ESIRS, facilitating increased irrigation efficacy from the ureteroscope while allowing gravitational descent on the ampla sheet of the residual fragments. ESIRS integrates PCNL with retrograde intrarenal surgery for the management of complex upper urinary tract calculi. By combining antegrade and retrograde technique, ESIRS can reduce the need for multiple percutaneous tracts while enhancing stone clearance within a single session. The most widely adopted configuration is the Galdacao modifying supine Valdivia position that we are using in our department too, which facilitates simultaneous and antegrade and retrograde access. However, this approach is not without limitation. This includes a restricted option for puncture, particularly for upper pole access, where there may be an increased risk of visceral injury. Additionally, suboptimal distension of the collecting system and the accumulating of air bubble may compromise endoscopic visualization. In contrast, the prone split leg position offers several technical advantages. It allows for a broader, more versatile puncture field. Under the influence of gravity, posterior calyces and proximal ureteral stone tend to migrate towards the renal pelvis, facilitating the retrieval. Moreover, the shorter trunk length and the feasibility of establishing multiple access points in the prone position may further enhance procedural safety and flexibility. Here is an example of ESIRS in supine position. I want to show you how once the shock pulse is activated, how quickly the pilocalyceal system collapses once all the water is suctioned out. So, how can your friend help you with the flexible ureteroscope if the pilocalyceal system is collapsed? You can't see anything from beyond if you are going with faster devices like shock pulse. The ESIRS technique also requires dual surgical setups, including lithotripsy and endoscopic system, two imaging display, and the coordinated effort of two experienced surgeons. In settings where such resources are limited, an alternative approach, PCNL combined with antegrade flexible endoscopy, offer a pragmatic and effective solution for the management of Stackor calculi. Notably, the flexible ureteroscope, compared with the flexible cystoscope, provides superior maneuverability due to its greater distal deflection and smaller outer diameter, allowing for improved visualization across multiple calyces, particularly those aligned in parallel. Clinical data suggests that PCNL assisted by antegrade flexible ureteroscopy is associated with higher stone-free rate, a reduced need for multiple percutaneous tracts, and shorter operative times when compared with standard PCNL. The incorporation of flexible nephroscope into PCNL has been shown to significantly enhance stone-free rate in the management of Stackor calculi. Flexible nephroscope reduces the need for excessive instrument manipulation, thereby lowering the risk for bleeding and associated complication. The cornerstone of any successful PCNL lies in establishing safe and precise access to the collecting system. In our practice, we favor a combined guidance strategy utilizing both fluoroscopy and ultrasound. This dual modality approach enhances accuracy while simultaneously minimizing the risk of complication, offering the benefit of complementary real-time imaging. You know that the renal artery typically bifurcates into an anterior and a posterior branch, creating a relatively avascular zone between this territory known as borderline. This anatomical plane represents the optimal target for renal puncture, as it minimizes the risk of vascular injury. Access via posterior calyx is generally preferred, given its association with reduced bleeding risk and more favorable alignment of guide wire advancement into the ureter. Ideally, the puncture trajectory should be transpapillary, thereby preserving calyceal integrity while optimizing both safety and access efficacy. You know that there are two techniques, the bullseye technique and the triangulation technique. The ultrasound puncture employs a needle guidance system mounted on the ultrasound transducer to ensure a stable and precise puncture trajectory. The transducer is positioned on the patient flank, just inferior to the 12th ribs, along the posterior axillary line. On ultrasound, the first calyx visualized is typically a posterior calyx, making it an ideal target for safe access. A key advantage of this approach is the ability to identify potential interposition of such structure like the colon between the skin and the kidney, thereby significantly reducing the risk of visceral injury. Once the target calyx has been clearly identified, the patient is instructed, not in a patient with general anesthesia, but in those with a spinal anesthesia, the patient is instructed to maintain apnea to minimize, in order to minimize renal movement, and the puncture is performed under real-time ultrasound guidance. After a successful calyceal entry, fluoroscopy is subsequently utilized to facilitate guide wire placement and to guide sequential tract dilation. You can see, Lai also presented the diameter of the sheets and the nephroscope that we are using nowadays, and we tend to lower these diameters. I would like to present you a movie right now. Sorry.
Second video, the kid...
Sorry. I will try to...
The cornerstone of any percutaneous renal procedure is secure and accurate access to the collecting system. In this case, puncture is performed with the patient in the prone position. Guidance is achieved by combining fluoroscopy, which provides the general direction of the needle, and ultrasound, which allows continuous real-time visualization of its advancement. This dual modality approach maximizes precision while reducing the risk of complications. Once the optimal trajectory has been defined, puncture is carried out under ultrasound guidance, targeting the desired calyx, and in this example, a lower posterior calyx. Careful attention must be paid to maintaining the correct needle orientation on ultrasound throughout the puncture. As the needle traverses the fascial planes, even minor deviations in its course may result in difficulties during subsequent steps, particularly kinking of guide wire after the needle is extracted. On the fluoroscopic image to the right, a right-sided double J stent is visible, showing significant calcification of the distal loop. Such findings are not uncommon in patients with indwelling stents that have remained in place for an extended period. However, the presence of incrustations increases procedural complexity. After advancing the needle into the targeted calyx, successful entry is usually confirmed by the spontaneous outflow of urine through the needle. However, if no efflux is observed, gentle aspiration with the syringe should be performed to verify intrarenal placement. Another reliable method of ensuring that the puncture needle is correctly placed within the pilocalyceal system is to inject a small amount of contrast under fluoroscopic guidance. This should always be done gently and in a controlled manner. If the needle is properly positioned, the collecting system will opacify promptly and uniformly, outlining the calyces and the renal pelvis. Once access to the desired calyx is confirmed, a guide wire must be advanced through the puncture needle. This step is essential for maintaining the tract, as it effectively seals the access pathway. By securing the guide wire in place, the risk of losing the puncture tract, a serious and feared complication, is virtually eliminated. Teaching Pearl, always confirm free guide wire mobility within the collecting system under fluoroscopic or ultrasound guidance. Resistance or restricted movement may indicate malposition and should prompt immediate correction before proceeding. Tract dilation is performed progressively using either sequential polymer dilators or single-step metallic dilators. In this case, polymer dilators were selected as they provide a more controlled and less traumatic dilation compared to the more aggressive metallic counterparts. Teaching Pearl. Whenever possible, match the dilation method to the clinical context. Polymer dilators are preferred in standard cases for their gentler tissue handling, while metallic dilators may be reserved for situations requiring rapid or forceful access. Once tract dilation is complete, the nephroscope sheath can be safely introduced. In this case, an active aspiration sheath is employed to minimize intrarenal pressure and reduce the risk of infectious or hemorrhagic complications. Through this sheath, the nephroscope, or alternatively a resectoscope, can then be advanced to perform the planned procedure. Teaching Pearl. Active aspiration sheaths not only control intrarenal pressure, but also improve visibility by continuously clearing debris and irrigation fluid. In this second video, the kidney is approached in the supine position, a technique that presents distinct challenges compared to the prone approach. Careful attention should be given both to patient positioning and to the puncture trajectory, as the skin to calyx distance is typically longer and access is technically more demanding. Percutaneous entry is performed under combined fluoroscopic and ultrasonographic guidance, allowing clear visualization of the needle's orientation on fluoroscopy and its progressive advancement on ultrasound. A valuable technical pearl in the supine setting is the use of a diamond tip puncture needle. Its superior penetrating capacity enhances precision, reduces the risk of deviation when traversing fibrous fascia, and ultimately facilitates a safer, more controlled access to the collecting system. Did you catch that? This demonstration also includes another tip for the instances when you have a difficult access: the double guide wire technique. Inserting 2 guide wires during access and dilation will allow you to insert the Amplatz sheath or aspiration sheath in a safer manner. 1 guide wire will stay anchored, and it will be kept for safety in case the tract is lost during surgery.
We'll go further with...
In situations where ultrasound-guided puncture proves difficult or even impossible, such as in the absence of upper urinary tract dilatation, a freehand fluoroscopic puncture may be performed. However, this technique requires a high level of experience and refined tactile feedback. In the case presented, the patient exhibited a complete pyelo-ureteral duplicity with total obstruction of the upper renal unit. The initial puncture, performed under ultrasound guidance, was not fully successful. Although the needle entered the pyelocalyceal system, it did not do so in a transpapillary fashion. Nonetheless, this attempt allowed the introduction of contrast, enabling better visualization. As shown in the photo, our colleague demonstrates the correct trajectory. Let's call it the genesis of kidney puncture. It is important to observe how the kidney shifts when pushed by the advancing needle. This highlights the essential skill required. The operator must be able to feel the needle as it traverses the renal parenchyma and then enters the calyx. Once appropriate access is achieved, placement of a guide wire ensures the tract is maintained and secure for subsequent steps of the procedure. Of course, these kind of cases would be impossible to resolve without a dedicated team.
Thank you very much. I'm letting you to discover the artist in every one of you and to carve the kidney stone the same as our famous Romanian sculptor Brâncuș carved the marble. Thank you. If you have any questions.
didn't see your demonstration today. You make supine approach your very easy. Where's your position? Do you prefer prone to supine and why?
Sometimes I prefer prone because it helps me to puncture any calyces that I want. If I have a secondary calyx that is parallel to mine, I can puncture it very easily directly on the stone without even introducing the contrast. You can feel the stone at the tip of your needle. And I will show you a case in my next presentation where I punctured parallel calyces to the main calyces that I use for entry.
And what's your view on multiple track punctures? Multiple tracks. What's your view on it? Do you do more than 2 tracks? If you have a complex stag on calculi?
Very rare. I'm not a guy that uses multiple tracks.
Yeah.
But by reducing the size of the scope, now when I do the second track, I will use a 14 French.
The smaller.
Smaller. Yeah. The Mini M from Storz. With a small working channel. But I can introduce a larger 500 fiber laser. And I can fragment the stone, and the Venturi effect helps me to clear the stone immediately. So I will do it for a small callus for some residual stone. But with smaller scope that we are used today, and with the use of flexible ureteroscope or cystoscope, in many of these cases, a single track is enough. I should debate about multiple tracks, but I'm not a believer in multiple tracks in PCNL. Although I have to sustain my opinion in the next presentation.
Congratulations for your presentation, very nice.
Thank you.
I have 2 comments about that. I prefer the supine position, and I think that the upper calyx and Tosca axis is a challenge really, but it's possible. And Tosca is perhaps, and Tosca you have to go intercostal, but it's possible and gives you a complete control of all the cavities, the renal cavities, and Tosca mainly in the lower calyx. And the second comment is about the obvious patient. Anesthesiologists and me prefer the supine position,
of course.
But there is an important disadvantage with the supine position in obese patients is that the distance between the skin and the kidney is very long, and sometimes you have difficulties to reach the collecting system.
You will need a longer ampla sheet.
A longer ampla sheet and longer nephroscope. And
we
then
have only one size nephroscope, you know.
Yeah.
We don't have longer nephroscope.
we use the lithoclass usually. And the problem really is that the amplitude of the movements in the tip, entonces for a longer devices is entonces more wide. So entonces if you have no experience, you increase the possibility of injury entonces with your movements inside the
kidney. Do you agree with me that we always can introduce in prone, in inferior calyx, a flexible ureteroscope in order to reach all the upper calyces that you want?
Yes, I agree with you.
You agree with me. So a part of this anesthesiological benefits of supine position, I can't see any other advantage. If you are not doing SIRS, of course that you can do SIRS in prone too, but it's much more
No, I think that the anesthesiologist's position in prone has changed a lot because there are a lot of surgeries of other specialties that need to be operated in prone. And I think that anesthesiologists is more frequent this position, and I think that they are more comfortable with the prone position. So I think that in specific cases it could be a problem, but in general the anesthesiologists are usually used for other specialties, so it's not a problem nowadays for anesthesiologists to use this position.
And you will see in all our cases that we presented today that the sheets is parallel to the floor in the prone position in every patient that we are performing PCNL. So there is no other major advantage of supine, apart of the fact that the kidney can be displaced very easily. When you are doing a single dilation, we are not using the Alcan dilators like in the past. We are using a single dilator, you saw. And even though sometimes it's difficult when you see all these kidney mobility.
Yes, I agree with you. Perhaps one advantage as well is that the endoscopic combined surgery is easier in supine position than in prone position. But I think that finally the selection of the position depends on the expertise and depends on your experience in the position, because I think that you should choose the best position in which you are more comfortable and for performing the surgery.
Both supine and prone position. That's why.
Okay, thank you very much to both of you. That was a very nice talk, very nice discussion. I think the conclusion is you never say never. You never say, I only do prone, I only do supine. You need to adapt to the patient, adapt to your theater setting and so on.
You have to know every position and every possibility. We are doing also ESWL.
Yes, so
we
done.
are doing flexible, you are doing PCNL. We have to adapt the patient. Okay, I will
we have
start
to be
with
in
the
time.
second presentation.
We'll start the debate and you remain there to continue with.
Prepared?
Yeah. So
You are
the
with
next
single track?
topic is a debate between Dan and Alberto. They already started it actually. It's going to be on multiple PCNL tracts.
So
and
I don't believe in multiple PCNL tracts.
Oh, come on, you have
Okay,
to.
but I have to sustain it today. So, like Harry Truman said, if you can't convince them, confuse them. I will try to confuse you today in order not to know exactly what to think. So, let's address our first question. Are multiple PCNL tracts still justified today? Well, if you look on the left on this case, probably no. But if we are talking about cases like the case in the second image, probably yes. I will try today to justify a better stone-free rate when you are using multiple access, the cost effectiveness, the OR time, the less risk of bleeding, and the renal function that is not affected by multiple tracts. In a recent retrospective analysis by Schenk involving 345 patients, the stone-free rate was significantly higher in the multiple tract PCNL group compared with the single tract. Importantly, there were no significant differences between the groups in major complications, including pilocalyceal system perforation, transfusion requirements, urosepsis, fever, or renal hemorrhages. However, the multiple tract PCNL group demonstrated a higher incidence of hydrothorax and postoperative infection compared with the single tract. Overall, while multiple access tract may be associated with a modest increase in certain complications, these remain clinically acceptable. The improved stone-free rate achieved with multiple tract supports its use as an effective strategy in appropriate selected patient. In a retrospective study performed by Fay, his team and Fay demonstrated that a total ultrasound-guided single-stage multiple tract PCNL for the management of Stankor calculi is both safe and feasible in selected patients. This approach was associated with acceptable morbidity while offering the additional advantage of avoidance radiation exposure and minimizing the risk of injury to the adjacent organs. The reported stone-free rate was comparable to that observed in the previous discussed studies. Similarly, Alphas reported a stone-free rate of 86% with multiple tract PCNL in a cohort of 100 patients with complication rates comparable to those seen in single tract procedure. While higher stone-free rates are well established, the question of bleeding risk remains central. Nicholas compared the morbidity of single versus multiple tract PCNL and found that the mean hemoglobin drop was comparable between groups, suggesting no significant increase in bleeding when multiple tract are used. Notably, the multiple tract approach achieved a significantly higher stone-free rate. Similarly, Ruiz's study demonstrated no meaningful difference in renal hemorrhages between the two approaches. It is important to know, however, that most of these studies were conducted using a standard 30 French amplat sheet,
In contrast, current European guidelines highlight that the use of mini PSNL sheath is associated with a reduced risk of bleeding. Current European guidelines indicate that the use of mini PCNL sheath is associated with a lower risk of bleeding. Consistent with this, a recent study of 100 patients undergoing PCNL with a 40 to 18 French mini perc sheath reported a mean blood loss of 112 milliliters. Only 3 patients required blood transfusion in this group, and 1 patient developed a branch renal artery injury that was successfully managed by superselective embolization. In a recent study of over 167 patients, Lin reported that renal function remains stable in 60% of cases and improved in 28% of these cases, while only 11% of patients experienced a postoperative decline in kidney function. It should be noted, however, that this cohort exclusively underwent mini PCNLs. In contrast, Nicolas evaluated outcome using a standard 30 French nephroscope and observed a slight postoperative increase in serum creatinine. Importantly, this change was comparable to that seen in single-track PCNL, suggesting that the use of multiple tracks does not appear to confer an additional detrimental effect on renal function. No differences were observed between infection complications. Contemporary literature suggests that establishing multiple tracks may as well be protective against infection risk, or at the minimum, it is no difference from standard PCNL. As demonstrated in a recent systematic review, the use of multiple track does not appear to prolong operative time. Across the included studies, procedure duration did not exceed 120 minutes, which remains considerably shorter than that typically required for a stage approach. An optimal strategy involves achieving maximal stone clearance through the primary tract within a defined nephroscopy time, followed by the creation of a secondary tract within the same session prior to completing the procedure. Some authors further advocate for establishing all necessary calyceal puncture at the outset before initiating stone fragments. This approach will facilitate, in their opinion, optimal pilocalyceal system distension with contrast under fluoroscopy or improve visualization with ultrasound guidance. When discussing operative efficacy, perhaps the greatest advantage of devices such as shock pulse and trilogy is time. In a randomized controlled trial, both lithotriptors demonstrated excellent performance with a stone clearance rate of 1.22 centimeter per minute for trilogy compared with 0.77 centimeter per minute for shock pulse. In a separate comparison, Manzo reported that trilogy is both more efficient and faster than laser lithotripsy in the PCNL setting. It is important to recognize, however, that this comparison was performed using a 500 laser fiber. When considering small fiber typically using in rears, the efficacy gap between becomes even more pronounced. When it comes to a new puncture and dilation, probably my colleague that support SIRS will be like, God damn it, how long this is gonna take. I will show you a movie. So I resolved the pelvic fragment, and you can see the unplugged sheath, but I have also a fragment located in the upper calyces. I was able to puncture the upper calyces, and then after the introduction of the guy wire, I was able to introduce a 14 French unplugged sheath, which is a very small unplugged sheath. And then I was able to fragment to introduce a nephroscope to fragment the residual fragments in the upper calyces and to remove all of them. This is the time in order to see how much it takes to puncture another calyx and do the dilation of the tract. you will see then in less than 4 minutes I was able to reach with a nephroscope in the upper calyces. Okay. I will move to the next case. Which do you think that is faster? The fragmentation using laser or the fragmentation using shock pulse or trilogy? I think that you are convinced, so I'm going to move further away. And I would like to present another case. You can see there are two parallel calyces. I choose the calyx, the posterior lower calyx, but you can see in this image that I have also a calyx. This is parallel with my primary point of entry. You can see on the CT, and I will show you how I approach this case. It's working or not? Okay. So, this was the first posterior calyx approach, but you are going to see that after I resolve the 90% of the calculus, I still have a residual fragment in a parallel calyx. Just a second. I have introduced the nephroscope. You saw that the fragmentation and the extraction of the fragment takes 20 minutes. It's not that it's taking 1 hour. The effect is spectacular. But at the end of the procedure, the renal pelvis was with no residual fragment, the upper calyx was with no residual fragment, but I still had, you saw this calyx that was parallel with my point of entry, and with the nephrostomy in place, in this case I leave a nephrostomy tube, I punctured directly the second calyx with the calculus located in it.
I mean, the neck of the calyx seems quite wide.
Yeah, the first one it was wide, but the second one is narrow. And I have used a second nephroscope, M from Storz, which is very thin. Yeah, and of course that I fragmented the calculi with laser, not with.
As we unlikely to have time for discussions, just a quick question.
Yeah.
You knew from the very beginning that you had stones in two parallel calyces.
Yeah.
When sometimes, what do you think? Isn't it a better strategy to puncture both calyces, leave a wire, so you have it in, and then you just carry on in case that something happens, so you're sure?
Earlier, some authors are suggesting that you should do both puncture.
I'm asking,
initially.
what's your view?
For
it's like
us,
a safety.
It's not a problem to puncture directly.
Sometimes
on
it
the
can
calculus.
be. Sometimes it can be.
Yeah, I can use the ultrasonography if I'm not able to puncture it fluoroscopically.
In a standard way, when we do know for sure that we're going to go for 2 punctures, we try and get the wires
I can
when
do
we
it,
start.
but I didn't have any case in which I was unable to puncture a callus.
Okay.
And
Good.
this is the calculus, which I fragmented with the laser.
And this was what was the size of the sheath?
14 French.
14, and the first one?
First one was 22.
22. So that is a very good example that yes, but when you do this, try and consider as much as you can to lower the diameter of your tract. Yeah?
Yeah.
Perfect. Thank you very much, Dan.
Thank you.
Much appreciated. Alberto, your turn.
Every day we are placing a lot of 8 French nephrostomies, and the patient is go away the next day. He's discharged the next day. So 8 to 14 is not
This one. I can do it.
To start, are there any other comments or questions for Dan? Okay. So I will ask you a question then. So how many is too many?
3 are the maximum number.
So you won't go above 3. Okay, fair enough. What about you guys in the audience? Wes is doing, there are some experienced PCNL surgeons. Do you have a different opinion? Yeah. 2 is enough. Okay, good. Thanks a lot. Alberto, please go ahead.
Okay, thank you again for your invitation. I don't know. Okay. So I think that percutaneous surgery is the most invasive endourologic technique for treating urinary stones, and has been described a high percentage of complications, around 14.5%, and most of them are related to the puncture and to make the tract of access to the kidney. And it occurs, the complications sometimes in spite of performing a perfect puncture and a perfect dilatation. This is the way in which we dilate. We use a simultaneous image of ultrasound and X-ray because you use a C-arm, a fixed C-arm, and we have no the possibility to inclinate on that. And so we use the 2 dimensions, one with ultrasound and the other one with the X-ray. In spite of performing a perfect puncture, sometimes we have some complications related to the puncture and related to the dilation. So the logic is that if we increase the tracts, we are going to increase as well the number, the complications, or the probability of have more complications. And we have an alternative, we can use only one tract, and we can combine with a retrograde flexible ureteroscope, we can use an anterograde nephroscopy, flexible nephroscopy, in which you can reach practically all the cavities, all the renal cavities into the kidney. And therefore, using endoscopic combined surgery allow us to perform a perfect puncture using endovision technique, and reduce as well the X-ray or the dose of scopy that you can use in the operating room. And you can follow the dilation without any problem. And therefore, you can use an anterograde nephroscope, nephroscope, for checking all renal cavities. And if you can access by the upper pole, you can control all the renal cavities during the surgery. And so you can check and treat each stone that you can find in this access. So if we imagine a boxing combat, entonces que between single tract and against entonces que multi-tract. Entonces que you can see that when we review or check, entonces que the last or the older series published in the literature, you can see that multi-track stone-free rate is entonces que higher when it's compared with entonces que single entonces que track. However, the rate of complications is higher for multi-track according entonces que to increase the number of puncture and entonces que the track. However, if we compare entonces the most recent entonces series, you can see in meta-analysis and systematic review that the difference entonces are little. There were no differences in the stone-free rate, but in spite of that, the probability of complications increase as well in multi-track entonces technique. And if we entonces compare entonces recent series, you can see that there were no significant differences in the stone-free rate, and the complication rate is entonces higher as well for multi-track entonces approach. And it's the same, entonces the rate of complication is entonces for minor and major complications higher in the multi-track entonces approach. There are other parameters that we can analyze, and so the operating time is very similar, only in the single track is a bit longer, entonces for complex stones, the need for second procedure is higher in the case of single track, but entonces the renal injury and the hospital stays is shorter or is less entonces for entonces single track entonces approach. So if we come back entonces to the combat in the round A1, if we compare the stone-free rate, entonces we can see that only the stone-free rate is slightly higher entonces for multi-track percutaneous surgery in patients with a hard stone burden. And when we analyze the complications, we can see that the single tract entonces has a very low entonces rate of complications with this compare, and the renal preservation and the hospitalization is entonces less, is safer and shorter entonces for single tract technique. And finally, the need of second procedure is slightly entonces higher for single tract entonces approach. So the winner is, by a split decision, in my opinion, the single entonces track when it's compared with multi-track. But however, it doesn't mean that the multi-track approach is not indicated, because in this case that entonces we treated last Sunday, entonces is a young woman, entonces 22 years old, as you can see, we have to perform 3 different entonces tracks, 2 standard tracks, and 1 mini percutaneous surgery. And the second indication for me for multi-track is in inaccessible calyces, in which we prefer entonces to use a mini percutaneous access for treating entonces this access. So for concluding, entonces I say that are multiple percutaneous tracts still justified today? Yes, but only for selected cases. Thank you so much.
We are on the same page. I think that in Romania the stone burden is larger compared with Spain and other countries. The patients are coming with very large stone calculi, and sometimes when you have a very thin neck of the calyces, you can approach it by a single tract approach.
Yes.
On every patient, we have to establish the right indication for the
Yes, I agree with you. In Spain, the complex burden stone has entonces reduced, because I think that for other clinical causes, entonces patients have ultrasound or have entonces CT scans, and so you can detect entonces stones entonces in an early stage. I agree with you. The highest stone burden cases in Spain is for infectious stones, entonces is the only case. And genetic entonces cases.
If you have a Stockhorn, a struvite stones, what you are doing in the first procedure, a complete type H Stockhorn calculi, are you trying to remove all the fragments from all the pieces? Are you trying to leave the patient stone free? Or you are trying to liberate only the renal pelvis and to place a very large nephrostomy tube?
No, it depends on the time. Entonces, que if I can finish the procedure in 90 minutes, entonces que I treat all the stone. But if the procedure is longer than 20 minutes, I postpone that for a second procedure.
Yeah, thank you. Because we still are afraid of a single complication when we are doing PCNL. And this is the sepsis and the sepsis shock.
Yeah.
This is the only complication that we are still afraid. And we have seen a lot of cases with.
That's correct, but I would have expected both of you to tackle a bit and talk a bit more about, you know, the increased risk of bleeding in multiple punctures that still exists, the loss of renal function. There are studies showing differences in multiple punctures. The question that I did ask, how much is too much? How many tracts are too many tracts? What are the pros and cons of doing this? So that would be my question, one of my questions.
For the second tract, we are not using anymore the 30 French amplas sheets. We are using a very small one, like a 12 or 14 French. So the risk of bleeding is decreased very much. In the 5 years ago, we were very good friends with radiology interventionists from municipal hospital. Nowadays, we can't see them.
So you don't have an interventional radiologist here?
No, but we have at the hospital there is in the near vicinity with us.
I'm not sure, Leah, how is it now in the UK? But I think there was a point when we said you can't do a PCNL if you don't have.
Unless you have a
you can't.
You can't.
You're forbidden. You can't do a PCNL unless you have an interventional radiologist in your hospital.
We have a protocol with this hospital in which if we have a bleeding, we are sending the patient and they are treating us. They are treating our patient. But we didn't saw the interventional radiologist in the last year. A few years ago, we were calling him 1 to 2 times a week. Nowadays...
Do you know how this is called?
Yeah.
You think it's experience? No, it's luck.
No. We decrease the diameter of the sheets. That's why this is the main reason why we don't have the number of bleedings that we have a few years ago. By decreasing the number of bleedings, the patient can be discharged the next day or...
One more thing that I want to make it clear for the younger colleagues. Anyone would say, okay, so why 2 tracts when you can have a flexible scope through the single tract? And that's very simple, unless you don't do PCNLs. If you do PCNLs, you actually start to understand that you don't have any flexible scope that have such an acute angulation to enter the tract that Daniel showed you. There's no way to go from that PCNL tract with the flexible cystoscope. The radius of the bend won't allow you. Even if you go, sometimes I go with a flexible ureteroscope where you can bend a bit closer and you can force the scope in, but that takes much longer. You won't be able to sort things out, and sometimes that doesn't work as well. So you have to you have to go from down below, and this is where supine is king, because you do it quickly. So yes, again, I did put this debate in the program because there's no winner here. You need to adapt to understand exactly what the patient requirements are and do what's required for your patient. But there is a limit. Don't do, I was hoping I'm going to give you one of those, I've got it from one of my Chinese friends with 9 tracts in a kidney.
I never done more than 3 tracts.
I know. Look, it's just for debate and fun. Good. Congrats to both of you. Very nice debate. And I'm happy that Professor Giavletta is here with us today. Thank you very much for joining us, Bogdan. It's your turn to discuss the new thing in endourology, which is suction. Thank you very much, Bogdan.
pare că am laptop la mine? Ușor. Dacă am făcut rost de apă, restul partidei e câștigat.
Avem un fișier video sau o prezentare?
Prezentare și cu niște videouri incluse. Următoarea, cea cu suction. Ok. Și ăsta mergem? Ușor. Da, suntem și embedded, trebuie doar deschis. Adică trebuie copiată. Mai avem invitații în afară? Nu, acum în sala, ca să știu dacă vorbesc în română sau în engleză. În engleză, ok. Ok. Microfonul? So, hello everybody. Good to be with you today. First of all, I'd like to congratulate you on this event. This is quite remarkable. I would like to welcome our guests from abroad, and very happy that they're here with us to learn from each other. I think every opportunity is great of sharing our experience. So we shall start with a few aspects about a topic that has been very frequently debated during the past few years with a lot of literature emerging. We're going to talk about the role of suction in modern endourological stone surgery. Okay. Să-mi dai laptopul? Ok. Schimb cu slide-urile atunci sau cum faci? Okay, so let's go back. So, the problem of residual fragments. So I can see the slides better. So the problem of residual fragments has been extensively debated. It's also analyzed in the guideline because, you know, endourology, like just any other surgery, is not actually perfect. So we leave occasionally, more than we'd like, we leave some fragments behind. So we need to come together and agree what size is acceptable for these fragments, what is clinically insignificant. There have been a number of parameters featured in this area, and the most commonly accepted is the one of 4 millimeters. But if you look at the percentages, 17 to 46%, we can hardly predict if those fragments are really going to be eliminated spontaneously. So the main target would be to do the best job that we can to leave as little residual lithiasis as we can. Slide, please. Also, there's the trouble of complications. No surgeon really likes to talk about it, but the truth remains they exist. And if you look at these pictures, you can see why. So the main 2 problems with retrograde intrarenal surgery is 1, residual fragments, and the second is rising intrarenal pressure. high intrarenal pressure due to elevated irrigation flux leads to pilovenous backflow that pushes the germs in the urine, in the urinary medium, into the circulation, and therefore you will have sepsis. And these are normally pictures you don't want to see, especially before performing flexible uteroscopy. But they are reality. And these are good to know so that you would have in mind what to predict. Now, in terms of suction, thank you. Okay, now we're great. So in terms of suction, we have, it's all good. We have the flexible access sheet with suction, either with a bendable flexible tip or non-bendable. We have the suction pseudoscope, the device in suction, which is a good advancement that now has more competitors, more companies producing it. And we have the suction through catheter, the CVAC, which is now evolving to more modern devices. Now, the evolution of the ureteral access sheet and flexible ureteroscopy went hand in hand, so to speak. We have the traditional sheet that has limitations, no doubt. You can barely control the outflow as well as the intrarenal pressure. You have the flexible suction sheet, which gives you a chance to direct it to the calyces which contain the microlithiasis, take them out, also point out to the lithotripsy place and eliminate the fragments as you destroy the stone. And also you have the intrarenal pressure monitoring flexible access sheet with the integrated platform. And that is very, very important. Why? Because it regulates what goes in and what is being taken out in order to maintain pressure, not too high, but not too low either, so that you would avoid excessive suction and bleeding from the mucosa, which impairs your endourological vision, but also the rising pressure with the pilovenous backflow and the sepsis. Now, the three suction techniques, the suction ureteral access sheet, the direct in-scope suction, and the irrigation and suction platform with control pressure, they tend towards this concept of clinically insignificant residual fragments. So to take out as much as possible and adapt yourself, your technique, your devices to the diameter of stone fragments. And the advantages of using suction device are multiple. First of all, you can control the intrarenal temperature and pressure, as I've showed you. You could potentially reduce the risk of infection because you stop the backflow, and you could improve your surgical outcomes because you take more fragments out, and therefore you increase your stone-free rate. So, we have a lot of literature, like I said, on the flexible access sheet. There's an increasing amount of papers showing up in quite important journals, showing that in ureteroscopy for renal stones, access sheet with suction becomes more or less of a standard. And we have a step-by-step guide on how to use this navigable access sheet. Now, among these papers showing up during the past few years, we have the tip bendable ureteral access sheet that I just mentioned as a safe procedure, good achievements on stone clearance. You can direct it exactly at the tip of the flexible ureteroscope, bend it with the scope, and therefore have suction as you do the lithotripsy of the calculus. So the tip bendable suction access sheet can provide a better vision as a result of that process when you compare it to the conventional sheet. Now, there are numerous devices being developed. I think competition is good. We have the ClearPetra, the Gaomed, and several others, with some of them being integrated into platforms, some of them not, some of them with a possibility to control the inflow as well. Now, this is a nice study targeting exactly what we're interested in every day. The stone-free rate, 24 hours after surgery, which proves what? That we have done a good job. And it's better when you're using the suction sheet, because apart from the washing out the fragments, apart from the job that you're doing with your laser, you're also getting help from the suction provided by the sheet. And therefore, you take more of the lithiasis out. And that's particularly important when you're dealing with a hard, large, multiple calculi. Also, overall complications, a significant improvement. Most of them related to pain, fever, and sepsis in the immediate after surgery time. This is a nice publication from 2023 showing an important advantage in terms of surgical efficacy. So you get a significantly shorter operative time, an improved stone-free rate with a statistical significance attached to it, reduced complications rate, and targeted, reduced, significantly lower incidence of overall infections while using the suction sheet. We followed this path of clinical research. This is a paper we sustained 2 years ago in the American Neurological Association Congress, comparing exactly that, the standard, still standard, access sheet, conventional one with the suction sheet, and more or less confirming the advantages of the latter. Now, this is a review that we've done, taking into account the literature that was available up to 2024. And at the end of that review, we came with a conclusion that the suction accessories and endoscopes are used on an increasing scale, and we didn't know what was to come in the next 2 years. We get to prevent septic complications and increase safety, by lowering the pile cell pressure, and with a potential to improve visibility. You know how important this is during endourological procedures, and also to clear out the small fragments and improve efficacy. While combining the flexible tip suction sheet and the device in scope suction, you can get additional advantages. Now, these are just a few examples. I put a lot of them. There's more. Just in 2025, numerous papers followed this path, evaluated in single-center, multi-center review or meta-analysis setup, data that's gathering around the idea that using routinely the suction access sheet will give you clinical advantage and show up as a useful tool during everyday surgery. Now, I put here a mentioning of how important the difference between the access sheet and the suction scope is, because the more space you get in between them, then you have a bigger chance of taking out larger fragments. But also these fragments, keep in mind that they're not very big, those that you cannot take out. So you should not leave out the main therapeutic principle of retrograde intrarenal surgery in 2026, which is dusting. You need to do as fine dust as humanly possible. Now, this is also a summarization of the difference that you have while using the newest scopes, the 7.5 French, even the 6.3 French, combined with an average 10-12 French sheet, or preferably, but if there's room, you have to adapt your technique and your devices to the patient and not the other way around. In pre-stated patients, 12-14 French, in which situation you can take out larger fragments through the sheet. Okay. This is also a very nice analysis on the technique, tips and tricks, where you should actually place the tip of your scope and the tip of your bendable sheet as much as possible in front of the lithiazic material of the lithotripsy site in order to maximize both the lithotripsy as well as the suction. and do them in a combined manner in order to save time and optimize efficacy. Not in the middle of that cloud, not behind it, not with your scope too much away from the suction sheet tip, but a joint venture. At the same time, same place, optimizing efficacy. These are some examples of the suction sheet that you use, the Elephant from EndoExperts, the Clear Petra. I don't want to say one is better than the other. I'll just say that they're effective. Depends on those that you are most used to. And they have advantages. Safety, lower intrarenal pressure, temperature, efficacy, not very expensive, and they will improve your vision. And they are more or less cost effective because they reduce the need to accessory equipment device and reduce the operating time. Because then you don't depend just on the scope and on the laser fiber, but you also benefit from the advantages of the suction. And these are various systems of adjusting the vacuum level, for example, not just by placing your finger and obturate the channel, but also there's another form to open or close for suction as adapting to the intraoperative situation. These are some videos that I don't think work. Okay. And also this is how you get to navigate and check your pylocalyceal system after procedure in order to make sure that stone-free is really stone-free. By the way, you don't really know how stone-free you are until you've done a CT postoperatively. Just an advice, you can have 100 ultrasound from 100 doctors and they'll give you 100 different results. If you really want to know how well you've done, do a native CT scan afterwards and you'll know exactly how big are the residual fragments, if they exist, and therefore plan your subsequent treatment. This is the IGAO med access sheet with the thulium. I would like to say that somehow, although there are contradictory points of view, the thulium might be a little bit better at the dusting mode. Of course, it's subjective, it's just an opinion, but in order to achieve a complete stone-free, especially for a larger calcul, you need to take your time and keep up with the operation steps. This is a summary of the literature in 2025 about this, about fans, and about the CVAC that, as I've said, is growing back interesting. New accent sheet, steerable. This is very interesting, actually, because you get additional mobility not just from the handler of the flexible scope, but also from the sheet. And therefore, you can orientate the tip of the sheet towards the lithotripsy side more easily. We used to have that solely under fluoroscopic control. That's the old principle, but now, entangled with the flexible scope, you get a lot more flexibility. Does intrarenal pressure matter? Well, absolutely it does. You have to adjust yourselves, adjust the intrarenal pressure at a balance that will keep the safety of your patient throughout the procedure, and therefore avoid the trauma, the biotrauma for once, and the septic risks for another. Monitoring pressure has become a focal point. There are a lot of papers on pressure. Flexible and navigable suction ureteral sheet are very effective at maintaining a low intrarenal pressure with high irrigation pressures. The suction devices give you another layer of protection because you don't have too much inflow gathering and pressing against the renal parenchyma. And the aspiration devices don't have complications related to high pressures if you monitor them correctly and you respect the steps and you make sure that the pressure remains less than 40. And for that, I will show you that the platforms are increasingly important, and they are also evolving, okay? We used to have platforms that only took care of irrigation. Now, also in terms of suction, as well as an artificial intelligence system. Of course, they are in the course of development, but there are more papers emerging because you get control. Actually, the platform has benefits from the sensor placed in the intrarenal system, and therefore adapts the irrigation and the suction in order to maintain constant pressure. This is the T-door system that we got to experiment. It's newly introduced, relatively newly introduced, and it gives you the chance to maintain a constant pressure throughout more difficult procedures and maintain real-time intrarenal pressure control. In combination with the Elephant 4 ureteral access sheet, and you can use whatever scope you like, either from Pusen or HugeMed or whatever. Now, this is a combined use of the HugeMed system with the T-door intelligent pressure control, and this is also being shown as effective and feasible. These are a few videos that should have also worked, but they don't. It's okay, no problem. And we have, of course, the direct in-scope suction that has been extensively analyzed by international personalities, such as Professor Traxé, Professor Gohard, and Cesare Scofone, and others. And we came under the conclusion that are useful. The single-use suction scope is the present and probably the future, because it provides a lot of advantages. We have a lot of experience, for example, with the Pusen scopes, which work very well. The 7.5 over 3.6 working channel, and the bolder, larger 9.2 French, which is the 5.1 working channel. I can tell you that the larger working channel really gives you an extra chance to take out larger fragments. And this is a summary of the advantages that have been constantly, well, relatively constantly shown by the ongoing studies. And basics is that you have a chance for stone disintegration over 2 centimeters, and therefore better surgical outcomes. This is an overview from the EAU section of section of urolithiasis, maintaining the idea that the removal of debris, of small stones, of dust can improve your vision, therefore avoid lesions of the mucosa, reduce intrarenal pressure, enhance visibility, and therefore better efficacy and safety. Also, you have an improved surgical time because you get to see better. Reduced intrarenal pressure will prevent pressure buildups, and therefore that reflux that looks so dangerous. Temperature control, because we have thermal lesions that exist during prolonged procedures due to the heating of the intrapyelic irrigation liquid if you don't take it out. And therefore get to minimize laser off times, because if you see better, you maintain your laser fiber in contact with the surface of the stone, and therefore optimize your operative time and have a better stone-free rate. Of course, it's not easy. Although it looks good, we should keep in mind that a standardized technique is important, that there are steps to be respected during every procedure, and there's additional layer of complexity to this technique, because you have to keep in mind several parameters: to move around for the stone, to do the lithotripsy, to control the suction, and to alternate the suction times with the lasing times through the scope, if you're depending on the scopes alone. If you're having the suction access sheet, then you can do them both simultaneously. So it takes an experienced, somehow, endourologist. I know we're great endourologists, but you need to have some experience to adapt to all these technique changes. The application of both types of suction requires an increased flow rate, so you have to keep that in mind in order to avoid a negative pressure and therefore lesions on the mucosa. This technique relies on the ability to maneuver the tip of the scope exactly to the area of the calyx in close contact with the stone, not too deep but not too far, and therefore benefit from the flexibility to work in any part of the kidney doing lithotripsy and to keep on dusting and not fragmenting. Now, as suction is applied, the working channel may block. This can happen at any time. Don't worry, it's not a disaster. But when it does happen, you need to solve it, okay, even from blood clots, even from spot dust, even from gather fragments. And while using device suction and intermittent aspiration, you can keep a lower power suction and therefore good vision throughout the procedure. Now this is another interesting paper showing that there's a limit to what you can take out, that fine dusting is still imperative, and that the suction is not a surrogate for competence when you're dealing with difficult stones, okay? You need to keep your cool and do as much as possible in one procedure, but stage procedures are also to be considered because patient safety must be first. This is a summary of the Twitter search back 2 years ago, quite visionary if you look at it, because the aspiration is the present and the future, because the clear view and the low intrarenal pressure remain priorities, and still, 2 years later, no consensus has been reached about the best suction technology and different modalities. They keep being introduced, new ones. So, but there are some features that have been proven by most of the literature. So you could say that the suction really gave the upper hand to retrograde intrarenal surgery because in most of the reports it has reduced complications, reinterventions, reduced time of operative procedure, and hospitalization, and a better quality of life. So we have to tackle with difficult cases as well, and where the boundaries of flexible uteroscopy have been pushed and probably will be pushed even further. So my take-home messages for today would be that endoscopic lithotripsy is evolving, that we saw remarkable technological improvements during the past 10 years or so. The single-use scopes are now widely spread. What used to be just a plan or just an advancement is now more or less routine. And at the end of the day, it improves safety and improves stone-free rate. And also the new action sheet is part of the daily routine. And of course, more randomized studies will need to confirm these findings. And the suction-capable accessories and scopes are used on an increasing scale. I think this is quite a reality. I think everybody in this room is doing it, and all the guys online, or most of them, and the European and the American surveys are confirming that, because more or less the whole international urological community is acknowledging that the lower the pilocalistal pressure is during intrarenal procedures, there's the better safety, and there we prevent the septic complications, which we don't really want. And these instruments also benefit your visibility, take out small fragments, and thus you improve your efficacy. But the practical impact remains to be determined. We still need to see significant improvements, statistically speaking, on the long-term success rate of the procedure. Thank you very much for your attention.
Thank you very much, Bogdan. Excellent presentation. So I can skip my presentation at the end with innovation in endourology because you went through all the new and nice things. So well done. Congratulations again. Questions, comments? He will have to stand up until one of you ask a question. So let's see how much you love Bogdan. Do you want him to? So your guys should start, otherwise something will happen. Come on, guys. I'm not going to ask questions myself. You have to think about what Professor Javleta presented and give us some of your thoughts or questions. Okay. Even for you, the very young ones, you can still...
Yeah. Bogdan, what scope do you prefer? What flexible ureter?
Well, most of our practice relies on those from Poussin, the 7.5 or 9.2. I prefer the 7.5 for an average 1 to 1.5 centimeter stone. I prefer the 9.2 for the 1.5 to or over centimeters stone, given the possibility of stage procedures. I also use the huge med, the 6.3 on a difficult acute angles and narrow infundibulum calyces. So I think there's room for more than one. Yeah.
We have used 6.3 today, and it worked very nice with an aspiration sheet, and we were able to bend the Cleopatra tip until we reach an inferior calyx, and that's why I ask you.
It's a big advantage on maneuverability. I completely agree. It's a good tool, and it's the thinnest on the market right now. And those difficult cases for the endourologist where you really need to push it, then it makes a difference.
Perfect. So we have some very young residents with us today. They did a boot camp yesterday, so they are first or second year. So all these things for them may not be. I want to ask them a question. Out of all this excellent presentation, how many types of suction did you manage to identify? And I'm not going to ask the young lady, but I'm going to ask you. Tell me. And if English shouldn't be a problem, but if it is a problem, say it in Romanian, because I think only Alberto now in the room doesn't speak Romanian, but he's Spanish, so he can understand. And it's not a question, so it's not to shame, it's to see what did you get out of it?
I try to understand the presentations, but I don't know the number of suction types.
You don't know about the suction types. Okay.
The number.
Do you understand what a scope is? You
Yes,
use
yes.
this, yeah?
But I
So the scope needs inflow
Yes.
to see. Yep.
Yes.
Now the suction thing is when the outflow doesn't just come out naturally, but you apply negative pressure, suction, to the outflow. How can you do this? Out of Professor Javleta's presentation, what did you understand? How can you do this suction thing? Where can you apply the suction? Any one of you, the younger guys, that can make a comment? And again, don't be stressed. We are here for you to understand. Who else was in the boot camp yesterday? You were. Any thoughts on your side? Not sure. Anyone else from the very young colleagues? Okay, someone with a bit more experience, but not a specialist. Dan, out of your younger guys.
Negative aspiration.
So can you explain to them in a very simplistic way how can we use suction when we do uteroscopy? What are the two types?
The mechanical suction and the negative aspiration.
How is that the mechanical suction?
With dormia or...
Well, that's not suction, that's mechanical removal. That's, it's removal, it's not suction. When we say suction, we mean we apply negative pressure. Where can we apply it? There are two ways to do it.
To the access sheet.
Exactly, and that is
pressure.
with fans, where the suction, the fluid is aspirated alongside the scope, in the space between the scope and the sheath. Okay, so that's one way of doing it. Yeah, and what's the other way?
Through the canal, to the work
Through the working channel of the scope. So you aspirate not through the sheath, not through the space between the scope and the sheath, but through the working channel itself. Is it clear now? So one is the fans, the flexible and navigable access sheets with suction. The other one is this, direct in-scope suction. So I'm pretty sure all of you understood it, but you need to think. That again, I keep on saying, think about what happens. Don't just listen. Try to process the information and think about it. And if I ask you to summarize something, it's like you see, like your patients. You spend half an hour talking to them. You think you've explained everything in the clearest way, and then when you ask them, so what are we going to do? You always get surprised. Yeah, exactly. Well, you talk to them. Okay, good. Bogdan, thank you very much again. Excellent as usual. We have 25 minutes break. Again, a coffee break because you're very tired and you're very hungry again. But we will start. So I would like, we will do more of these things.
So can I put a question for
Sure.
Professor Jarleta? Sorry. Great presentation. I saw that you're using the intelligent pressure control system by TDOR. Do you use it, in your opinion, for selected cases or on a daily basis?
Well, we had for a limited series, so we don't have that on a routine base. So I couldn't really say because
It's
we only
a
use
useful tool, you feel?
Yeah, it is. I think it is. I think it is. It depends on availability. I think that the greatest difference, like any technique, will be given in the difficult cases. Because there you have an excessive pressure, you have prolonged lithotripsy times, and increased septic risk. So obviously for a 1 centimeter stone, I'm not sure it's going to make a huge difference. Well, once you have it, why not use it? I agree with that. But the real difference, I think, will be made in those challenging cases in which really a complication can stop you from finishing the procedure. Okay? And if this system gives you a chance to prevent that and to follow up on a 2-hour lithotripsy time, which is quite challenging, I think you agree, and if it keeps your safety throughout those 2 hours, then I think it's really worth it. But of course the future will tell, because there are no major series published so far. It's just developing.
Yeah.
Thank you.
Thank you.
Good. So, 4 o'clock, we start here. This is something I would like to, with all the courses and things that we do. Time is relative, but punctuality isn't. So at 4 o'clock we start. At 4 o'clock, those who respect the guys in the room should be here, please. Thank you.
Sunt recurente. Bloc Pharma recomandă URI, soluția urinară de plin, ce conține proantocianidine și demanoză, ce distrug biofilmul și blochează complementar adeziunea bacteriană, și filantus și crisantelum, ce reduc și previn formarea lithiazei urinare.
URI se administrează 2 tablete pe zi, dimineața și seara, timp de 4 săptămâni pentru fazele acute și o tabletă pe zi seara, timp de minim 3 luni, pentru a preveni recurențele. Atenție! Schimbarea produsului în farmacie poate afecta eficiența tratamentului. Recomandați pacienților să nu accepte schimbarea tratamentului prescris.
Artlist.io.
there is always a ray of light, guiding us towards health. There is always a path, leading us towards the future. We unveil the mysteries of minimally invasive techniques. We drive innovation in endoscopy. HugeMed was established in 2014 and dedicated to medical endoscopes, forming a comprehensive team covering R&D, manufacturing, sales, and service. With the collaboration of over 400 colleagues, we continuously promote the adoption and the advancement of endoscopy.
We are firmly committed to delivering human-centered products and services, striving to provide safe and affordable, minimally invasive endoscopy solutions by integrating, enhancing, and revolutionizing imaging and surgical instruments. We dedicate ourselves to advancing healthcare for all.
With the support of a strong R&D team, as well as experts from Chinese Academy of Sciences and foreign academicians, we have made multiple breakthroughs in core technologies and obtained hundreds of invention patents. During the process of research and development, we strictly conducted quality tests to ensure the stability and reliability of imaging. We currently offer 6 major product lines covering airway management, video laryngoscopes, urology, ultra-slim 6.3 French, single-use ureterorenoscopes, pulmonology and ICU, single-use bronchoscopes, gastroenterology, general surgery, ENT. These lines cover clinical applications across more than 10 departments. We allocate 25% of annual sales to R&D, continuously enriching our product portfolio. To bring decent endoscopy to all people in need, we committed to independent development and manufacture. We now operate production facilities covering over 10,000 square meters, including automated production plants, GMP-compliant dust-free plants for single-use products, and assembly plants for reusable products, with a monthly production capacity exceeding 50,000 units. In the future, we plan to establish second manufacturing center, increasing annual capacity to 3 million units. As a pioneer in global expansion, we are constantly exploring new market strongholds. We have obtained certifications including NMPA, CE, FDA, and have received numerous domestic recognitions. Our sales network spans over 100 countries and regions, with partnerships established with more than 10,000 hospitals worldwide. Domestically, we offer 24/7 after-sales service. While abroad, we work closely with our local distributors to build offshore service networks. With a heart devoted to the health of mankind, we pursue the path towards great achievements.
Looking forward, we remain committed to our philosophy of sustainable development through relentless innovation, resource integration, and consistent growth.
Our ongoing mission is to become the world's leading supplier of single-use endoscopes.
O zi din viața noastră cu brandurile Stada CHC. Dimineața începe cu pregătiri pentru școală și imunitate pentru cei mici cu mini-marțieni. Mătușa răcită ia modafen, răceală și gripă și gata! Este pregătită să facă yoga. Tata la volan se pregătește să meargă la sală. Înainte de antrenament, intră în formă cu proiezii activ. Mama ajunge la birou și simte brusc disconfort urinar, dar este pregătită și calmează rapid disconfortul cu urinal acut. Bunicul grădinărește și se simte în putere. Bunica știe de ce. Silimarină Stada. Mătușa este foarte atentă la imagine și cu hepatrombin cremă, intervențiile estetice nu lasă urme și se simte impecabilă. Tata ajunge acasă și după o zi grea are și o durere de cap supărătoare. Ia repede un modafen forte și se relaxează. Bunica începe să resimtă durerile de genunchi, dar aplică Mobilat Pro și este gata să coboare la cină. Acum, toată familia s-a reunit. Stada. Grijă pentru sănătate, pentru fiecare generație.
And I'm again grateful to Stefan Rașcu for getting into a debate with Bogdan Javlete about the need to actually measure the stone volume rather than just one or two dimension. Thank you very much, Stefan. Please go ahead.
Thank you. Again, a pleasure to be in front of you today. Well, I have to admit that when I received the topic, my debate, so to say, today, well, I felt like, okay, so we're two bald guys, but I'm the one who has to convince everybody I have a full head of hair. So basically, here's how it goes. Well, as a disclaimer, you can never actually talk about a waste of time when trying to ensure the best result for your patient. But still, well, some things can be unnecessary, maybe in some circumstances. So for the topic of discussion today is stone volume measurement, a waste of time. Well, I don't know what to say yet. Can be yes, no, or maybe. And there are situations when no can actually maybe yes. Well, that depends on a series of factors, like stone location, like the type of procedure you're going to choose, and maybe other options for the measurement of the stone burden. And because I like questioning myself, and usually others too, I try to search the literature for what it has to say about stone measurement and options for measuring. And I've come to this study from 2018. which measurement is best before flexible arthroscopy to try and predict your results. It was a retrospective study, so to say. With 67 patients, they tried to assess the clinical utility on the radiological parameters to measure the stones as a predictor of the stone-free rate after a single session of flexible arthroscopy. They used the maximum diameter, the cumulative surface of the stone, the volume, the 3D volume, and the cumulative diameters of the stone. And in conclusion, like the graphs here suggests, well, stone burden evaluation can be critical to predict stone-free status after a single ureteroscopy. At the end of the study, the planar and the volumetric measurements actually showed an equal ability to predict the stone-free status, but with a 3D volume that was more accurate to predict that status, but with diameter measurement, the total diameter measurement, being easier to use in clinical practice. And, in conclusion, the stone burden evaluation was critical to predict stone-free status after a single ureteroscopic session. Planar and volumetric measurements showed equal ability to predict the stone-free status, but of course 3D volume was a bit more accurate to predict it. Still, measuring cumulative diameters remained easier in clinical practice. Another study, and that's an important one, I guess, and you'll see at the end of my presentation why I think so, from 13 years ago in +1. And it tried to demonstrate the utility and the limitation of the cumulative stone diameters in predicting the urinary stone burden at a flexible arthroscopy using only holmium laser lithotripsy. Over 240 patients. The preoperative factors analyzed were the cumulative stone diameters in millimeters, the stone volume in cubic millimeters, and the number of stones. And they tried to predict the stone-free rate for cumulative stone diameter versus volume. And what the conclusions of the study actually revealed were that the cumulative stone diameter and the stone volume were equally beneficial in predicting stone-free rates after a ureteroscopy for patients with a maximum stone burden or diameter, so to say, of 20 millimeters. However, in patients with a cumulative stone diameters of over 2 centimeters, CSD cumulative stone diameter was inferior to stone volume as a predictor of the stone-free status. So the study indicated that if you have a maximum diameter of 200 20 millimeters, 2 centimeters, or at least 4 stones, you should better evaluate your chance of getting a stone-free patient through volume and not cumulative stone diameter. Now, it very much depends on the location where your stone is. It's very different to actually plan your surgery if you're doing it for the kidney or for the ureter. This is another study from 2 years ago, actually, in the Canadian Urological Association Journal, with over 500 patients that had ureteroscopy, but this time for ureteral stones. And they were trying to evaluate, to assess the factors that were affecting, well, the operating time and therefore also the risk of sepsis, actually. And, the average diameter of the stone was about 7 millimeters with an average volume of about 1 cubic centimeter. And what they found out that in surgery for ureteral stone, and because the space in the ureter is relatively limited, it's small, and the size range can be limited, size in terms of volume may not be a predictive factor of prolonged operative time for ureteral stones. So in the ureter, it's not that important to measure the volume. The cumulative stone diameter might be sufficient to determine the stone-free rate of your patient. And now, quite large meta-analysis of more than 12 studies for all the procedures we can perform for stones, from ESWL to ureteroscopy to PCNL. And they would try actually to assess the stone size measurements, accuracy, on the outcomes together with complication rates and operative time. And for ESWL, well, it wasn't quite that important. So the area under curve still was a bit significant, was significantly higher for volume than for linear size, but not the cumulative stone diameter. In terms of odds ratio for diagnosis. In PCNL, well, in PCNL, they established a threshold to better assess your outcome with the volume, and the threshold was about 15 cubic centimeters. That's a lot. Before that threshold, it wasn't that important whether you use cumulative stone diameter or area of the stone or volume. But after 15 cubic centimeters, that's quite different. Well, for retrograde intrarenal surgery, so for flexible uteroscopy, the area under the curves in the study actually showed it's significantly higher for surface area together with volume measurement compared to the linear dimension, so the maximum diameter we are quite measuring and as we are advised by the guidelines to do. So, the final conclusion of the study was that, well, from a statistical perspective, the areas under the curve for the area and volume are significantly better than for linear size. So what we should basically do, try always to orientate to go for either the cumulative stone diameter or volume of the stone rather than the linear size of the stone. So, now, what do the guidelines actually tell us? And I've put on the slide the current guidelines on the left side and the old guidelines from 2024. And the only difference between those two images is the red lines I've marked on the slide. So nothing has changed in the last 2 years. Now, in terms of volume, well, it's quite different when you have a maximum diameter of 2 centimeters, because a maximum diameter of 2 centimeters can mean actually 2 by 2 by 2 centimeters. That's a volume of 4 cubic centimeters compared to 2 by 1 by 1. That's a volume of 1 cubic centimeter. So it's 4th time the difference. So basically, it's pretty much important. Normally, it should take you 4 times longer to operate on that patient. And now I'm going to go back to my first study that I've presented from PLOS 1 in 2013 that actually established the threshold of 20 millimeters or 2 centimeters in one linear size diameter. And just to plan your surgery, well, with a standard home UMIAG laser, to perfectly dust a stone takes about 1 hour. So this means in 90 minutes of OR time of surgery, you might be able to perfectly dust 1.5 cubic centimeters. But for a stone that's over 20 by 20 by 20 millimeters, actually each millimeter over 20 adds an additional volume or an additional stone burden, because I'm trying to compete with the volume here, adds about 0.2 cubic centimeters of volume. So 5 millimeters more over 20 is 1 cubic centimeter more for the stone. That's a lot. That's actually a lot. So as take-home messages, well, try not to only use linear measurement of the stone to actually plan your surgery. Of course, CT scan remains the gold standard imaging for diagnosis of urolithiasis. And always for stones that are until 20 millimeters in its largest diameters, measuring stone volume might be unnecessary. Cumulative stone diameter or the stone area could be enough for a proper planning of the surgery. And over 20 millimeters in its largest diameter, calculating stone volume might be of more help, and it's probably not a waste of time. Otherwise, it can be a waste of time for your surgical time and, of course, for your patient. Thank you for your attention.
Thank you very much, Stefan. I think Bogdan, is your turn now. You do, now looking closely, you do have some hair, my friend.
Cu dimensiunea, cu stone volume, de prezentare stone volume. Da, da. So, all good? Well, congratulations first to my colleague. I have to tell you, I have such pleasure that we are here together, because I remember some years ago, as I'm not that young anymore, I remember doing the national congresses of urology, when we started talking about flexible uteroscopy, it was like committing a sin. It was so difficultly accepted in Romanian and urology that endourology is actually a solution, that we have to let go of open surgery, that this is the future, technological advancement, and minimally invasive techniques. And to those colleagues that are as young as I am, they can very well remember the debates that were quite, well, we felt quite lonely. And now I'm very happy that we're not lonely anymore. Even more so that the Teodor Burghele team is doing a wonderful job on flexible uteroscopy. Not only have they caught up, but they're there. They're in touch with the latest developments. And I have such personal satisfaction that we are here today in this joint venture for minimally invasive retrograde intrarenal surgery. Now, coming back to this debate is, well, it's not a debate to be won by anybody, because we're both right, because stone diameter is the most common, as I will show you, and it has been extensively reported in the literature, the more common way to assess a stone. But I will try also to show you some perspectives from which stone volume could bring additional information. Like I said, one does not exclude the other. Now, perhaps you did not know, I for sure didn't know. My son, my 12 years old son Lucas told me that there are stones moving, even in Romania, in certain areas, because of the physical phenomena involving water that changes the mass of the stones, and therefore by changing mass it changes position. Now, coming back to our own issue today, stone size can be reported in more than one way. As we know, we're living in a three-dimensional world. The guidelines, as Stefan so nicely described, still uses the linear measurement of cumulative stone diameter to stratify it up to 1 centimeter, between 1 and 2, and over 2 centimeters. But 2 centimeters is not 2 centimeters, because there's more than one diameter, and a spherical stone with large diameter all around has a much larger volume than stone that has different diameters depending from when you look at it, and therefore the stone volume will differ significantly. So a 2 centimeter stone is not the same regardless of the stone. Of course, the EAU guidelines, just as the AUA guidelines describe, we consider the largest diameter as a threshold for everyday practice and treatment choice. That's true. But there are a couple of issues that we have to tackle with in 2026. Treating larger stones, 2 centimeters or more, by flexible uteroscopy or short-wave lithotripsy is challenging. And the PCNL is still there. However, there's a higher risk of a follow-up procedure. So stage procedures, depending on surgeons' expertise and patient preference, can be a way to go. And the surgical planning, as I will try to show you later, does depend quite a lot on stone volume, because then you'll know what to expect from being able to treat that particular stone size. So, of course, we have this competition of techniques. Dusting, I think it gains more and more ground to have as fine dust as possible, to have the best stone clearance. But, of course, every endourologist who has done a flexible uteroscopy and lithotripsy knows that dusting takes time, okay? It takes patience. And in order to really try to replace SWL and not to mention PCNL, you have to come up with some pretty good outcomes in terms of stone-free rate, and to be able to show at least statistical similarity between the postoperative results, while tackling with large calculi, with difficult to approach calculi, with multiple stones. These are the formulas that by which you can measure the stone volume. As I mentioned before, CT, I think, is an integrant part of the patient evaluation for stone management, and it's here to stay. Unless you do it, you don't get the whole picture. Ultrasound is just for orientation, and by CT you can easily measure all stone diameters, lengths, widths, and depths. You have this formula by which you can calculate, and this formula roughly leads you to half of this product, basically. Also, there are segmentation softwares. Why? Because some stones are irregular, because the differences in stone diameters can be quite substantial, and therefore this software, taking into account more than one size, can give you a clearer overview. You also have artificial intelligence. I think we can all agree that artificial intelligence is a growing industry and growing expertise. I have seen it rising since, 2 years ago. I was really shocked. I was on a panel on artificial intelligence symposium session, actually poster session, and I thought, probably they just dumped me there because nobody else wanted to moderate that session. And then I saw in the first row, I will never forget it, my colleagues were laughing at me, literally laughing at me. And I saw the president of the EAU, the vice president of the EAU, the scientific director, the director of the scientific committee of the EAU, and it was all about AI. And 2 years later, we have almost half of the EAU annual meeting around AI, its performances. And one of the fields that were most likely it will succeed is that of numbers, okay? Size evaluation and numbers. And for stone size, I think it's doing a great job. I don't have it yet. We don't have it in our department. I don't know if there's any center in Romania using it for stone evaluation, but there should be, and I hope there will be in the days to come. Because the artificial intelligence gives you superior accuracy by comparison to any formula, okay? And especially for the complex stones. Stones that are more difficult to measure. And probably one day, the CT doctors, the imagists, will lose their job. That would be a very happy day for us, urologists. So the great majority of urologists are agreeing, and this is a survey that has been done a year and a half ago. The stone volume evaluation is superior, but that doesn't mean they really do it, okay? So the truth, like I said, it's in between, because it's easier to measure the maximum stone diameter, but obviously a more reliable evaluation is given by volume evaluation, which is not that difficult. Just have to get along well with the CT guy so he can give you the length, width, and height of the stone. And there are ellipsoid formulas. For auto-evaluation, Professor Traxe suggested this very simple method, and also there are computer automatic evaluation, more complex and of course more feasible. Now, why is it important? It's important because diameter increases the volume exponentially, because you calculate the volume, and therefore for an increase in diameter you have a multiple times increase in volume. And increase in volume means when you see the stone in front of you and you have the 275 microns fiber laser, then the volume of the stone in front of you will make a difference, will make a very big difference. And we come to realize that the number of fragments also grows exponentially, which means you see fragments all over the place when you're doing a harder stone, a larger stone, 2 centimeter stone. As those fragments will impair what? Your efficacy, your stone-free rate, even your safety, because you get to see less. And so 2 centimeter stone is not just double the complexity, it's multiple times the complexity, okay? And many studies emerging now have shown that. Now, this is an example on how you calculate a stone volume of a 2 centimeter stone and see that you can do it. You can do it in real time. You can do it in one procedure. Okay, in this case, which this case gives you an advantage because one of the diameters is 3 times smaller than the bigger one, the biggest one. So you'll have a shorter lithotripsy time, which is tremendously important because it determines our ability to break the stone in one procedure, okay? And that's the big difference in lithotripsy time that can make this case, because 25 minutes is not that long, that can make this case feasible even when we're up on the learning curve, okay? Even if we don't have 100 or 200 or 300 flexible uteroscopies behind us. Now, an increase of only 1 centimeter means 4 times as much in volume, and therefore 4 times as much in lithotripsy time, which means that some stones really cannot be efficiently treated in one session. And to set up patients' expectations, and to set up a treatment plan, and to avoid a puncture, and to diminish the rate of PCNLs and related complications has a cost. And that cost is state procedures. If the patient accepts it, can be one very good way to go, but you have to discuss it very clearly, very honestly with the patient from the very beginning. This is a comprehensive review. I also reviewed this in the publishing process for the Spanish Journal of Urology, showing stone volume estimation to be feasible. Either you do it manually or automatically with the software. Might give you a better representation of the actual stone burden. I think that's the key to this whole debate. When is important to know the stone volume? When the stone burden makes the difference, okay? Same as we discussed before about suction and all. The real difference is being made in difficult choices, difficult cases. Those that you are not sure you'll be able to follow through. So regarding ureteroscopy, stone volume was found to be, according to this study, which was a multi-center study, more predictive of the stone-free rate by comparison to the maximum diameter or cumulative diameter for stones over 20 centimeters. Look at those names. They're big names in endourology, okay? So these guys know what they're doing. The idea is that in particular, for large stone burden, stone volume actually gives excellent prediction, and the statistical significance is great, okay? This is another study in British Journal of Urology International, stone volume instead of maximum stone diameter, showing endourology experts, academic urologists keener to adopt stone volume in practice. Of course, it depends on how flexible you are or how open you are to new possibilities. While those at the beginning, they tend to overlook this parameter, maybe they don't encounter in their daily practice such difficult cases, but most of the urologists agree the stone volume gives you a better estimation. Either you do it or you don't do it. It's like the opera. Even if you like it, if you don't like it, you know, Richard Gere used to explain it very nicely in Pretty Woman in the movie, that it learns you something about yourself. Whether you like it, then you love it forever. If you don't like it, you'll learn to respect it. I think the same as the stone volume. You have to acknowledge it's there, even if you don't use it. This is a predictive model. Artificial intelligence, I love how this sounds, okay? A predictive model for the stone-free rate status using stone volume. A variable importance show total stone volume as the strongest predictor for the non-stone free status, which are cases where our success rate is not excellent, where we leave residual lithiasis behind, and for these cases, stone volume is the best predictor. We have kidney stone calculator. That's a 3D extension of the 3D slicer. It's a software, more or less. Stone burden being evaluated better by stone volume than the cumulative diameter. Within this platform, within this calculator, you can do this online. It's not that complicated. And you can use this mathematical formula and get to a predictive outcome. Okay? This is another study, also very interesting, that compares the ability of artificial intelligence to detect and measure kidney stones volume. And the AI calculates the volume of kidney with a average difference of 80% when compared to the volumes that are being calculated by radiologists. It gives me much pleasure to show you this, because I'm not very fond of imagistic imagist doctors. I kind of feel they're a little like artists, you know. Either they have a good day or a bad day, and that really impairs on the quality of your day. So by integrating the artificial intelligence with kidney stone detection and treatment, there's the potential clearly for greater diagnostic procedure and to predict treatment effectiveness. 2025, already we're talking guidelines. Yes, I showed you the guidelines that did not change yet, that still get a little bit stuck to the stone diameter. But the French Urological Association guideline is a little bit more progressive, confirming stone volume as a better predictor of the stone-free rates, and automation through AI might improve both accessibility and precision. Because the problem is accessibility, is how much time and effort you're willing to put into calculating this stone volume. So the French ULTS guidelines since 2022 up to now kept this procedure. And last but not least, this is a progress that might be considered revolutionary, a strong recommendation for CT evaluation by the American Urological Association guideline, showing non-contrast CT as the most reliable imaging modality for evaluating story size and volume. And the volumetric measurement may be obtained through CD segmentation software and artificial intelligence algorithms. And they can predict, very importantly, operative time, treatment outcomes more accurately compared with conventional linear measurements. I think this is, more or less like a conclusion on this topic, because as we know, American medicine has been at the borderline of progress at least most of the times. So let's look at this problem from all points of view, including volume, because as I've shown you before, we're living in a three-dimensional world, and I think it's better that we do so. Thank you very much.
Good. Thank you very much to both of you. We are out of time now. I'm just going to try, we won't take any questions or comments on this one. I'm going to try and summarize. Stefan has shown that probably up to 2 centimeters length and depending on the location, we may be okay with just not measuring the stone volume, but over 2 centimeters, we should definitely do it. Bogdan has shown that actually it's quite useful for any type of stone. From my perspective, the conclusion is that irrespective of what we discuss and debate now, probably in a couple of years, CT scans will be reported by AI and stone volume will be automatically incorporated, and AI will even be able to give us how much time are we going to spend with a certain scope and a certain sheath to take that stone out, calculating the ratio between the scope and the sheath. So thank you very much to both of you. We're going to move to the next topic, where I invite Daniel to moderate a round table on some complex stone cases. The panel would consist in, again, Bogdan, thank you very much, Stefan, thank you, Alberto, and myself. Do we have one more microphone? Four. Okay. So give one microphone, please, to...
Thank you, and to Alberto.
Then I'll share my microphone with Stefan.
Okay. Pui cazurile? Stau aici. Can you tell us about the history of this case, Israel?
This is a young patient who presented to the OR at our clinic. He had a double J stent mounted about 9 months ago.
In another hospital?
In another hospital, yeah. And he presented with this CT scan. And yeah, that's pretty much the case. He's a young patient, 24 years.
And this one is the patient CT. It was a very young patient, I think 24, yeah.
Anything else about the patient's history? Is this his or their first stone? When was the stent inserted? Did he have any other surgery before?
He was 9 months ago, I told you. He presented in another hospital with a renal colic on the right side. It was his first presentation, first admission, and that's pretty much it.
His uroculture was negative. How you would treat this stone? Because the double J stent was calcified, I was not able to remove it, not to extract it. I saw the distal part of the double J catheter, but the burden of the stone on this part was significant, and I was not able to extract it. How you would proceed?
One question. The patient has urine culture?
It was negative.
Was negative?
Yeah, the urine culture was negative.
Yeah. In this case, in my department, we perform endoscopic combined surgery. Okay. We try to treat the calcification around the double G stent by ureteroscopy. And in the same time, we try to perform percutaneous access to treat the kidney part of the stone.
Okay, Alberto. But it is also possible to treat the distal calculi on the distal part of the stone using shock pulse or the lithoclast in order to have this distal part free of any calculi. And then to take out this part, to fix it with a grasper or something, and then to advance with a semi-rigid ureteroscope on the ureter along the double J catheter until you reach the upper part, the proximal part of the double J stent, and then to try to fragment it with a lithoclast or shock pulse, and then to extract the calculus, then to insert a ureteral catheter. It is also possible?
Yes, I think so. I think that I usually don't cut on the double G stent.
Yeah.
Usually I try to treat retrograde the calcification until I arrive, and then simultaneous way, entonces que I perform a percutaneous access, I treat the stone in the kidney. I try to go down in the ureter, trying to extract the double G stent for the
in
percutaneous
an
access.
antegrade manner. We try first to extract it in a retrograde manner, and we advance with the semi-rigid along the double J stent until we reach the renal pelvis, but it takes too long to fragment all this important piece of calculi, and then we perform the PCNL and extracting the double J stent antegrade.
It's also more difficult to maneuver the scope along with the double J stent.
No, when you have a patient with a catheter that is left in place for 9 months, the ureter will be very dilated, and you can introduce even a larger semi-rigid ureteroscope along the double J catheter.
No, I mean inside the kidney. Inside the kidney, if there's if that calcification is prolonged and you cannot reach it with the semi-rigid, and you need to put a flexible scope, you can try that. It's possible. But I mean, why not?
It's going to take a lot of time.
Yeah, it takes a lot of time. But only to avoid the percutaneous traject. Depends. You can try it or not try it. Of course, the fastest and most efficient is the percutaneous.
And you can't leave the patient stone-free if you are choosing for a
More
retrograde
likely,
approach
yeah.
in these cases. But as a demonstration, we wanted to show that it can be done. But in this case, when you have a large burden of the stone in the renal pilocalicial system, you can't leave the patient stone-free.
It's correct, everything that you guys said. A couple of considerations. We all got lots of these cases with COVID. There was like an epidemic of encrusted stents. And you have to think of it every case differently. So it will take a very long time to go alongside this. You can do it. And Dan's observation that the ureter will be quite compliant and large, that's very correct. And my advice is to try and take advantage of actually of that. So instead of, because you know for this one, you'll have to go percutaneously because the kidney burden is huge. So instead of losing time and trying to go with a scope alongside the stent and reduce the calcification on the ureter, you start simultaneously, one surgeon on the kidney, the other surgeon on the bladder, you clear up the bladder end of the stent. Once you clear that up, then you try gently to pull the stent out through the kidney. So you try to pull it out in an antegrade fashion, and you would be surprised that you can take out stents with severe incrustations that otherwise you would spend like 1-2 hours to cut them out if you do it this way. Obviously, you may not. But this would be the first thing to try. And then if this doesn't happen, then you try and break everything alongside ureter upside down. But it's also safer in terms of ureteric avulsion risk to pull it out from the kidney rather than pull it down in the bladder. Okay? So don't waste time trying to reduce try first, you may be lucky and you may be able to pull it out through the kidney, and then you really save a lot of time.
We presented this case in order to suggest that you don't have to waste time. You have to go with the PCNL and try to remove it in an antegrade manner.
Any other comments from other experience?
It's for sure a nightmare case. So anytime you get this case, it's not easy to fix or to handle. Well, my main point here is that you've mentioned something very interesting: negative urine culture. Do you think it's that important in this case? Because in a patient with a 9 months, yeah, I'm sure it was negative. But in a patient with a stent that's placed for 9 months that has obstruction in several calyxes, like it's seen on the CT, given by the stone itself in the renal pelvis, also by the stent that has an obstructed ureter, I guess the most important thing for this patient is not the way you handle the case, but the way you warn the patient about the septic risk, because for sure he has a septic risk. I would, of course, also go in a retrograde fashion until I can reach it. Well, I'll stop at the level I can maximally reach, and then percutaneously, but maybe through a stage procedure. So maybe do as much as I can from the bladder, the ureter, then place a nephrostomy tube inside the kidney, drain the kidney, and in a secondary time, go with the percutaneous access for the rest of it. That's just a comment. Yeah, for sure. In life, everything's possible, but it's very important for the patient to know that. Yeah, that's the point.
You saw that the majority of our cases in PCNL are left only with double case stent, so not totally tubeless, but tubeless PCNL. But in this case, I will leave nephrostomy.
And this is because you fear the septic risk, right?
In this case, it's very difficult to finish the stone in one step, so I think that is a good option to. Yeah.
Okay, so for the second case, it is a male patient, no urological past history, and it was an incidental finding of a calculus. Here is the CT scan, and what you can see here is that the left kidney is malrotated, and it has a lot of cysts. You can see the kidney stone. And here is the 3D reconstruction.
You see the orientation of the posterior calyces in this case.
What's a bit strange to me is that you said no raised inflammatory markers, no nothing. But if you look at, if you put a CT scan back, you'll see that if I'm not wrong, the wall of the pelvis is very thick. So there was a lot of inflammatory reaction there. So yeah, it's quite very thick. So no evidence of active infection. Okay, fair enough.
How will you resolve this case? In prone, in supine, combine, exerts? How you are going to resolve it? Alberto, I know what I've done, so I look for your opinion.
You said it's malrotated? Daniel, is malrotated and it has cysts, okay? I would do flexible.
Combine antegrade and retrograde and exerts.
Okay.
Patient placed in supine position, and I went also with the flexible ureteroscope, and the patient.
And you managed to avoid puncturing the cysts because they can bleed quite badly.
Okay, but you can avoid it by using the ultrasound when you are doing the puncture.
Okay.
What was your access for
The inferior callus.
Do you remember which callus did you aim for?
The most posterior and inferior one, as always. In supine.
For me, supine as well. Yeah.
Over 1,000.
In this case, I perform, first of all, to operate the patient a renal gammagraphy. I think that is important in this type of cases to know the previous renal function, because sometimes the surgery deteriorates a lot the renal function.
We are performing a lot of scintigraphy in this patient, and in this patient had for certainty scintigraphy, but we didn't have time to.
And did you go through the cyst or not? You avoided the cyst?
Yeah.
So, Alberto, would you be against going through a cyst for a PCNL?
Sorry?
Would you be against going through a cyst when you do a PCNL?
this case?
No, generally.
In general, to assist?
So going through a cyst, if the cyst is in front of you but still that is your preferred way to go into the calyx, would you have any issues passing through the cyst?
I usually I like to make the dilation dilation of the tract in the calyx only, and then I advance with the scope.
If the cyst is in between, are you happy to go through it and then go into the calyx?
Yes.
There is no problem.
Do any of you empty the cyst first, or you don't bother?
We are not bothered. Okay, Remus, the next case.
It's a female. The third case is a female patient, a young female patient. She presented to the OR with the left renal colic. No past medical history, no evidence of active infection. But we performed the CT scan.
And we have this image on the CT scan.
Okay, so first look, native, nothing suspicious. A really small calculus near the bladder. But then,
after injecting the contrast,
well, things change.
have you seen something like this?
That is spontaneous rupture immediately.
So, without any maneuver performed, this is a CT scan after injecting the contrast prior to any surgical maneuvers.
Radiological iatrogenic.
Yeah, I see. Yes.
What's the management plan?
We play, Albert, I know what I've done and I will tell you. What is your management?
What was the CTE result, the evaluation?
We have a large extravasation of the contrast or perforation of the pilocalicial system. And you have this calculus that is on the distal part of the ureter. What are you going to perform? A semi-rigid, a flexible, or you are postponing the surgery?
At most, a double G stent in place, and then we'll see.
Would you place a guide wire with this perforation?
Well, I would do fluoroscopy. I will do contrast injection should or if
you already have contrast because you performed the CT.
No, during the cystoscopy, you can tell or if it's approach, then contrast injection, see what's going on with the upper tract.
You already had on the upper tract this extravasation of the contrast.
Yeah, you don't really know where it starts. You don't know where the fistula is. Not on this. You will see on fluoroscopy.
It matters?
Of course it matters, because then you get to, you might have a little bit of evaluation if you have a chance to go with the guide wire all the way to the kidney, or you end up in the fistula. So I would try at least to mount the guide wire. It depends, of course, on how strong the colic is, what the symptoms are, because if it's well tolerated and it's not a big hydronephrosis, you can wait. You can do conservative treatment, but if it's an aggressive colic with fever and beginning of a sepsis maybe, or a large hydronephrosis, then you really need to stent it. And the most minimally invasive, I think, is the best. So I would do fluoroscopy, and on fluoroscopic control, try to put the guide wire in the pilocalicial system, and the stent in place. Best case scenario. Worst case scenario, I don't know.
How you would manage this case?
In this case, I had a similar case 2 weeks ago, and in this case, I insert a nephrostomy tube, and then in a week or 10 days after, I perform a pyelography to see what is the problem of the extraction.
We will show you our images. So we have placed a nephrostomy tube. We already had the contrast in the in the upper part of, it was not very easy to place the nephrostomy, but we placed it. An 8 French, not the other one, 14 French. We placed an 8 French nephrostomy tube. We left the patient for 2 weeks and then we performed the ureteroscopy. So it was not very easy to find because it had some very small calyces, but we were able to place the nephrostomy tube.
Yes, Stefan, please.
For the audience at least. So you solved the case in a retrograde fashion after placing a nephrostomy, and that's what I would have done for sure. Just a quick question. How long will you keep the stent in place after this case? You didn't leave a stent? You just left the nephrostomy and that's it? No. I'm talking about, from what I understood, maybe I didn't understand enough. You had a stone near the bladder, right? You didn't get the chance to treat it yet.
After 2 weeks, after the
Yeah, I do agree. So let's say you're going to solve the case perfectly, and you'll put the JJ stent inside. How long will you keep it? For how much time?
2-3 weeks in order to be safe when you are performing the
2 or 3 weeks. Okay.
So you would expect that 2 to 3 weeks after this, the ureteric or renal pelvis or whatever would have healed. Yeah, if you want to be extra safe, you will live it a bit longer. There's nothing to lose, so you would live it a bit longer.
Perform a conscious enhancement study after removing the stent in this case? Same radiologist?
So the learning point here is that though at this stage the patient is not in renal colic anymore because there's no pressure, this kidney has to be drained, and you need to drain things in one way or another. I know that you are very much, and I think nephrostomy is very okay, but it's not an easy nephrostomy. Okay, so that is good in expert hands and so on. On the other hand, a gentle retrograde approach is not going to make a huge damage if you know how to do it, and you can still try and put a stent. So I wouldn't exclude what Bogdan said, that you could do that, and you should be prepared, because irrespective of how skilled you are, you may not be able to put a nephrostomy. It's not, I would say it's a low chance if you're very good, but it may still happen. I've seen it happening. And also, obviously, it depends on the patient. If the patient is stable, if the patient is not septic, and so on, then your chance to do a retrograde, even to sort, if it's a small stone, you can even take it out in the same setting if you don't use pressure and so on, it's still not completely out of the question. But I agree that would be the safest thing to do and to try. Start with this. If it doesn't work, stent. If that doesn't work, then you're in trouble. Anyway, nice case. Thank you.
We take also in consideration in placing a double J stent, but our first choice was to place a nephrostomy.
And the main problem in retrograde maneuver is that you can infect and the urinoma. So in these cases, I prefer to insert a nephrostomy because always there are some or any dilatation of this collecting system. So it's not so difficult to insert a nephrostomy in these cases because always there are a dilatation of the system.
The dilation of the pilocalicial system was minimal, and
There wasn't too much on the CT scan, at least.
it was minimal.
Oh, you can ask the radiologist to put
Okay,
more.
but the last case is the most interesting one.
Yeah, go ahead.
You don't have to leave, stay here. We need your opinion because the patient was treated in UK first to come in Romania. It was a Romanian.
Okay. So this last patient is the youngest one, and it's a male patient. He already been through 3 episodes of urosepsis. And in one of the hospital, he got a Klebsiella that does not have any antibiotic sensibility. He has bilateral urolithiasis, and this is the CT scan. On the left part,
Laurian, this is the CT scan of the patient. A very young patient, 27 years old, with a Klebsiella urinary tract infection, sensible only to cefiderocol. It was the only antibiotic that was available for the treatment. It's 4,000 pounds for one.
It's expensive. It's the nightmare of all public hospitals. When I see a referee,
How would you treat this patient?
I wouldn't test it for cefiderocol.
I'll send it to you. So you can see on the right side, the patient has a double J stent and a lot of large calculi on the ureter. And on the left side, he has a minimal nephrostomy tube, but very large calculi on the ureter. What you should do? No. Switch back.
Let's begin with the legal question. So this is a patient with a severe infection, right? Okay.
He had 3 episodes of sepsis shock prior to arrive here. He was treating in Balch and Balch Hospital.
Okay. We are all
3
surgeons.
times.
We are all surgeons. We don't like malpraxis. So let's think what would be the best circumstances that we would consider suitable to do any kind of surgery to begin with.
What kind of surgery are you referring?
No, before you touch the patient, what would you be your best circumstance in order to consider yourself at least partially malpraxis safe, starting any kind of procedure on a patient like this? Because this is a very actual talk. For example, you will find many American urologists that will actually start surgery in this patient for fear of lawsuits.
Okay, but it was a very young patient. He has 27 years old. He was refused by all the other hospitals in Bucharest.
Okay.
Okay? I could send him home without any problem, but the patient will die. He had already three sepsis shock.
Yeah, okay. How many days
times do you think that will resist?
No, I fully agree that something has to be done. I was just asking you as a therapeutic management, because we're doctors, we're not just...
In this case,
to reduce the risk of sepsis, what you should do?
In this case, my first decision is to use L-methionine or similar, or acetohydroxamic acid, entonces que for reduce the possibility that the stone increase, and as well to treat with antibiotics and increase the effect of the antibiotics, entonces que for this case. And for avoiding the sepsis in these patients, perhaps I plan a step treatment, a stage treatment. I started perhaps in the left side with endoscopic combined surgery, with a retrograde intrarenal surgery, and I will make a percutaneous access, entonces que for drainage, and for try with an indirect access to try to treat the calcification of the nephrostomy and reduce the time of the operating time a lot for reducing the sepsis risk. In a second step, I treat it.
First of all, I dilated the nephrostomy on the left side, and I placed a nephrostomy on the right side of the patient. And I dilated this nephrostomy progressively in order not to have... I started with an 8 French, and then I switched to 12, and then to 14, until I reached an 18 French nephrostomy tube on bilateral.
So Dan, just a sec, for the young guys, when was the first PCNL or percutaneous approach done ever? Was the first series or case reported? 50 years ago, 1976, Fengstrom. Do you know how long it took them to dilate the tract? Because that's exactly, 3 weeks, progressive dilation, and then they did it blindly with just a grasper into the kidney. So yeah, progressive dilation may still remain an option in this kind of cases. Also, sometimes there are case reports. I've done it only for encrusted pyelitis, but you can do what's called a dual drainage of the same kidney. That keeps, it's the safest way to keep the pressure very, very low. So you puncture upper and lower calyx, so you have a continuous flow. I'm curious to see what you've done farther
Then
on.
I resolve the calculi on the right ureter, and then I perform an antegrade PCNL in supine position. You can see how the calculi on the left ureter, huge calculi, have been resolved with the shock pulse. And then I have placed a double J stent antegradely, and I still left the nephrostomy tube for 2-3 weeks. First I took out the double J stent and then the nephrostomy. I stopped the drainage on the nephrostomy for 2-3 days, and then I extracted. And then I started to do flexible for the right side. I would like to show you on the right side how the kidney looks when you are doing flexible ureteroscopy, and the final result if Remus has any X-ray, any KUB. Oh, I will show you in my office, I have pictures. But it looks very strange because there are, on the right kidney, there were a lot of calculi, but in some chambers, I had to cut the wall of the chambers in order to reach all these fragments and to extract them. It was very difficult. It was a very difficult case.
So how about the management before the surgery? Wonderful surgery, congratulations, but did you have a multidisciplinary team with an infectionist?
Yes, of course. I presented the case, and I tell everyone that this case will cost our hospital a lot. And the specialists in infection disease from our hospital helped me with cefiderocol and all the antibiotics in order. Yeah.
Good. So, thank you very much, Dan. Very nice cases, well chosen. Thank you for the good discussion. And yes, at some point, someone has to, as the British are saying, bite the bullet. So you have to try and do something. And in this case, you succeeded, so congratulations. We are a bit late now. If you guys are too tired, I can skip my lecture because my promise was that we will finish in time. But if I go ahead, we won't finish in time. Are you still happy to go ahead? Yeah. We will exceed by 10 minutes. Is that okay? Good. So what I'll try to briefly talk now about is what's interesting, what's new, what's the current status, what are the new things in endourology, and especially in kidney stones, because this is what we are focused on. Let me see, does it work? Maybe I'm a bit too far away from no, it isn't. So you've already seen these images. I'm going to run very quickly through them. These are they are still the current scopes. They are the same for the last 5 years, more or less. You know the pros and cons of all these things because we went through them. So I'm not going to repeat. We have the very thin scopes now. We have something else. If you remember, there were different ways of enhancing vision on the reusable scopes, like the system on Olympus and the system on Storz. Now, also the single-use scopes have this kind of digital processing of images that should help us to identify tumors a bit better. And as far as I know, this is the first scope that has actually come with this, and this is a single-use scope. So, and there are a few others that are working on the same system. So it's not NBI, it's not the same principle as the Olympus NBI. It's more similar to the S technology from Storz. It's a digital processing of the image. What else? And this is about cystoscopes now. As you know very well, flexible single-use cystoscopes are a reality. If you think a bit, it took much longer for these devices to be implemented. And I'm going to ask someone who's young but not very young, so one of the young specialists, why? Who's a young specialist? Spune-mi, tu cine e care e special? No, știu, cine e young specialist? Quickly, Mihai. Tudor. Tudor, perfect. Why it took much longer to have single-use cystoscopes rather than single-use ureteroscopes? Yeah. What do you think? Think. This is what I want from all of us, and especially from the young guys, to think. And your friend already gave you...
It was much more cheaper to do a cystoscopy with a standard cystoscope than with a flexible one, and with a reusable one.
Okay, Stefan. Yep, that's okay, but
this has to deal also with the type of anesthesia that is performed. So you can do cystoscopy with local anesthesia, with reusable cystoscope, yeah, and of course it's all about the money. It's very
guys. It's follow the money. A reusable cystoscope doesn't break, so you can use it 500 times. Unless you break it, you want to break it, you can use it 500 times. Reusable ureteroscope, it breaks very easily. So how much should a flexible cystoscope should cost to allow it to be economically feasible? It should be very, very cheap. Companies that don't like cheap products. Okay, with cheap products you have a very low margin. The more expensive the product, the more successful. The most successful device in urology ever, economically, do you know what it was? The Da Vinci robot. The most expensive. So always think like this. If you go to a company with an idea, look, I've got this thing. It's going to be extremely cheap. It's going to cost no money. It's going to save us a lot of time and it's perfect. They will just say, okay, thank you. No one's interested. So follow the money. That's the idea. So it took much longer to have flexible single-use cystoscopes than ureteroscopes, but we do have them. They are very cheap now. And they are almost at the level where if you put all the costs together, honestly, it may be cheaper to have a single-use flexible cystoscope. But on top of that, what's new? What did I put in there? If you look at the handle, what do you see? And you can see this on every scope that I've put there. Suction. So they also have suction. What does it mean? It opens the gate for a new thing, so you can potentially even treat, I wouldn't say large bladder stones, but small bladder stones under complete local anesthesia with lasers. Why not? You can aspirate. It's going to take longer, but still you can do it in your office rather than in theaters. What's next? Oh, sorry, I'm going back. Bogdan already mentioned. I'm not gonna talk too much about this. But now, finally, after driving our cars, I love this example. You know, they say, "Oh, do we need to measure the pressure?" No, obviously we don't, because we didn't do it for so many years. But it's like you have a speed limit. We knew about the speed limit. You drive the car, and actually you know on your foot that I'm not crossing the speed limit, but I have nothing in front of me. to show me what is actually my speed. It's just how I press the pedal, how the trees alongside are running. You understand what I'm saying? And now you tell me, oh, I don't need this screen to show me my speed. Obviously, it's not just you need it, you will all have it. And probably I won't retire until it's going to be illegal not to have it. So yeah, the intrarenal pressure sensors are here, and they are here to stay, and they will be with you guys, the younger guys, forever. But what we did is very primitive, you know. How do you know your speed? Because I'm just pressing a bit on the pedal, not too much. Yeah, now this is your way to actually know the speed, know the pressure. And this was the first one, single-use LithoView Elite, the first one in the Western world, let's put it like this. And a few things were quite obvious. If you use no access sheath, the pressure will increase. The larger the sheath, the lower the pressure. Another very interesting thing, another obvious thing is that the more things you put into the working channel, the less pressure you'll have in the kidney because the flow will be. So with the fiber, the pressure is not so high, okay? But the last one down there, and I can't point on it, but it's the lower graph there, is quite interesting. What do you see? What would you expect? So if you put the sheath, and this is not with a suction sheath, with a standard sheath. If you put the sheath in the renal pelvis, obviously the intrarenal pressure is very low. Yeah, everything goes out. If you put it in the PUJ, as we were taught to do it, just put it under the PUJ, actually the intrarenal pressure was higher than compared to having the sheath just in the distal ureter, not in the mid-ureter. Does this sound logical? It doesn't sound at all, but this was reality. Now, it's a very biased reality, because you don't know if the surgeon actually did exactly what I told you. It's very important. Did they actually control the sheath all the time against the scope? It's probably not. Because what happens? You have the sheath very close to the PUJ. The PUJ is tighter. It's the scope. I'm going to put this down. Yeah. So it's the scope, the sheath over the scope, and the PUJ that gets tight. The scope goes through the PUJ, but someone who doesn't control the sheath will pull the sheath over the PUJ and will invaginate the PUJ in the space between the sheath and the scope. And that rises the intrarenal pressure. While if you keep it at a safe distance lower down, this is not going to happen. This is my only explanation for this thing. It may be right, it may not be right. Now, Happiness Works, okay? That's a very nice name. Like Build Your Own Dream, another very nice Chinese name, BYOD. BYOD is now the largest electrical car company on this planet. Happiness Works is, yeah, true. Happiness does work. If we are happy, everything is good. But this is actually, again, a scope, a Chinese scope with a pressure sensor, and for the moment in Europe or in the western part of the world, they only have the measurement system available, but in China they have something more, and we'll briefly talk about what else do they have. But then I'm going to show you a very dull scope, isn't it? It looks very not attractive in any way. Okay, and that's a new Chinese scope. There are others as well, but this one is going to be available on the European market. And it has not just the intrarenal pressure sensor, but also a temperature sensor. I'm not going to go into the debate if that is useful or needed or not. Now, Bogdan already told you about the direct in-scope suction, the disc part, and I hope now our younger colleagues understand the difference. This is when the suction is applied directly, as you see there, through the working channel of the scope and whatever is aspirated, it aspirated through the scope, through the working channel. Fans means the aspiration is alongside the scope through the sheath. Yep. No, I'm not going to insist on this one. I'm not going to insist on fans, but this is the other way. Yeah, the suction now, everything what's sucked is, you see the scope is there, the small thing in the middle, the sheath is the large thing, and the stone fragments are aspirated in between, through the sheath, in between the scope and the sheath. Very easy and nice concepts. I'm going to jump all these things. You've seen them, they are very familiar now. These are just a few tips and tricks on how to manipulate them. But this is the future, actually the present. And it has been the present in China since, look down there, 2019. That's 6 years ago, but 2019 is when it was published. The studies that they did was 2017. So they have it for 8 years. So this is actually how far ahead is the Chinese innovation in urology and endourology compared to us, to Europe. We've been continuously shooting ourselves in the foot with absurd bureaucratic regulations. We are all concerned and we care about our patients' safety, but we lost any common sense in how we should promote innovation. This is my personal opinion. I may be wrong. And this, what is this? This is basically a system that doesn't just measure the intrarenal pressure, but controls it. So if you set a limit, it will keep the inflow and adapt it continuously to the intrarenal pressure to keep it at a certain limit, or at least not to bypass. The initial models were just keeping it below. The new AI-powered devices, like the ones that I'm going to show you, will keep it constant. You understand the difference. One thing is not to hit over, the other thing is to stay there. Yep, to keep it constant, which is more or less what you need, because otherwise the system will collapse. Okay, that was the first one, and then another one, and this is what we have currently. If you look up there, the two images is our system that only measure. The lower two images, ZSR and EGAO, are the ones that are available on the European market now. They both got the CE mark. EGAO end of 2025, ZSR December 2025, EGAO February 2026, CE mark for Europe. This for you guys, this is like the primitive thing of what you're going to use when you're going to be my age. Or not my age. When you're going to be my age, maybe urology is not going to exist. These are the systems that keep the pressure constant in the kidney. The sensors are on the sheaths. Okay, so you see the sheath there, flexible sheath. The pressure sensor is on the tip of the sheath. They are not perfect, but this is not the future, the present of endourology. And I promise you, everywhere you'll go from now on, every endourology meeting, this is going to be probably the hottest topic. Good. So you see where the sensor is. You have the arrow there. What else? Yeah, these guys, they also have the same thing. So they can control and monitor the pressure. Not the temperature, though. They can, because that is a completely different issue, and you don't really need to, from my opinion. But you can monitor the temperature continuously while you can keep the pressure constant. So watch this space. Now the CVAC system, that was the initial build of the system, which was basically a steerable sheath manipulated under radiological control. Very primitive, but it was still working. But not this one. The new thing is probably, the first, let me see if it works if I press on it. Yeah. So I'm not going to talk too much. You'll see the idea. You'll get the grasp of the idea from the video. It's basically suction. It's a large device, a kind of a scope that has inflow and outflow through the same device and aspirates fragments as you work. Okay, so the inflow is lateral, the suction is through the scope and allows you to, there's no additional sheath, it allows you to sort the stones very quickly. There were issues with this device, and though the concept is what we've been thinking of for many, many years, and it works, they sold a lot of models, a lot of devices in America, and it is, again, the future, the present. There were issues because of one thing. And who can tell me what that one thing is? Tell me.
Maybe the pressure?
Exactly. They couldn't measure the pressure. You have to have this high inflow. If the system gets blocked, there was no way to know that. So they had this inflow ongoing because there was nothing to block the inflow, while the outflow of the suction channel got blocked, and that led to high intrarenal pressure, which led to sepsis and deaths. Okay, very directly. So that was the issue. They will most likely sort it out, but otherwise a very nice system. And this is what my friend and mentor Olivier Traxet has been working on for many years now, and it is going to be probably a huge breakthrough in endourology once it's done, because it has everything. It has the pressure control, it has the suction, and look how it looks in vitro. It's impressive, isn't it? Once we'll have this kind of device, yeah, obviously it's going to cost a small fortune, but it is going to take an even larger bite of the PCNL kingdom, though not all. Good. So I'm going to jump over the pulse modulation. You all know about it. We don't have time to go into details, but there are infinite ways that we can modulate the pulse of the laser. Any one of you can invent one, go to a laser physicist, and you can modulate the pulse. You say Mihai's modulation or whatever, but what is the real clinical benefit? This is very debatable. And for the younger guys, also for the older guys, why? Because in the lab, all these pulse modulations are perfect. They work because it's physics, and they will work. The problem is the lasers are extremely dependent to the distance to the target. In the lab, the distance to the target is continuously the same. Yeah, so that's why it will work. When you translate this into real practice, this is impossible. We hit the target out of, we laser 10 hertz, 10 times per second. How many times, there's no obvious evidence, but how many times do you think an experienced surgeon actually hits the target with a laser? Me, probably once, if I'm lucky, twice. Otherwise, the distance, and every hit is going to be variable in terms of, because the distance is going to be continuously different. So this is why, though in vitro, pulse modulation is perfect, in real life, the effect is much limited by our ability to keep the target at the same distance. You can call it whatever, vapor tunnel, virtual basket. And again, this is not false advertisement. All these effects are real in the lab. Now, TFL, we've discussed about TFL. It was the new kid on the block for many years. I was lucky enough to actually study the prototype, the IPG prototype with Olivier in Paris in 2015. Now it's the third generation, and this generation is going to try to address the problems of the TFL, the low peak power, meaning that the fragmentation effect is not so good as with the higher peak power lasers. And they are trying to sort it out, and they will probably, this third generation will be able to improve that by changing, it's basically a new optimized pulse or structure of multiple pulses. You'll see it, and it works, at least in what has been presented so far, it works quite nicely, and you can achieve fragmentation. but still there are features of the lasers that you can't change. The peak power is still in that range. The Tullio, you guys have it, you're lucky, you're not very convinced of it. I honestly love it. I've been using it for almost everything as a new toy. You know, I've got all the lasers, I'm very lucky. Because it's in between. You've got the amazing cutting and coagulation properties from the thulium, but you also have enough peak power to break stones for PCNL, to break stones for bladder. Bladder stones go very well. Enucleation, to me, it's
We are
very
using
good.
a lot for stones. We are not using for enucleation.
I know you don't like those bubbles, but
We
it's a
don't like
distance
those.
problem. You know, if you get into the right distance, the bubbles are gone. No, I'm not going to go into details, but this is a pulsed thulium YAG. It's not a fiber laser. It's a YAG laser, a crystal laser, but instead of being like the standard thulium, a continuous wave laser, it's a pulsed laser. I can talk about lasers for hours, or I'll stop here. This is more or less of a graph showing the differences, and actually the Tullio should be in between. It's in the middle, and it takes benefits, or I would say the best out of both worlds. However, any of these lasers, if you know how to use them, they will be quite useful, and you can do whatever you want from them. What's the new thing? I think Leia told you a lot about the Magneto, the Cyber-Ho. This is a high-power laser. So it's a holmium YAG laser. It's a lamp laser. It's not a diode laser like the thulium fiber or the thulium YAG. I'm just going to jump to the... It's like having this laser is like the difference between piloting a plane for one of those small planes where you have like 3, 4, 5 things that you have to change. That would be a normal laser. If you get this one, it's like really piloting a new big aircraft where even the ceiling of the cabin is filled with. So it has so many features that you can change and adapt that it becomes very difficult for someone who doesn't really love lasers and know a lot about them to put together all these combinations. But it is an amazing tool, an amazing device, and what's amazing about it is that basically the engineers, you see how many pulse modulations, how many pulse lengths are all together, and a combination of all these things is actually available. If you have a combination of 5 with 3, it's not 15 times, it's much more. So what's the wonder here? The wonder is this, and this is again one of Olivier's slides. You see that the huge peak power of the holmium, the engineers managed to tame it and keep it in the range of the thulium fiber, around 500 to 600 watts. But it's like putting a tiger in a cage, because you see, it's not a linear deliver of the peak power, of the power. It still goes like this, but it stays in that range. What does that mean? We didn't have time to discuss about lasers and peak power, what's the benefit or not. It means that you will have an excellent dusting ability. They advertise it as good as thulium or thulium fiber, actually, which is probably very close to reality if you look at how the peak power looks like. Good. Quickly, from Alkan dilators, and you see that guy there, you can still meet him at congresses. If you do, go and take a picture with him. With me, it's a bit more just meeting him at congresses. I can even call Peter a good friend. He's an amazing guy. He will talk to you. He will be but he's a legend. So this is Peter Alkan, the guy who invented the Alkan dilators. But from there, now we've moved to a different thing, and though it's much more expensive, probably for you guys when you do PCNLs, the balloons are still the safest thing. I'm going to jump over this, and yes, who can name any of the guys in the picture down there? Not you, Alberto. Not him. I'm going to start giving you a clue. because all these three legends of urology, really legends of endourology, are Spanish. The Spanish endourology, it's a force in Europe. These guys are really, really good, but they are on the shoulders of giants, and these three are giants of endourology, and any endourologist should know them, and they are still alive. You can, if you're lucky, you can still meet them. Any clue, any guess? Huh? So, the guy in the middle is Gabriel José Valdivia Uria, so the guy who actually changed the way that we do PCNL. The guy on his right is, yes, exactly the guy Gaspar Ibarluzea. What did Gaspar do? You were right. This is the guy who modified Valdivia's position, but he was very modest. He didn't name it the Ibarluzea position, but he named it Galdacao position from the city where he, and the hospital he was working in Spain. But what about the other guy? It's also Spanish. Huh? Yeah, correct. But what about the other guy? Huh? Come on. To me, that's the legend of legends. So this is the first person who ever did a ureteroscopy. Okay? His name is Enrique Perez Castro Erend. Perez Castro. Look, 1980, first Congress, EAU Congress in Athens, half of the people in the room started to boo him. This is fake. It doesn't exist. You overlapped an X-ray, and it's not correct. 1980. Good. Tract size, what's new? Nothing is new, because since it's 2025 now, and all these things, all these guys, and again, I would encourage all of you to meet them and to talk to them. Guohua Zheng, Super Mini PCNL. Janek Desai, I'm starting from the left side of the screen to the right. Janek Desai, 2012, Ultra Mini PCNL. Mahesh Desai, Micro PCNL. Sven Lame and Udo Nagele, Mini PCNL, 25 years ago. And Manoj Monga, Midi PCNL, in the early 2000s. What's new in PCNL? The new thing, the thing that if you don't have this, it's very difficult to say you're a tertiary center, you're expertise in PCNL, is the big difference between having to put two probes together to get ballistic and ultrasound, or just having a single device which actually gets the trifecta, ballistic, ultrasound, and suction through a single probe. For the moment, there are only 2 devices on the market, and you young guys, you were very lucky today. To me, and I've been to a few congresses and meetings and courses, too many, it's the first time when I saw in a live case someone using both these devices in the same time. So it's perfect. Thank you very much, Dan. Exactly. Now, what is the new? The new is not so new, actually, because we've been trying to do some robotic ureteroscopy for many years. And for various reasons, it didn't get too much traction. But the first robot was a modified thing in 2008, and you can see what happened afterwards. I do have in my department the Avicenna robot. I do use it, so I do robotic ureteroscopies. But these robots were not convincing. They were more or less robotic arms, robotic consoles, like this one, the Avicenna, where you fix the scope and then the robotic arm manipulates the scope, whatever scope you have, in, out, rotates, and so on, to perform the procedure. But for any of us, I wouldn't say expert, but with enough experience, urologist, you're faster than the robot. So if you're faster than the robot, then what's the benefit? Okay, yeah, you can say it's more stable. You don't get X-ray exposure. Your ergonomics of the surgeon is perfect. You don't stay like this. Did you see what they made me do? So I had no ergonomics whatsoever. We need to talk then. So I was doing this, and the screen was there. I had to look at the, come on, if I do 6 or 7 in a row, I'm going to die. So you have to think of all the things, where do you want the screen and so on. So the ergonomics is obviously a very big advantage, but otherwise not too much. However, things are changing, and they will change, and robotics in ureteroscopy will be the next new thing, because, and yeah, Ely robot is the only one out of these robots that doesn't have a separate sitting console, but just like an Xbox console where you can just play on it. And this is how, more or less, how you manipulate. You see in these videos how you manipulate the robots from different consoles. However, things are changing already, because with AI, these robots can measure automatically if the stone will pass through the sheath. Okay, so the Korean one does it already. They also can remember how did you get in. So instead of you having to go on the same route, the robot will do it automatically. So they have the memory of the path, and they advance in there. Still not impressive, probably. But though it is, because look, at some point, he's doing this, and the robot gets, again, back into the calyx where they were initially and where the stone was. And then he takes over. You saw that. This is important now, because this robot starts to do something that is going to break the barrier. Actually, it moves with respiratory movements. Okay, but for the moment, it's still something that is not tracing the stone, but moving to keep the target more or less closer. But it's already available. Now, those robots, as you saw, they were robotic arms, you put the scope in. But look, in bronchoscopy, they have these things where the whole thing is integrated. So the scope is a part of the robot, and you manipulate it. And the grades of freedom are all the way around. So multiple grades of freedom. You see how you can manipulate it. Obviously, they've been modified now, and they are working on developing the same machines for ureteroscopy. This is the work of Professor Landman from UCI, University of California, Irvine, where Ralph Kleiman is, but Prof. Kleiman is now the boss there. And they did this robotic combined percutaneous and ureteroscopic access. The concept is a bit different. It's not a robotic ureteroscopy. As you can see, they introduced through the calyx a sheath to suction what resulted from ureteroscopy, and it was controlled robotically. Obviously, AI is everywhere. We will use it more and more. We are using it more and more. We are using it for automatic stone detection and volume measurement, as we discussed. We use it for planning treatment. There are softwares now that you can easily access. We are using it for predicting stone composition via machine learning models. We are using it for predicting the outcomes of surgery. This is a very nice AI calculator for predicting spontaneous stone passage, developed by the British Association of Young Academic Urologists. It's quite nice, you can have it. So basically we are heading towards the era of the PSA, what Prof. Pale Oster has been thinking about for many years, meaning PSA, personalized stone approach. With all the data that we have, we as surgeons, we can't process all this data immediately and come with a personalized approach, but the new AI help will actually do this for us and will come with a specialized guidance for every patient, taking all these things into consideration. And this is now reality, not future anymore. Now, my very good friend, Prof. Ceva Tefik from Istanbul, we are working together on a few projects, has developed this model where we can accurately and automatically segment stones during endoscopic surgery, and that is very good. So basically, you can trace the stone with AI. Again, a very good friend, Ben Turney, professor at Oxford, helped with this turbidity classification. So basically, turbidity means how can you see or you can't actually see the stone. Why is it helpful? Because if you can't see it, you can't laser nicely. And if you can't laser nicely, you need to change that. How do you change it? By putting this directly in control with the pressure monitoring and with the lasers, and the laser will not shoot until the turbidity is good enough so you can laser, and that is going to work in conjunction with the pressure monitoring system, because you can't just increase the flow without taking care of the intrarenal pressure. It is a lot of work. I think this is the last slide, and this is where we are heading. And if you look, we already have all these things. We are just waiting for integration. We have pressure control. Yeah, we have lasers able to do things differently. We have pressure sensors, we have pressure monitoring and pressure control devices. We have robots, and we will have the AI to put all these things together, and that's going to change the way that we treat stones. But what is really going to change things from the robotic perspective is the moment when the robot will be able to track the stone continuously, laser only on the stone, and it already exists, but track the stone continuously irrespective of the movement of the kidney, and keep the same distance from the tip of the fiber to the stone and laser only at that moment. This is something that no human can do, not even Olivier Traxel. So, and that is the breakthrough when no one will be able to say, oh, but I'm better than a robot. And this is coming. I'm working on something like that with a team from Germany, but there are other teams working. We can already track them. It's not as easy because it's a 3D thing that you need to track with a 2D camera. It's not as easy, but the results are already promising. So probably 10 years from now, the robotic ureteroscopy will be this thing, and no one on this planet, as a surgeon, will be able to say, oh, but I'm better. No, you're not. And you can't be. And this is when robotic will take over in endourology. So I think I'm going to stop here. I did talk a lot, but I probably told you 1% of what I wanted to tell you. Thank you very much to all of you being here until, I think it's almost 5:30. I hope you enjoyed what we did for you today. We had amazing faculty. Thank you very much, Alberto, for taking so much of your time. Leia had to leave as well. Please, lots of applause for the local guys, for Dan and his team. And everyone else. You know, this is, for us, we don't have a real benefit. The only benefit is that we hope that you guys are going to do much better than we did. And we want you to understand how much passion and work is behind all these things, and to kind of transmit this to you, and we want us to be able to trust you when we are old, so you can be our doctors. Thank you very much, guys.
Thank you. Thank you, Alberto. Thank you, Bogdan. Thank you, Laurian, for being here and for sustaining our workshop. And we are expecting you as soon as possible for other great workshop. Alberto, do you want to come with me? Yeah. With your work? Perfect. If you have time and you are not very tired, to show you our setting.